somewhere beyond traditional thinking, beyond standard treatments, is a place that bridges where we've been to where we're driven to be. It's where innovation that saves and sustains lives meets the providers who make it happen. Where our ability to manage illness expands to reach patients with limited options. Where we address complications before they become life-threatening. Where we're not only treating diseases, but also discovering smarter ways to prevent them. This is our place, where we come together to write our greatest chapter as a visionary company operating at the center of global healthcare. This is the intersection of our boldest possibilities. This is the new Baxter.
Good morning. Sawubona, Dumelang, Molo, Shalom, Abshweni, and a very warm welcome to everybody. It is my great pleasure and honor to welcome you to the South African Burn Society Congress this morning. And we are very, very pleased and excited to be able to host on this platform. We are very honored to have in our company past presidents from across the globe. We would like to welcome Dr. Ahuja, past president of ISBI, Professor Adeline Muganza, past president of the South African Burn Society, Professor Moeng from the past president or current president of the Trauma Society of South Africa, Dr. Richard Nabuko, past president of the Pan-African Burn Society, Professor Huisen, past president from the Trauma Society, and Sister Phoebe Brewer, the current president of the Wound Healing Association of South Africa. We would also like to take a moment to remember Liz Greenfield after she has passed away, and we would like to honor her and then remember her contribution to the world of burns, ISBI, and the South African Burn Society. We would also like to welcome our sponsors and thank them for their encouragement and their support. Without them, this would not have been possible. We would like to welcome all our esteemed guests from across the globe. We really value and appreciate your contribution. This is the first time in the history of the South African Burn Society that we are able to host such a large international contingency on this platform, or bringing them to the South African context. We would also like to welcome all the delegates, and we would like to thank you for your time. And then we trust that this would be a very informative conference for you. When we look at the theme of today's conference, we have then aligned ourselves with the word global. And global means a reflection of things locally, but looking at what is happening as well internationally. And historically, we used to host a handful of scholars in our South African Burn Society. But this time around, because of COVID, where the life as we have changed and the world as we know it has changed so incredibly much, that we then had to change our thinking. So instead of shying away from it, we have adapted as evolution encourages us to do, and we have brought to you scholars from across the globe, the most knowledgeable, the most respected, most esteemed speakers, so that we can share it locally. So what we are wanting to do is look at what the best standards are globally, and then also apply it locally. So therefore, we are trying to go local with our knowledge, and then also with this platform here this morning. So in 2012, Dr. David Mackey introduced at ISBI the concept or the paradigm of one world, one standard of care. And that means that doesn't matter where in the world you are, you should be able to receive the best burn care that is available. And we have then aligned our conference and our values with this thinking so that globally we can learn from each other. So it's about reflecting locally what we are doing, reflecting globally what is being done, and then combining the two so that we can then share and learn from this platform. And our theme for this morning then is local is the gold standard. So you will be learning a lot from our host of international speakers and also the most esteemed South African speakers. And we trust that this will be a very informative and a very knowledgeable conference for you. And thank you so much for joining us. I would now like to introduce you and hand over to our MC for the day, Dr. Ridwan Suleiman.
Good morning. Thank you, Dr. Ethel Andrews, and a warm welcome to all of the attendees of the South African Burn Society Congress 2021. It really is a pleasure and a privilege to be the MC for this event, and I look forward to all of the presentations and the interactions over the next 2 days. As Dr. Andrews has indicated, the Congress is being held entirely virtually this year. COVID indeed has disrupted every aspect of our lives and the way we do things. Fortunately, the South African Burn Society has adapted and is presenting this Congress in a virtual setting with attendees from all over South Africa as well as all over the world. I encourage all attendees to please interact, please share comments within the chat boxes and try and interact as much as possible. I also encourage you to attend the virtual booths, the sponsored trade partner booths, which you can link from the main page. Sadly, thousands of South Africans fall victim to severe burns every year. Only a small number of these victims receive the correct medical care simply because there just aren't enough medical professionals with the right expertise to treat burns. This is why a congress like this is so important, not only to celebrate you, the healthcare professionals who are able to provide that treatment and that service, to recognize that excellence, but also that excellence should be and does influence standard practice within the field, both globally and locally. And we need to amplify that excellence. And I look forward to the presentations from all the healthcare providers within this industry over the next 2 days. We do have an excellent lineup of speakers, and I certainly look forward to hearing from all, as I'm sure all of the attendees do too. So I am joining you from Pretoria within South Africa. I encourage all of you to also share where you are joining us from. Please share your location, and we will be looking at where all of the attendees are joining us from in a minute. So please do share. We'd really like to see where all of the participants are on this Friday morning. I see that we've got already a few attendees locally within Cape Town and Johannesburg, but we've also got people joining us from Lagos in Nigeria, welcome, as well as London. Someone else from Pretoria, where I am also located, a warm welcome to you as well. Anyone else who is currently present, please do share your location. It really is quite nice to know where everyone is on this morning and where you are joining us. As mentioned, the interaction is so important, and I encourage you to share your comments and firstly your location within the chat box on the live stream. I see a few more locations locally, including more in Johannesburg, in Pietermaritzburg, Witbank as well. A warm welcome to all of you. We'll just give it a few seconds and see where other members or attendees are joining from. As indicated, I think it's crucially important to recognize all of the medical professionals within the field. There only are a small number who possess the right expertise to treat burns. And we have fantastic professionals, including doctors, nurses, physiotherapists, occupational therapists, dietitians, psychologists, who are all part of this industry. And it will be great to hear how the management of patients with burn injuries is being managed locally as well as globally. And fortunately, thanks to the work that all of you do and the correct medical care of the burns victims, these victims can carry on living their lives, be part of society, and continue to chase their dreams. We will be starting with our lineup with our speakers shortly at 8:15. I encourage you to continue sharing your locations in the meantime. And once again, a warm welcome to all of you who are joining us for the South African Burn Congress, South African Burn Society Congress 2021. So our first speaker this morning is Sister Sarita Jacobs, a Grit. Sarita Jacobs received her bachelor's degree in nursing science in 2006 and a bachelor's degree in critical care in 2019 from the University of Pretoria. She has performed various managerial roles over the past 13 years with specific focus on burn victim patients. She was part of the team that developed and established the first specialized burns unit in Life Healthcare. In April 2021, she became part of Legacy Emergency Medical Services, where she started a nursing division that performs home visits. Furthermore, she contributed to establishing best operating practices in the management of severe burns in Legacy Emergency Medical Services. It's a great pleasure to welcome and to have you, Sarita. Sarita will be speaking on the topic improving emergency management of service burns in the pre-hospital setting. Thank you and welcome.
Thank you very much, Doctor.
Good morning, ladies and gentlemen. Thank you very much for the opportunity to come and share our best practices with you today. My name is Sarita, trained registered nurse with a passion for burns. In 2017, I was part of the team that developed and established the first burns unit in Life Healthcare situated in Baxter, Mpumalanga. Part of our project was to improve the management of burns in general in Mpumalanga, and we hosted several training days for emergency medical services, for doctors, for other emergency departments. From there, a dream developed for Legacy EMS to become a dedicated burn care ambulance. I joined Legacy in April of 2021. I quickly realized that in the hospital setting, it is easy to maintain the ISPI guidelines for burn care, but in practice, in the field, it is a whole different story. I realized that EMS is faced with a lot of challenges. In the ideal world, you would like to achieve the goals set out in the ISPI guidelines, but in practice, it is not as easy. Today, I would like to share the journey of how Legacy EMS strives for different ways to achieve the goal and what we have implemented at the end to ensure best practices. Let us first look at the practice guidelines at present. The focus is airway breathing, circulation, disability and deformity, and exposure and extent. I would like to focus on improving circulation in the pre-hospital setting. I would like to refer you to the ICI Practice Guidelines for Burn Care of May 2016, which is the gold standard for burn care at the moment. The HPCSA Clinical Practice Guidelines for all registered emergency care providers that was published in July 2018 are also referring to the ISBI practice guidelines. During this presentation, I will focus on 3 areas where we can improve in the pre-hospital setting. The first is the cooling down and the covering of the wound. The second one is maintaining adequate ambient temperature and preventing heat loss to prevent hypothermia. And the last one is to ensure adequate perfusion with our fluid reserve. The ISBI guidelines for cooling the wound down is to use running water for 20 minutes if it's a flame or a fluid burn, and up to 1 hour if it's a chemical burn. The wounds are then to be covered with a clear cling wrap. The challenge in the field is that people have been so used to using the hydrogel dressings because they are easy to use but available on the ambulances, and it limits the time that they're on the scene. The other aspect is that you don't always have water available. Sometimes you might have water available, but it's not necessarily accessible. Example, a patient got burned while his house burned down. There are taps on the outside, but the hose melted in the process. So how do we transfer the water from the tap to the patient? If it's a small burn, like a hand or a foot, it's easy to put that underneath the tap with the running water. But if we talk about a 55%, how do you get that water to cool the patient down? The other challenge is if it's in a remote location, example like house fire. The fire might be very far away from a home. There might be firefighter trailers for extinguishing the fire, but they might be filled with sunlight soap or with foam. It won't be necessary clean water. If you don't have anything else, then it's good, then at least it's something cold, but it's not the ideal. Cling wrap is also not always available on the ambulances. So given all these challenges, we had to test different ways to make sure that we can achieve the guidelines of the ISBI practice guidelines. So the first thing that we have implemented was that the dispatcher or the control room is responsible to initiate the cooling down of the wound. So once the ambulance has been dispatched, they phone back and they instruct the first responders on cooling the wound down by any means possible. Your ambulance will take around about 5 to 15 minutes to 1 hour if it's a remote location. So you win that 10 to 15 minutes already with cooling the wound down. So by the time the ambulance arrives on the scene, you already have 5 or 10 or 15 minutes of cooling down that wound. One of the things that we have tried was to use abdominal swabs with saline, but we very quickly realized that if it's a major burn, that you need a lot of abdominal swabs with saline. The problem was also that it stays wet. The patient remains wet, so it's not just cooling down, but the patient remains wet, which has a risk for hypothermia again. So the next thing that we tested was to use foldable cam showers. So if you take a 20 liter, you can fill it from any tap around the patient, and you can then take it as a shower head. You can use to rinse the patient down. You can clean the wounds while you're rinsing the patient down. So then you can also do a proper assessment. This was very effective. It folds up very easy. It's tiny, it can fit in your ambulance, and it's a way that you can transfer the water to the patient. Only challenge we had with that was that somebody had to hold the container, or you must have somewhere a hook where you can hook it onto. But the foldable cam shower were very good. Then the cling wrap, our suggestion is not to buy the bulk huge cling wraps because they are very difficult to maneuver. So if you think, oh, we buy bulk and it's easy, but rather buy the smaller 50-meter cling wrap. So smaller, you use it for your patient, and then afterwards you can discard it. So once we put the patient down with the shower, we cover them with a cling wrap, and then next we place them in a body bag. The body bag that we bought is the ones with handles on. So this helps to prevent heat loss from your patient. It helps you with the movement of your patient to the stretcher at the hospital bed, because you don't need to touch the skin of the patient that's already burned, especially with your larger burns. So you can move your patient very easily, and of course you will keep the face open. The last thing that we realize is that hydrogel dressings do have a place. If you really don't have a way to cool the wounds down, you can use your hydrogel dressing, but it must not stay longer than 20 minutes. Hydrogel dressing is not a covering, it's a cooling down. So you can cool down the wound 20 minutes, take it off, and then you still cover it with clean wrap, the wounds with clean wrap. So what is very important is that you need to do all of this before putting the patient on the stretcher. So you shower them down, you put the cling wrap on, and then you put them in a body bag and then on the stretcher. The prevention of hypothermia is extremely important. It dictates the outcome of the patient in the hospital at the end. The challenges are that hydrogel dressings are still used as a covering and left on the wounds for more than 20 minutes. Sometimes the hydrogel dressings are applied on seam and then only removed once the patient is at the hospital, which can be anything from 15 minutes to an hour. Furthermore, fluid resuscitations are done with cold IV fluids. To warm up a vaculator in the ambulance is extremely difficult. And then you also have the cold ambient temperatures of the ambulance. So we really had to think out of the box to see how are we going to improve this prevention of hypothermia. So in the process, we did explode a few vacuolators. We did set a light blanket. So the first thing that we tried was to place the vacuolator at the vehicle engine once we stop on the scene. The engine is nice and warm, so we thought maybe if we put it there at the engine, it can warm up quickly. But by the time your IV is established, your vacuolator is not warm yet. The next thing that we tried was to place the vacuolator in the microwave. It did warm up, but it also did explode. The problem is at any given time when you remove the vacuolator from the microwave, you do not know what the temperature is of the vacuolator. We also did try placing a blanket in the microwave to warm up the blanket. It did end up in flames. And then we tried electrical blankets as well. The electrical blankets work nice. The problem is that the risk involved with the patient, because your burn patients do have a lot of serous fluid. So your risk involved is too great to use the electrical blanket. You do have IV fluid warmers that you can use on the road. The problem with them are that usually you can only administer at a slow rate. So if you administer burn resuscitation fluid where you need a lot of, or maybe large amount of fluid, it does not warm up your fluid in time. So what we finally managed to do, we bought a 12-volt food warmer. It can contain a 1 liter vacuolator at a time. So once dispatched for a call, you switch on your food warmer, and it can take up to 45 minutes to warm up the 1 liter to 38 degrees. So usually by the time you start administering your IV fluid, your fluid is at least warmer than normal. We also place the patients in the body bag, which helps a lot with the prevention of heat loss. And then we set the ambulance temperature to 30 degrees when we dispatch for the call. So the crew struggles with this because they also have to wear PPE for reverse isolation that we have implemented in our ambulance. So they wear gowns and masks and caps and shoes in order to prevent infection for the patient. So the 30 degrees we usually start off so that when we get out of the ambulance, the doors are open, you do lose a lot of your temperature. So once the patient is stabilized inside the ambulance, we do go down to 26 degrees, which is the guidelines, and then we can maintain at 26 degrees. So ultimately, this is very difficult for the crew, but it is the best for the patient. In order to ensure adequate perfusion, the aim is to achieve a systolic blood pressure of at least 19 millimeters of mercury. With burn wounds, it's important to remember that the problem is usually with your preload. Be very careful before initiating inotropes. First, make sure that you've got the correct amount of fluid resuscitation before commencing up. Inotropes. If you use adrenaline example, it will stimulate alpha receptors that will increase your afterload by causing vasoconstriction in the periphery. It will cause increased contractility by stimulating beta-1 receptors in the heart, but it won't increase the preload, it won't affect the preload. So please remember to make sure that your estimation of your burn injury and your Falklands formula was calculated correctly before initiating an inotrope. What I realized was that we don't have easy access to paperwork, and it's not easy in the pre-hospital setting to quickly estimate the burn and work out the formula. So we have downloaded an app from the Play Store, the Burn Fluid Calculator app. This application uses the London Radar chart to work out your TBSI by just selecting the area of the body affected, and then it gives you a total body surface affected. And then you add the patient's weight and the TBSI, and then it works out your Falklands formula for you, which will give you the guideline on how much fluid you need to administer. We also have good relationship with our burn unit in the hospital and with the burn specialist, and we do send them pictures if we're not sure. What is also very important to remember is that you don't calculate this if the skin is still intact. The skin might be red, so your superficial burns. If the skin is still intact, you do not calculate that as part of your TBSI. Only the areas where the skin will come off, where it's already off, or where there's complete skin breakdown, or you see that it will break down. We recently purchased a Cinova MTX device, the Matrix Multiple Bioparameters Monitoring. It is similar to a pulse ox. It's a handheld device, but what is amazing about this device is that it can give you a map and a cardiac output, a stroke volume. It can give you a pH as well as a partial pressure of oxygen and a partial pressure of the carbon dioxide of the patient. This device is very useful in management and decision making for your patient in the burn care setting as well. Thank you very much. Are there any questions?
Thank you so much, Sister Curator Jacobs, for that very informative presentation on the treatment of burns patients. I don't see any questions as yet. I do encourage all attendees to share any questions that they do have in the chat box. If in the interest of time, I think we'll continue to the next presentation, but if you are still available, Sarita, and if there are questions in the chat box, I encourage you to also respond and interact over there. Thank you so much once again for the lovely presentation. Our next speakers are Dr. Nirav Patel and Ms. Tiffany Fairbairn, their topic of their talk is community burns prevention in Johannesburg, South Africa. Dr. Nirav Patel is a consultant pediatric surgeon at Chris Hani Baragwanath Academic Hospital and lecturer at the University of Witwatersrand. Nirav serves on the board of Surgeons for Little Lives and was the past president of the South African Society for Surgeons in Training. A proud Witsi, Nirav has a strong interest in academic medicine with multiple peer-reviewed publications and in local and international journals. Welcome, Nirav. Nirav's co-presenter is Ms. Tiffany Fairbairn. Tiffany is a production-level pediatric occupational therapist, also working at Chris Hani Baragwanath Academic Hospital. She graduated from the University of Western Cape and completed her community service year at BERA in 2015. Her interests are in pediatric burns and child psychiatry, and she has been the occupational therapist in both units at BERA since 2015. She is a member of the task team developing the Gauteng Burns Protocol for clinical support and therapeutic services, and is currently doing her master's in child psychiatry, including the impact of traumatic experiences in child development. Welcome to both of you.
For this opportunity. My name is Nirav Patel. I'm a pediatric surgeon here at Chris Hani Baragwanath Academic Hospital. And today myself and Tiffany Fairbairn, one of the pediatric occupational therapists, will be talking about our efforts to address the problem of pediatric burns in our environment. So how big is the problem? Data from our pediatric burns unit at BARA tells us that in a 10-year period between 2009 and 2019, average annual admissions have increased by about 45%. So we went from about 343 average annual admissions per year in 2009 to around 588 in 2019. But these numbers don't reflect the true magnitude of the increase in pediatric burns in our environment. In 2019, we did an audit and found that nearly half of all trauma patients that we managed were children that had been burnt in the community. If we add the number of children that we treated as outpatients from casualty that presented to our hospital alone, not the local clinics within our catchment area, the number of children treated for burns in 2019 alone is over 960. Pediatric burns cause a massive diversion in resources away from non-preventable pediatric surgical conditions. So again, according to the same audit that we published last year, nearly 20% of all surgical procedures that we performed between 2019 and 2020 as a department were for the management of burns. In a 2011 paper published by Nikki Lotto and her team in Pietermaritzburg, they found that for every percentage of body surface area for burns admitted at their unit that were managed conservatively, the cost was approximately 8,000 rands. For those burns that were managed surgically, the cost was approximately 5,000 rands. So you can imagine, with the huge number of admissions and the high level of burns that we accept in our unit as one of the only pediatric burns referral centers in the country, what kind of resources are being spent on the management of these preventable conditions. National and international data tell us almost the same thing. They tell us that South Africa is not different from the rest of the world and that the majority of burns will occur in the home during all seasons. They'll affect children under 5 more than any other population age group, and that the majority of burns are due to hot water. Local data at Paraguanath reflects this trend, so we know that the majority of our children that are admitted are burnt at home in the presence of a caregiver. That 75% of the children that we admit are burnt with hot water, and that 67% of them are under the age of 5. We also know from our data that nearly 40% of the children that we admit receive no first aid. And out of the remaining 60%, 25% receive incorrect first aid. And we all know that in the management of a burn, appropriate first aid is critical to managing the severity of a burn. So this is a picture of a local South African township. And when you think about this, you may wonder, or we may wonder, how we as hospital-based clinicians can have any kind of impact on the problems that we are facing. But when you look at factors that contribute to burns and break them down, you see that there are opportunities for us to intervene. And we identified education of individuals, families, and the community as one of the areas where we may intervene and hopefully try and mitigate the scourge of pediatric burns. At present, there's a paucity of governmental and non-governmental organizations dealing specifically with burns prevention. Those organizations that do exist focus primarily on the treatment and rehabilitation of patients who have been burned, or on the education of medical professionals in the management of burns. In Gauteng province, there is a school-based program aimed at educating children about burns, but as we know from our data, the majority of children that are being burnt are under the age of 5 and in the care of a caregiver. So we feel the existing programs actually miss the target audience. So basically there's a gap, and this gap is an opportunity for us to intervene.
Okay, good morning, everybody. So the information is a lot to take in, but the good news is that something can always be done, and there's always an opportunity for some form of intervention. And for this reason, Nirav and I decided to formulate a comprehensive intervention using the 5WH approach. We considered the following in our planning: why burns, what can be done realistically to affect change, where can we implement change, who can assist us, and when should the plan be implemented. So the stats speak for themselves about why burns. Burn injuries are a growing problem that is vastly impactful, but it is also something that is very preventable. Because burn injuries are so preventable, the overt opportunity was to establish a burns awareness program with a large focus on prevention. To tackle the problem at the root, we realized we needed to make people aware of the prevalence and seriousness of burns. We needed to promote prevention strategies, and we also needed to create awareness of what to do should a burn occur, as all accidents cannot be prevented. And Nirav will now elaborate a little bit more on the program that we've developed.
So our burns awareness program is based on 3 core pillars. These core pillars are general awareness, risk reduction, and action. Within each pillar, we've instilled a few very simple messages that we hope will empower individuals and families and communities by educating them and equipping them to decrease the risk of an accident or an unnecessary burn occurring within their environments. In general awareness, our aim is to educate caregivers predominantly that children under 5 are at greatest risk, that most burns in children will occur at home in the presence of a caregiver while bathing, cooking, or being held by an adult, that most burns are caused by hot water, and that burns are absolutely preventable. Under risk reduction, we hope to equip parents to prevent burns by teaching them that they can create a child-safe zone within their homes, regardless of the size of their dwellings, that all hazardous and other cooking equipment can be kept correctly stored away from the reach of children, that all parents should test bath water before putting their children in their baths, that no caregivers should hold children while doing any other task, and because of the crowded living conditions in which we live, to ensure that all of the people or all of the adults residing within a dwelling are aware of the rules of the home. Finally, in case a burn does occur, we hope to educate parents to, or caregivers to, not to do anything that can make the burn worse, such as covering it with margarine, oil, pup, or toothpaste, to immediately institute the appropriate first aid by rinsing the burnt area under tap water for 20 minutes, and if a tap is not available, then to use a bucket and a jug, and to seek early medical attention.
So when Rob and I were deciding where this program should be implemented, we quickly realized that it was not enough to aim our program only at the population at Barra. If we wanted to affect change, we needed to start at the source of the problem. And if we compare the situation to a river, at a hospital level, we are merely downstream, dealing with the debris as we receive it. However, if we want to minimize the debris, we would need to go upstream to the source. And for us, that meant that we needed to reach beyond the borders of the hospital, into the communities, and even further, straight into the homes of our children, where caregivers could be empowered to affect change within their own homes. Nirav and I realized even quicker that this program was not a two-man job. It was not for us to reach into the communities, but to rather join hands with those who make up the community to create a network of human resources. We approach community healthcare workers, health promoters, and through them, caregivers, to create a body of passionate people committed to implementing the program within the various communities. We imparted knowledge and skill through workshops where those involved could adopt the program and relay the simple messages throughout the community. In order to get buy-in and ensure that the essence of the messages was clearly understood and absorbed, we took care in creating a simple message that has been translated into local languages and that has been made more accessible by using multimedia platforms such as printed pamphlets, animated videos, and print media. Examples of the pamphlets have been shown in previous slides, and video messaging can be viewed on the Surgeons for Little Lives website. We also made a point of making sure that this message, these simple messages, would be repeated in various contexts so that the message could be grasped more easily by caregivers and by community members. Burn injuries have been noted to be more prevalent in winter. However, they still occur throughout the year. And because of this, we thought that it was very important that the program will be implemented throughout the year as well.
So our implementation phase has two arms, essentially the in-hospital arm and the out-of-hospital arm. In hospital, we have in the past few months implemented multiple daily health promotion sessions at the Pediatric Surgical Outpatients Department at Chris Hani Barra. And in the next few months, we're hoping to extend this to the Pediatric Outpatients Department. These are both venues where we have a captive audience in parents and caregivers who are waiting with their children to be seen for whatever problem they are presenting with on the day. More generally, and in order to widen our access to the community, we have developed multiple partnerships with various community-based non-profit organizations, with the Gauteng Community Occupational Therapy and Allied Health teams, and with the Gauteng Department of Health ward-based outreach teams, in order to take this message into people's homes with the hope of educating them in their local language in a simple way, repetitively, using a variety of media, with the hopes that all of this will, number one, inform them, and then equip them with the appropriate information that they need to be able to change their behavior and decrease their children's chances of being burned. To date, we have implemented program at South Rand Hospital, Kalafong Hospital, at Lenasia Community Clinic, at Chris Hani Baragwanath Academic Hospital, and at a few clinics in Soweto and the Vaal region. In addition, our program has now been adopted as part of the Allied Provincial Burns Protocol. We also try to access the community using other forms of media, including our social media platforms, as well as various forms of print and digital media, and through appearances on local radio stations. In the future, we hope to create a data collection tool that will allow us to surveil the impact of our interventions, as well as to perform a study to better understand the mechanisms of injury within our particular community.
We would really like to thank everyone for listening to our presentation, and we hope that we have inspired you to become actively involved in initiating change in a problem that is really so preventable. Plans only take flight into action when we persist, engage, and partner with one another. And we have been very lucky to have been partnering with so many members in the community. We appreciate all the input and contributions so far, and we also welcome any input from those who are keen to get involved. So thank you very much.
Thanks very much.
Thank you so much, Dr. Patel and Ms. Fairburn, for a very informative presentation on the burns awareness program. Prevention is certainly better than cure. I'm just looking to see if there are any questions from members of the audience at this stage. I don't see any questions come through just yet. And once again, I encourage you to please share your questions in the chat box on the auditorium for the speakers. Well done, and thank you for a very informative and initiative and a wonderful presentation. Our next speaker is Dr. Marlie Janse van Rensburg. Dr. Marlie Janse van Rensburg is currently a senior registrar specializing in emergency medicine at the University of Witwatersrand. She graduated from the University of Pretoria with a bachelor's in medicine and a diploma in primary emergency care. She started a pre-hospital career as a volunteer 15 years ago after qualifying as a basic ambulance assistant at the age of 18. Today, she is a renowned and respected doctor in the Netcare 911 Road Ops Division and is part of the Netcare Critical Care and ECMO Retrieval Team and one of 2 doctors who fly for Netcare 911's helicopter emergency medical services on a regular basis. Welcome, Dr. Marlie Janse van Rensburg, and the talk of her topic is the management of burns in the pre-hospital setting.
Hello, everybody, and thank you for that very good introduction. So this is what I call my natural environment. And basically, when I'm not in the ED, I'm probably working in a response vehicle, sitting in the back of a helicopter, doing what I love most. When I was initially asked to present this topic, my first reaction was to talk about the clinical aspects of burn care in the pre-hospital setting. And I will touch a little on that, but I really want to focus on the specific challenges we face when treating burns in our setting. So in South Africa, like all other low to middle income countries in the world, we have a high burden of injury from burns with a limited number of burn centers available. So EMS has an important role when it comes to managing these patients because we can make a huge difference if we apply the right interventions early, especially in rural areas where delayed presentations to healthcare is common. But we also have the responsibility of making wise transport decisions, and we need to be able to decide which patients will benefit the most from specialist care. In a recent review article where the authors reviewed 17 papers from 5 countries on pre-hospital care of burns in Africa, they found that appropriate first aid was only administered in about 0.5% of cases, and this mostly occurred in South Africa. They also found that pain management was hardly addressed, and that treatment delays were common. So in South Africa, we have a private and provincial EMS service, and our EMS system is well developed compared to the rest of the continent. But our EMS resources are unequally distributed, and therefore we have areas where services are well resourced and developed, and others where these resources are very scanty. Over the last 30 years, we have evolved and moved away from the previous short course training system to a higher education framework that is aimed at elevating the standard of care we provide to our patients and also extending the capabilities of EMS practitioners. So simply speaking, EMS providers work on one of three scopes: basic, intermediate, or advanced. But because we are in a transition period, there's some heterogeneity in the qualifications that fall under the intermediate and advanced scopes. A recent revision of practitioner capabilities and the introduction of clinical practice guidelines by the HPCSA in 2018 has also brought major changes to extend the capabilities of EMS staff who previously trained in the short course system. But despite these changes, advanced life support paramedics are still a very scarce resource, especially in rural areas where there may only be basic or intermediate life support providers. Now, one might think otherwise, but burns actually make out a very small part of the trauma cases that we deal with, and an even smaller part of the overall EMS caseload. A recent retrospective review of burns cases treated by the Western Cape Provincial EMS confirmed this. They found that on average, the Western Cape EMS respond to 3.2 burns cases per day, and this amounts to 2.9% of the trauma burden and only 0.6% of the overall caseload for that service annually. Just over half the cases occurred in rural areas, and over 80% of cases were transported to medical facilities, most of which meet criteria for burn center referral. So when we do respond to these incidents, usually there's one of three scenarios. Either it's a huge fire, but there's no injuries on scene, or the individual has been burned and we get activated for that. And lastly, it can be a major incident with multiple patients that need to be triaged and treated systematically. The thing that makes working in the pre-hospital environment so challenging is that there are so many unpredictable external factors that play a role in pre-hospital providers' decision-making process. Things like weather conditions, hazards on scene, terrain, accessibility of the patient, and ambient lighting, as well as the availability of resource, all need to be taken into account when making decisions regarding treatment. So I've decided to share two cases that I've been involved in to demonstrate some of the challenges we may be faced with. A few years ago, I was part of a medical team on standby at the Swartkops Air Show, an event that attracts huge crowds each year. Despite the fact that there are thousands of people, the most you will normally do is hand out sunscreen, earplugs, and panados, and for the most part, you can enjoy the show. So on this day, it was around midday, and the air show was in full swing with a crowd of about 15,000 people when my phone rang. There was an explosion at one of the food stalls, and we needed to go and assess the situation. Both ambulances and the response vehicle stationed at the event were on scene within minutes. After a quick scene survey, we determined the scene was safe, so now we needed to find all the patients. We found 6 people, 3 of whom sustained burns to the face, the neck, chest, and upper limbs, and 3 with burns to their hands and arms. While arranging for additional resources, the next step we had to do was triage. So a triage in burns MCIs like this is difficult for a number of reasons. Firstly, because existing triage systems rely heavily on total body surface area and burn severity to determine the treatment and referral priorities. And although the need for triage is well recognized, triage tools like the triage sieve and sort is not specifically designed for MCIs with burns. What complicates matters even more is that patients frequently have other injuries in scenarios like this that we need to take into account when making these decisions. In theory, burn centers should be reserved for patients with more severe, complicated injuries. And a systems-based approach is therefore important here because even a small number of burns patients is enough to overwhelm a facility, and therefore patients who might normally qualify for treatment at a burns facility may need to be diverted to trauma centers or even non-specialist facilities. But how do we make that decision? The second thing that is quite challenging about managing burns or triaging burns is the fact that the patient needs to be fully exposed in order to assess total body surface area. Not so easy when you have a crowd of 15,000 people around you, or if you find yourself in a potentially hostile environment. Patients require close monitoring because they can deteriorate rapidly, and these resources are not always available. And lastly, burned wounds can also be very distracting, causing us to miss other injuries if we don't actively look for them, resulting in patients being incorrectly triaged. One of the triage tools that were developed for scenarios like this is the fast triage and burns algorithm. And this is a new triage method for pre-hospital use during burns mass casualty incidents. It provides a simple, quick, and reliable means of triaging burn patients and enables us to decide who will need burn center intervention. Accurate assessment of burn severity is quite tricky, and there are a number of reasons for this as well. When we initially got to these patients, for instance, their injuries were so fresh that it was really difficult to determine from the start the exact depth and size of the burns. Burn wounds develop over time, and if patients are seen immediately or very soon after an injury occurred, deeper burns can easily be mistaken for superficial burns as blisters have not developed yet. The wounds may also be covered in soot, concealing the burn, and lack of adequate ambient lighting will make it even more difficult to make an accurate assessment. So like previous speakers have mentioned, determining burn size is of the utmost importance. And the recommended method to do this is to use the London Browder chart. But in reality, this might not be practical in the EMS setting. So people revert back to methods like the rule of nines because it's easy to remember. And we know from the literature that large burns are often underestimated and small burns are overestimated. And this will lead to inaccurate fluid calculations, which may adversely affect patient outcomes. Mobile applications like the eBurn app offers innovative solutions to this problem and has been demonstrated to reduce the risk of human error, particularly from untrained, non-specialized clinicians, and may be a useful adjunct in the pre-hospital setting. We all know that the burning process should be stopped immediately, and the skin should be cooled with cool running water for 20 minutes, because this prevents a process called wound conversion and preserves the zone of stasis. It has also been shown to improve pain, promote healing, and decrease skin graft requirements, and is associated with better outcomes. We are often concerned, however, that we might induce hypothermia when we cool burns. But several studies have suggested otherwise. Pre-hospital cooling of burns do not induce hypothermia as long as it is not done in an uncontrolled fashion, and basic measurements are taken to warm the patient. Uncontrolled cooling with cool running water can act as an evaporative mechanism that may inadvertently assist in the onset of hypothermia, which is associated with increased mortality. Burns patients, like all trauma patients, are at risk of developing hypothermia, and this occurs particularly in patients with large burns, so those more than 20%, because their thermoregulatory mechanisms are impaired. So the risk factors that have been identified for developing hypothermia in EMS-treated burn patients include total body surface area of more than 20%, extremes of age, polytrauma, an initial GCS of less than 8, extrication, and then obviously also if the burns occur in winter months. And it can be prevented by simple measures like warming, wrapping the patient in a blanket or space blanket, and increasing the ambient temperature in the ambulance, and also infusing warm fluids. But this is not always available to us. In the context of this case, if you would want to provide first aid by cooling the burns with cool running water, you will require approximately 80 to 160 liters of water per patient. So clearly not a practical idea in cases like this. The use of hydrogel dressings like burn shield would therefore be the next best alternative method to cool burns. But burn shields can also run out, and then what do? So this is where the improvisation will come in. So you can cover the burn with cling film and then wet a sheet and use that as a dressing to cool the burn and then change it intermittently. The goal here is to cool the burn and to cover it with an appropriate dressing and get the patient to an appropriate facility. In the pre-hospital setting, we will always resus with balanced crystalloid, and we use the Parkland formula to calculate fluid requirements. International services sometimes use this fluid matrix that you see on the screen. But when you use a fluid matrix like this, it can lead, you can see that some patients will fall in the same category. Some of them will be under-resuscitated and others will be over-resuscitated. So it's better to use a formula combined with your endpoints of resuscitation. And although urine output monitoring is not always possible in the acute setting in the pre-hospital environment, we should always aim to sort of achieve this while we are treating our patients. So if you've done everything you needed to do, sorted out all the life-threatening injuries, put in a catheter and monitor urine output to guide your fluid resuscitation, because this will avoid over or under resuscitation. Beware of hypotensive patients with burns, especially when you encounter them in the pre-hospital environment, because when a patient is hypotensive and their injury just occurred, we should look for injuries other than burns that are causing their hypotension, because burn shock develops over time and it's really unlikely for them to be hypotensive early in the course of their injuries. In the case of burns mass casualty incidents, the WHO Technical Working Group on Burns recommend that oral fluids should be encouraged unless there's a delay in transfer of the patient to the nearest hospital. Because when you have to deal with multiple patients, fluid requirements may be easily miscalculated. I think one of the biggest challenges we had in EMS was providing good analgesia for patients. In burns patients, many practitioners still believe the old teaching that full thickness burns are not painful and therefore refrain from giving analgesia or they underdose their patients. It is clear, though, that full thickness burns are indeed painful and we need to provide good pain management for all our patients. Historically, though, BLS and ILS practitioners only had Internox on their scope, and this was never available. So with the recent introduction of the new CPGs, this changed, and all EMS providers are now able to administer methoxyflurane, otherwise known as Penthrox, which is a potent inhalational anesthetic agent that has been shown to provide excellent pain relief, even in small doses. The only downside to this in our setting is cost, and I don't know how this will influence the availability of the drug. In terms of the advanced life support scope, they have various medications available to them, including ketamine, fentanyl, and paracetamol, which allows them to adopt a multimodal analgesic approach that can be titrated to the needs of their patient. The last case is a call we recently attended in a rural area, about 80 kilometers from the nearest level 1 trauma facility, where we were told that a diesel tank exploded and injured 2 people. 1 person sustained severe injuries. When we arrived on scene, we found the patient lying in a pool of thick mud about 10 meters from where he was initially standing when the tank exploded. He had deep partial thickness to full thickness burns with a total body surface area of approximately 90%. He also had bilateral tip-fib fractures. We later found out that the patient was actually busy welding on one of these. You'll see the tank there on the picture. He was welding one of those tanks that were empty, and it exploded. So when he hit the ground, the bystanders hosed him down and managed to extinguish the flames, and that's where all the mud came from. Calls like this are extremely difficult, even for experienced providers. From a pragmatic point of view, I can tell you about all the nuances in this patient's care and how things like the fact that we found him in the mud made clinical management so much more challenging. And I can tell you how to address all the clinical scenarios in this case. But I think all of you know what this patient's ultimate outcome was. And we certainly did everything we could for him. We airlifted him to the best facility there is. But did any of this make any difference to him? I don't know. You see, we need to take a step back sometimes and think about the interventions that we are performing for the patient. We need to think what the interventions are that will make the biggest difference for the person in front of us, because we're not treating only injuries, we're treating people. And if this was me, there would only be two things that I would find really meaningful in the end. And this would be to be able to say goodbye to my loved ones and to die pain-free. So in conclusion, as EMS providers, we are in a unique position to provide early interventions to our patients that can make a significant contribution to a good outcome. But pre-hospital burn care is not always as straightforward as it seems. We know we can't save everyone, but we will damn well try, because this is what is important to us. But if we really want to make a difference, we need to think about what is important to our patients, because ultimately, this is all that really matters. Thank you.
Thank you so much, Dr. Janse van Rensburg. There aren't any questions from the audience, but there is a comment from Dr. Gary Dos Passos, and the comment reads, "Beware hydrogel dressings in small children. I have seen many arrive severely hypothermic due to over-enthusiastic application."
That is certainly a concern. Yeah.
Thank you so much. And I see some lovely interaction in the chat in the live stream, and I encourage you to continue the interactions. Thanks once again, Dr. Janse van Rensburg, for a lovely presentation, and I really enjoyed the passion that came through from the
Thank
talk.
you.
We're moving quite swiftly through the presentations. Our next speaker is Dr. William Mapham. Dr. William Mapham founded Vula Mobile to connect frontline health workers with specialists. His first-hand experience as the vice chair of the Rural Doctors Association and as a specialist ophthalmologist helped form the solution. He has published academic articles on the role of innovation and technology in improving healthcare delivery. Vula has been used in the field of burn care since 2016 and was voted Best Health Solution in South Africa by MTN in 2019. So Dr. Mapham will be speaking to us on Vula, using technology to improve care for burns patients. Thank you.
Thank you very much for the introduction, and thanks to the previous speakers. As mentioned, Vula connects frontline healthcare workers with specialists. I'm from the Eastern Cape in South Africa, which is a bit more rural than other provinces, or similar to some other provinces. And I went back to the Eastern Cape as soon as I qualified to improve the situation there. This was the road to my first job. It was an hour-and-a-half drive to get petrol, and we defined rural as the time it took to buy ice cream, which was only 3 hours. And so we went back there to try and make sure things got better. However, as junior doctors, you don't know everything. And I think the previous speaker spoke about like, what do you do in the first aid situation? This is a letter that I wrote myself for a patient in 2004. The patient had an eye condition. I didn't know what it was. It looked very serious. I said, please take this letter, go to Mthatha. It's only 3 hours away. It's our nearest eye clinic, and hopefully they can help you. The next time I saw the patient was 7 years later. I went back to volunteer as a specialist, and he came with the same letter that I'd written 7 years ago. And he was so excited to see a specialist. And when I looked at his eye, it was tragic because he had gone blind in that eye. And I realized then as a specialist, it was a simple condition, and we actually had the medication he needed the first time I had seen him. As you know, many patients travel huge distances to get to specialist care, and I'll speak a bit about that a bit later when I show you the data. However, what I realized when I was specializing was the problem wasn't just in the rural areas or the periphery. Here I'm specializing, I'm seeing patients, I'm teaching students, there's more patients waiting, and that phone in the corner just rings off the hook with people like me in the past trying to get advice. So we had to solve the problem for both sides, as well as for the people who want to collect data. So Vula Mobile is an app, but there's also a web portal. It's designed for use in our settings, so it uses 20 times less data than WhatsApp, and it's secure to use. And although we started in ophthalmology, it's now available in 53 different specialties. So if you do want to refer to other specialties rather than just burns, it's available. And basically, we built our own chat system, and I'm going to attempt to give you a demonstration now. But just to reiterate, there are now, I think, 116 types of healthcare worker using Vula, including EMS practitioners and community healthcare workers. So let's see if I can show you the live demo. Okay, you're going to see my phone now, so hopefully no one calls me. And so the Vula app is at the top right on this corner of the screen there. Basically, it looks like a messaging app. I'm currently as one of the lecturers, and so I'm teaching students, so these aren't clinical cases. And if I click on new referral, and I try to find my local burn specialist, let's see who's on call in Pietermaritzburg today. And it's Nikki Alotto, who you may be familiar with. So now I'm connected directly with the person who's on call right now. No more hanging on the phone as a rural healthcare worker. I know exactly who I should be speaking to. And I put the patient's information in, and there's all sorts of options here. For example, maybe the patient's caught burnt by flame, and you spoke about how to calculate the burns protocols and formulas. So here I can actually just color in whatever the case may be. If it's an adult, the patient's picture will automatically turn to an adult. And let me just show you a few things there. And then if you choose the patient's weight, or you estimate the patient's weight, when you press save, it'll tell you exactly what to do with the patient, even before you've spoken to the burn specialist. And the first speaker spoke about being able to add photographs, so as well as all these kind of simple things that you can tick box. You can also add photographs to the patient record and send that securely to the specialist on call. So if I press refer now, Nikki would get that information. So it's really nice and simple to use. And so yeah, it's free to use. And if anyone out there wants to start using it, it's available for you to do that. Let me just stop that one. Cool. So hopefully you'll see that the list of healthcare workers on the screen, and showing you the demonstration. Currently on Vula, there are almost 23,000 healthcare workers on the platform. It's growing very rapidly. So hopefully you join up. And almost 650,000 patients have benefited to date. And currently it's running about one patient every minute. So it's built to scale. The busiest user on Vula ever was in a COVID ward, and he managed 125 referrals in one day. Basically because it streamlined that referral process, and the specialists get the information they need straight away, rather than having to listen on a phone. There have been multiple papers published, happy to share them. And I think Nikki's going to be doing a study on the burns system in KZN soon. And just know we've also published papers on how to be secure, so that you can be guaranteed that when you use Vula, that all your information is secure. In terms of the impact, virtually all the papers showed that in 1 in 3 cases, the specialist can actually advise the peripheral healthcare worker what to do, and the patient doesn't need to wait for transport and travel all the way through to a referral hospital. The other 2/3, about another third, are emergency cases that do need to come through, and the remaining third are ones where the patient can be managed remotely in the first case, and will only be transferred to the specialist service for an appointment. We publish the response times to all the specialists, and on average, the response time is 15 minutes. So while the peripheral healthcare worker is with the patient, they're getting the advice from the specialist they need. And the reason it's about 15 minutes, or sometimes a bit longer, it's roughly the time between a specialist's own patients. So when I was working as an ophthalmologist at Tygerberg, we would only respond during our cases. We wouldn't have to be interrupted by phone calls. Just in terms of training, Vula is now used for training at 4 universities for clinical associates, nurses, physios, and for medical students. So if you want to use Vula for remote training, it's also available. And I just thought to show you a couple of quotes before I show you the data. This is from emergency medicine. Being able to contact the registrar or specialist saves a lot of time, anxiety, and frustration. The stats help improve services, to see where the need is and to see where you can plug holes in the system. And I'll show you some live data in a second. And just in terms of security and making sure things are done in a medical legal manner, at Mitchell's Plain, they support peripheral healthcare workers by reviewing, in this case, the Mental Healthcare Act forms, so that patients are transferred between facilities legally. So every month we send all the departments using Vula their sort of monthly aggregated analytics. And I thought I would show you some actual real data that's live. I thought that would be quite fun to show you that. So let me just share a different screen. So what I'm about to show you is live data from across the country. One of the reasons this is used, and I think you mentioned trauma earlier, it's the 16 days of activism against gender-based violence coming up. And they're going to be using the data from Vula to look at the trauma cases across the country for males and females. And then they're going to run a whole lot of interventions, and they'll see the impact hopefully at the end. So let's hopefully see this soon. There we go. So these are the different practices using Vula at the moment, and you can see the different figures per year in all these different cases. If you want to look at the map, you can actually see, for example, this is Pietermaritzburg, and you can see exactly from which facility all the different referrals are coming from. So this is hopefully, this is all live. So you're seeing a live feed from Pietermaritzburg, and hopefully the map comes up, but I think you can probably see the outline of the province. It's quite a large province, but if you go to Kimberley, this is one of our largest provinces in South Africa, and it's basically a 7-hour drive to get from one side to the other. So if you can use the specialist advice to guide the frontline healthcare workers before they make the referral or before the patient has to travel, you can have a massive impact on patient care. What we did also is we looked at the cause of burns, which I think the first speaker, Ridwan, was speaking about as well. So I'd like to show you quickly the cause of burn at Red Cross Hospital. So Red Cross is in the Western Cape, and you'll see that most of the burn wounds were from hot water, with some from fire and flame, almost like 1 in 10. However, if you go to Pietermaritzburg, what we did after the riots there is we wanted to see, are more people cooking on fire or are they cooking on electricity? And there we showed that actually they're still being burnt by hot water, but many people in that province are still cooking on fire every day. So the pediatric burn cases there are a different kind of pattern to the Western Cape. And it gets actually worse, I'm afraid, or just different. If you go to Kimberley, you'll see that the numbers are almost equal. So your burn interventions in the community can be actually individualized across different provinces. And you can even use the data to look at the individual hospitals that are referring into Kimberley, for example. So you can see where are people being burnt by hot water or children, or where are they being burnt by flame or fire, so that you can actually almost individualize your interventions down to very discrete individual areas. So that gives you a sense of what the data can do. Yeah, so hopefully that gives you a bit of a sense. And if you are in a company that supports burns or works in the burns field, we do offer opportunities for partners to support departments that are using Vula, because we offer it for free for every department using Vula. I've shown you the data, and those are my contact details, and that's the website. So I really hope to be working with more of you soon. And I've just left some time for questions. So here to answer anything in the meantime, or you can just mail me if you'd like to contact me later. So yeah, thanks very much.
Thank you so much, Dr. Matham. Fantastic use of technology. Let me just read a couple of comments from the audience. Dr. Dos Passos says, VULA has become an integral part of our service. We rely on it heavily to provide advice and triage patients. Dr. Rachel Moore says, highly recommend introducing VULA into your unit, department, or hospital if not already in use. It's a great app, and support from the VULA team is always prompt and excellent. Another comment from Dr. Dos Passos. Another important point is VULA provides a paper trail when you give advice. And finally, from Mary Jane Tanti, this app is groundbreaking. Please include podiatrists in healthcare worker type. Well done to the VUMA team. Some fantastic feedback.
Yeah, thanks very much. And I guess the one functionality is relatively new. We only released it 2 months ago, was the ability to message patients securely, but it doesn't share your phone number. So this can be used to send out media, or I think the speakers from VIT spoke about sending out videos or PDFs. That's now available for you as well. So hopefully we get to the real source of the burn causes rather than just wait for them to see a health worker.
Indeed, that sounds fantastic. Thank you once again, Dr. Mapham. In the interest of time, I'm going to have to continue moving on to the next speakers. Our next speaker is Professor Ashley van Niekerk. Ashley van Niekerk is a professor at the UNISA Institute for Social and Health Sciences. He has a PhD in social medicine from the Karolinska Institute and a master's in clinical psychology from the University of the Western Cape. His research portfolio is embedded in critical socio-psychological and public health understandings of the multi-layered nature of injury, its causation and prevention, with a long-standing focus on burns and child safety. He contributed to the development of national evidence-based injury and violence prevention policy in South Africa and provincial policy for fire prevention and safety. The title of Professor van Niekerk's talk is Energy Poverty, Burns and Prevention, a Systemic Energy Intervention for South Africa. Welcome, Professor.
Thanks so much, Chair. Congratulations to the Congress organizers for an excellent start. And my thanks to the presenters for their stimulating and innovative presentations. I need to check if you can see the screen that I'm sharing.
Can I ask you to go full screen, please? Perfect.
Thanks, Dr. Suleiman. So the focus of my presentation is on prevention, and this is a particular upstream policy intervention that focuses on the management of paraffin and the promotion of an inclusive energy migration for South Africa, especially one that is focused on the needs of energy poor communities. So this case is based on 3 legs. The case for an inclusive energy policy is rooted firstly in research around the health outcomes of energy poverty. Secondly, in more recent years, there's been an especially strong human rights case made. And thirdly, the rise of information about feasible and safe energy alternatives. This migration that's being discussed here is specific to communities that typically are on the margins of South African society. Typically, these are communities in informal settlements and communities for whom the term energy poor may be used. These are communities that depend on solid fuels, woods and coal, and hydrocarbons, in particular paraffin, and that use unsafe combustion appliances with these fuel sources. Now, burns is a striking indicator of energy poverty. As you might know, there are 2,000 deaths a year due to burns. This is due to all causes, and these deaths are disproportionately from energy poor communities. I will speak to some of this case, the 3 legs to the case for this migration, and conclude the presentation with some of the information around the alternatives that are presenting themselves than are feasible for the South African setting. Firstly, by way of context, let me briefly talk about the energy poverty problem. So energy impoverishment is indicated when a household uses a disproportionate amount of its income on energy purchases. And energy impoverishment is quite widespread. You might be surprised that some years back, the Department of Energy indicated that nearly half of South African households were in fact energy poor. In the current climate, with energy at such a premium, I wouldn't be surprised if this has altered for many South African families and in fact worsened. Stats SA indicated in 2018 that up to 2 million people were living in extreme energy deprivation. So most of their energy needs were not being met. And those that were being met through fuels such as paraffin. We know in South Africa, and this is based on recent research, that households that use paraffin have higher risks for injury, of course, burn injury in particular, or ill health, and ill health through ingestion of paraffin or inhalation of toxic fumes. As I've indicated, the site for energy impoverishment in South Africa is concentrated in informal settings, informal communities. For those that are dialing in from outside the country, just to let you know that these communities primarily use informal structures. So the dwelling unit is made of flammable material and often in very close proximity to each other. When a fire is initiated, it may be exacerbated by a number of contextual factors specific to these settings. Firstly, the physical environment. I've indicated the flammable material, but also the internal layout of these homes are quite congested. And so a curtain may be in very close proximity to a paraffin stove or a candle or some other source of heat. Secondly, there's a high concentration of paraffin in these homes. And, when a fire is initiated, of course, if paraffin is in the home, even if it wasn't immediately at the site of the initial ignition event, once paraffin is set alight, it is of course highly combustible. And there've been videos on the rapidity of this explosion. I think it was indicated as just needing 1.5 minutes for an entire dwelling to be consumed in flames. The second set of factors important is the presence of substandard equipment, particularly paraffin appliances. Regulation and monitoring in South Africa is very poor. There are other igniters also reported. Of course, candles are important. And of course, for intersect, candles too are, as far as I'm aware, primarily manufactured as a result of paraffin. Factors in the human environment are important. Risky stove use by appliances by children, children present in the home alone, and then the number of children, especially if there is quite a few children. These are important factors to injury causation. And then burn treatment knowledge and to an extent safety knowledge have also been implicated as factors in both the South African literature and also the international literature. So let me just map out briefly the health case. Because of the particular audience today, I think most of you will be fairly familiar with some of the stats and some of the findings on the health outcomes, especially for paraffin and fire burns. I'm noting, of course, that there's a big body of burns that are not related to this, especially the ones that result in hospitalization, about 100,000 hospitalizations in South Africa. And so a significant part of that is due to hot liquid burns, of course. The concern of the current presentation and the current initiative is around, especially around fire burns, because of their association with severity and with fatal outcomes. So in South Africa, the fire protection agency, fire services, report 5,000 annual shack fires, and this is only the fires that are reported to FPSA. 53% of these are estimated to be due to paraffin, and 30% are due to candles. These injuries, when they are incurred, typically require hospitalization, and the colleagues in the medical field will indicate that the treatment required is often invasive, intensive. It is certainly expensive, and in many cases, it is long-lasting. And so much has been written about the immediate medical consequences. There are also psychological consequences that have been written about increasingly in recent years. And then some interesting work coming out of Australia that has highlighted the longer-term health consequences. And it's important for us to notice this Australian Cell study indicated for a range of health outcomes that burn survivors would have between 1.5 and I think it is 2.5 times greater occurrences of cancer, cardiovascular disease, and so on. Besides the direct burn outcomes, just for noting, ingestion and emission is a huge problem. Paraffin, part of the so-called attractiveness around its use is that it's easily decanted, and so it's easily purchased at the spaza shop. You could buy it in a cold drink bottle, but because of that ease of use, it is also a significant ingestion hazard. And estimates have done the rounds of between 46 to 93,000 ingestions a year just to children. Older adults are also vulnerable. And of these children, 40 to 50% present with chemical pneumonia. Beyond these ingestions, emission through substandard stoves in particular may impair lung function, and they may worsen other health conditions, including TB. Those of you in the Western Cape, I'm presenting out of the Western Cape, would know that parts of the city of Cape Town have amongst the highest rates of TB in the world, as far as I'm aware. But there's also increased impact on other conditions such as asthma and cancer. Some indications from the international work is that there may be central nervous system effects as well. This is from the UK's Public Health Department that brought out a position paper on this a number of years ago that flagged as a result of acute or chronic exposure, or both, higher incidence of irritability, restlessness, ataxia, drowsiness, convulsions, coma, and in some cases also death. That is the health case for this energy migration. There is a human rights case too. It's been particularly mobilized at an international level, but there are echoes nationally of this. You'll be aware that the UN has a 2030 agenda for sustainable development, and that SDG 7 indicates the universal access to safe, affordable, sustainable, and modern energy as a global priority to be attained by 2030. This recognition is important. There have been NGOs that have been working in the energy field that in fact have indicated that SDG 7 may well be a precursor for other important social priorities, including the eradication of poverty. Of course, good health and well-being is there. the development of sustainable cities and communities, and then even gender equality. I perhaps shouldn't say even, because so much of the energy burden in a country in South Africa is borne by women that are responsible for much of the energy-related activities that place women, but also families, at great risk. In South Africa, the Human Rights Commission has recognized that access to safe energy is in fact a key aspect of social and environmental justice and is thus constitutionally protected. Finally, the third part to the case, the third leg of this case for an energy migration is the rise of modern energy alternatives. And much of this has been discussed in this last week around the rise of renewables, hugely important because of the climate impact agenda. But important to note that there are countries with experiences that energy poverty can be changed through national policy. National policy that substitutes hazardous fuels with cleaner and safer alternatives are seen as an important prerequisite for this energy migration. Globally, electricity and LPG have been recognized as clean, safe, and sustainable domestic energy carriers with the potential for large-scale diffusion. Internationally, electricity is a preferred carrier due to its versatility and its ease of use and its cleanness, of course, at the point of use. Governments have prioritized large-scale electrification. In South Africa, 90% of homes are connected, although, as I've indicated, in the current context, the real use of electricity is probably much lower. We have unscheduled power outages due to grid constraints and unaffordability. Although this morning, thank heavens, there appears to be no power outage to affect the Congress, and I'm sure the Congress organizer is very pleased about that. But for the rest, we do know that this is the status quo for South Africa for a number of years. There are limitations in general that cause on-grid households, in any case, to revert to the use of paraffin and other dirty fuels. And although we don't have, as far as I'm aware, recent findings about this, I'm fairly certain that the usage of these other non-clean alternatives would have risen dramatically in the last couple of years. South Africa has had positive experience of safe alternative energy. It is LPG and electricity that has been recommended by the WHO, but the rise of the renewables must be taken into account, and there does need to be greater South African work that looks at local use of renewables. And local use, of course, cost considerations are always going to be important, but of course, local and safe use of renewables, especially in contexts that really require this. So contexts like the informal settlement. LPG has been argued as a replacement for paraffin in work that I've been involved in. It has been taken up in part by government, but I say only in part. There is recognition that LPG has better performance in terms of the technology and in terms of the usability of the fuel, as well as the associated appliances that are available. There have been internationally really good experiences with conversion. So in Indonesia, 50 million households were converted from paraffin to LPG in just 4 years, reducing not only health outcomes, negative health outcomes, but reducing energy poverty and providing massive savings on fuel expenses. In South Africa, we've explored LPG diffusion. There are some perceptions around affordability and safety, misperceptions around the costs, and initial work has indicated and provided encouraging results on the satisfaction of users and the benefits for local value chains. However, while there have been a number of speeches and a number of statements indicating government support for rollout, support also for LPG because of regional sources being discovered, there is still no expedited provision of this source, and there is also limited, as far as I can tell, plans for electricity connections in indigent communities or households that are not reached by the system. And as we know, because of the current constraints, this is probably not a priority, and certainly not. Is probably most likely not a priority for government at this point. I can't talk for government, so I need to measure what I'm saying in response to this. Earlier this year, a group of parties through UNISA and through ASIF for our international partners is the Academy of Science in South Africa, and it is the premier science policy body in the country. Along with other partners, we came together and we launched a series of webinars, initially under a banner of the No Paraffin campaign, but focused on an accelerated transition to safe, affordable, and modern energy, especially for impoverished communities. The campaign has three parts. Firstly, the immediate reduction of health risks to the poor, and this would be through the phasing out of paraffin as a domestic fuel in South Africa. Combined to this is strengthened protections for paraffin users during phase out. We're well aware that paraffin use will continue, especially in the absence of alternatives in this immediate phase. And then thirdly, the scaled up implementation of modern energy alternatives, either electricity, either LPG, or selected from the emerging renewables that now are being evaluated in South Africa. The campaign is contingent on a number of factors. It does require government championship. It requires political commitment to provide the safe energy. The campaign is certainly contingent on empirical evidence to support this, civic society mobilization and support, and then we're aware that effective communication that can foreground the way forward is vital, and so we flagged a communication strategy as well. Based on recent experiences with campaigns around HIV, around tobacco control, and around lead eradication, we feel that these elements make for a strong case, if adopted by government and with strong civil society support, for a reduction in paraffin use and a reduction especially of severe burn outcomes as a result of informal settlement fires. Briefly, two phases to the proposal, and these are my last few slides. The first phase is, of course, as I've indicated, around hazard control and removal, and we specifically are asking for 5 recommendations. Firstly, that manufacturers ensure that domestic products comply to the design standards set in South Africa, and that there is increased support for South Africa's enforcement authorities to step up the verification of products and for them to step up activities to curtail the manufacture, the distribution, and the use of substandard stoves. Second recommendation is that the current compulsory stove standard be urgently reviewed. It needs to address shortcomings and ensure enhanced protection of stove users while paraffin is still in use in this phase-out period. We call on SABS to formulate a standard for a bitterant for illuminating paraffin to reduce cases, especially of child and older adult ingestion and poisoning. And then we call for safety educational campaigns where there is information on the safe stove use behavior that is required, and that the emergency response behavior that will be necessary either to treat the burns or even before burns are sustained when a fire breaks out, around the safe pathways out of a home and so on. Second phase is focused on engagement, policy, implementation, and monitoring, and it's for the short to medium term. And again, government is called on to implement 5 recommendations to put in place an engagement strategy to facilitate public interest in this transition, to publish a white paper. This would be the policy paper that indicates the milestones, the timelines, and the mechanisms for the phase out and upscaling of the chosen energy alternatives. SAPS needs to set design and construction standards for the new appliances. Fourth recommendation is supportive infrastructure. We've seen the reports and the papers on the systemic barriers to safe energy use. There have to be systemic interventions to improve use, to improve distribution, and this is going to require some financing, some financial support, and perhaps incentive systems to encourage people to leave paraffin and to adopt the alternative fuels. Monitoring and evaluation is important. We continue to need an agile burn prevention sector that can provide information on, for example, the readiness of communities to adopt alternative energies, to identify implementation issues, to assess patterns of use around the new technology, and of course to report on safety kind of issues. In conclusion, this campaign is aligned to the UN 2030 agenda. It's cognizant of the indications of the scale and impact of energy impoverishment, and it notes that alternatives are available. There are better alternatives that must be considered for South Africans, and therefore we call on championship on government, civil society, research, and industry. But I guess also bodies such as the SABS, we think it's important to have the support from bodies and communities such as this one to support such calls. We also call for ongoing empirical research. South Africa is I think really blessed to have such a depth of researchers in the country, and so this is an important attribute that South Africa has in its arsenal with respect to prevention. We call for scaled up implementation of the energy solutions. We're aware that there's a massive debate in the country at the moment. This debate should not forget the needs of the 2 million South Africans that will be lighting a fire or using a paraffin stove tonight. The debate is still very focused on those that currently are connected but don't have consistent and regular access to good energy. Finally, a good plan, and all good plans need good milestones to record progress. 2030 is really around the corner, and so we believe that there is no time for not engaging with this issue. We call then for strong engagement with the issue. Thank you, Chair. I'll conclude. A couple of references if you need to read up. There is a campaign statement on the Academy's website, and colleagues and I have put out a publication in the SMJ earlier this year. I will leave you with some questions, but I will hand over back to the Chair at this point. Thank you so much, Dr.
Prof. very informative presentation. And as Dr. Anne Forster has noted, the work you are doing, Prof, is incredibly important. Thank you. We are running slightly behind time. So in the interest of time, I'm going to keep moving. Please do continue to interact in the chat box in the live auditorium. Thank you once again, Prof. Our next speaker is Ms. Annerie Duploy, the CEO and founder of Hero Burn Foundation. Annerie Duploy, her husband and father-in-law, were sadly involved in a tragic light aircraft accident on 18 October 2008 near Lephalale. Sadly, her husband, Hank Duploy, and her father-in-law passed away in the tragic accident. In 2012, Annerie founded Hero Burn Foundation in honor of Hank, who selflessly gave his life to save his wife's and to keep his memory alive. Ms. Annerie Duploy will be speaking to us more about the Hero Burn Foundation, a non-profit organization that's focused on the prevention of burns. They do burn awareness, offer support for burn survivors and their families, and provide opportunities for burn survivors to reclaim their lives. Thank you, Ms. Annerie Duploy.
Thank you so much. I'm alive.
Yes, you are.
Thanks. Good day, everybody. I'm really so honored to be in the presence of all these wonderful people presenting today, and thank you for this opportunity. My journey started on the 18th of October 2008, where on a very normal day, my life changed forever. We went for a flight in my father-in-law's light aircraft, and a few things went wrong and the airplane crashed. So we hit the ground and immediately we were all engulfed in flames. The fear going through something like that is not easy to explain. I was trapped in the plane. My father-in-law passed away on impact, and my husband was able to actually get me out of the plane and save my life. I wasn't able to move and was trapped, but by doing this, he shielded me from most of the flames with his body. My dear husband, Henk, sustained 80% burns. We were taken to the nearest hospital, which was in Lephalale, and stabilized there, and then taken from there to Mill Park Burns Unit, which is one of the best burn units in our country, and we were very fortunate to actually be admitted there. We were both sedated and ventilated, and my husband only survived for 11 days, then he passed away. I was still in a coma. I woke up approximately 3.5 months after the accident, only to find out that my husband didn't make it and his funeral was already done. The hopelessness you go through being a burn survivor, waking up from something like this and knowing that you've lost almost everything is something that only people going through this can truly understand. You do not just lose what you actually have currently going on in your life. You need to prepare to be in hospital for months on end. You also lose the person you were before the accident. Not saying that you can't get up, but you do change. To understand burn survivors and going through a process like burns, it's important to actually make contact and give that support. Burn survivors making contact with burn survivors giving support to burn survivors is where we see the most success. After being in a hospital for approximately 6 months, I realized that the support out there for burn survivors was not as what we wanted. And I created Hero Burn Foundation, started Hero Burn Foundation in the beginning with the main objection to be there for burn survivors and their family members. So, sorry, I just want to see how I change this. So, it was approximately 3 years after our accident, I realized that what I went through can actually help other burn survivors. And not just the burn survivors, but the family members of burn survivors going through this. A lot of times we do forget that the husbands, the wives, the moms, the dads standing next to that bed where a burn survivor is still sedated and fighting for their lives, that they also do need support. I've seen this with my parents and my family. And for me, it was one of the biggest things to make sure that we give that support to the family members. Getting everyone involved, explaining what they can expect going through this process with their loved ones still in ICU, still ventilated, still fighting for their lives. It is a life-changing experience going through burns, not only for the burn survivor, but obviously also for the family members and the caregivers. Through the foundation, we actually established that there is such a great need for burn survivors to actually speak to other burn survivors and get in contact with other burn survivors and talk to people that actually went through what they went through. Getting them back on their feet, giving them some guides as to how to prepare for their life going forward is so important. Putting in place a system and a foundation where there is a concrete support for the survivors, going into our website, making contact with us through Facebook, actually making contact with us telephonically also. We can put them in contact with other burn survivors. And we've got a program called Burn Buddies, where we put like-minded burn survivors that actually went through the same kind of trauma and have them support each other. Putting up burn support groups at burn units and making sure that the burn units know that you are there to give support where they not normally have the time to give that intensive support is also very, very important. Most of our support that we do currently have is telephonic support. Obviously, with COVID, we weren't able to do a lot of our visits in hospital. So a lot has moved over to electronic help, social media, telephone conversations, and just make sure that burn survivors always have a point of contact. It is so important for a burn community to actually be there and open for burn survivors 24 hours. Burn survivors has to cope with the whole process of not only working through physical pain, emotional pain, learning to cope with being a total new person with probably a new personality, that financial burdens always slips in with this. A lot of people going through burns lose everything. In our situation, we lost our houses. I worked for myself. My husband worked for himself, so we had no income. We lost our vehicles. We lost everything. I had to start my life from scratch again. And most burn survivors go through things like this, not being able to work again And understanding the concept of all the trauma burn survivors goes through actually gives us a better understanding as to how to help, how we can help, how we can assist. Establishing the need, getting out there, getting donors, getting sponsors, and making sure that we're actually looking after these burn survivors. We also make contact with social workers where we do feel social workers are needed in a certain situation. We open communication channels between Euroburn Foundation, the Euros we work with, and medical departments, and to make sure that the Euros actually commit to their medical treatment. We do find so many burn survivors going through this trauma just want to isolate themselves and get away from everyday life. And as Euroburn Foundation, it's important for us to get these burn survivors back on track, seeing their physiotherapists, their occupational therapists, their reconstruction doctors, getting them back to hospital and not leaving their medical care behind. We do a lot of small projects where we actually hand out comfort blankets, which are knitted by lovely ladies right around the country to hand out to burn survivors in burn units. And we've seen the connection that burn survivors makes with this small little gesture actually gives them hope. It's that small little steps that we can take to actually give hope. And then I think it's very important for people to know that going through this, it's a lifelong process. It's a lifelong commitment to being a burn survivor, and getting the patients back to the doctors throughout their life, committing to their reconstruction procedures is an ongoing process. Sorry, I just want to move this one on. One of our main focuses that developed approximately 2 years after starting the foundation for me was creating burn awareness. We've grown a lot in this aspect, and for us, burn awareness is one of the most crucial parts. So besides doing the burn support to the burn survivors, the families, we try to create burn awareness as far and wide as we can. At schools, we do social media burn awareness as far and wide as we can. We've got open channels with primary schools, pre-primary schools, even with high schools and universities, to just get involved and make sure that we can get the word spread further. Our burn awareness campaigns, we hashtag as Be Burn Aware, getting to the schools and getting the students actually comfortable with the Be Burn Aware campaign helps them to actually get the word out to their homes. It's always the children that carries over the message quicker and better and faster. And we do feel that that is the best way to actually approach our burn awareness campaigns. We do share a lot of tips and burn awareness flyers throughout all our platforms that are readily available for everyone to share. Schools can make contact with me if they want me to come and do burn awareness at schools. And then we do have a very important yearly fundraiser, which is actually a burn awareness campaign. We travel throughout the country with motorbikes and old vehicles, in rural areas on dirt roads, and this happens once a year. Last year, we actually traveled 37 hours on dirt roads doing burn awareness in rural areas, because that is where we need to get the message out. We need to get the message there where they do not have access to social media, to other platforms. And this has been so rewarding, seeing in the communities the work that we do, getting feedback from the communities actually months after, to see that it actually had a great impact. This is also part of our burn run that we do every year, making sure that we get the word out. Some more information about the foundation, you're welcome to visit our Facebook page. And here's just some photos of some of the burn survivors that we have worked with during the past few years. You are welcome to contact me at any time if you want me to get involved in your unit, see that we get that support, especially telephonically, out to the burn survivors in your unit. And thank you for your time.
Thank you so much, Anuri. You truly are a hero, and the work that you're doing through Hero Burn Foundation is really inspirational. Thank you.
Thank you so much, Doctor.
We are moving on then in the program. There is a slight change. The next speaker will be Dr. Anne Forster. Dr. Anne Forster graduated from the University of Pretoria in 2014. She completed her internship and medical officer time at Tembisa Hospital in Gauteng, where she developed a passion for burn surgery. She's currently specializing in general surgery at Sifako Mahato Health Science University and Dr. George Mukhari Academic Hospital. Dr. Forster is currently on the executive committee of the South African Burn Society and has been putting in many, many hours behind the scenes together with other members of the EXCO to ensure that this Congress is taking place. Thank you, Dr. Forster, and we look forward to your presentation and talk on burn centers and referrals.
Good morning, Ridwan. Thanks so much for the introduction. Yes, I'm Anne Forster for the South African Burn Society. I am going to go through some burn referrals. It's a topic that has come up quite often about from junior doctors and healthcare providers across the country. When people burn, where do we send them and when do we send them? And we think this is quite critical. So from the South African Burn Society, we have actually created a list of referral criteria, which is available on our website as well as a list and map of the current referral hospitals in the different provinces. So, burn services are provided throughout the country and are not only limited to burn units or burn centers, but not all burn injuries require admission to a burns unit. So we'll go through what are the normal burn referral criteria that we would like to see in a burns unit. So the criteria for adults, so patients in any age group with deep partial thickness burns of any size, any patients with burns of special areas, and this would include anything from face, hands, feet, genitalia, perineum, or anything involving major joints, because this would need specialized care as well as continued rehab. And then any patients with electrical burns, including lightning burns. This is quite important because there could be underlying any cardiac abnormalities and further injuries that are not necessarily visible to the naked eye. Then obviously complex chemical burn patients, as these might develop over days. So the initial burn might not be as obvious, and this would need specialized care. Any patients with any inhalation injury or suspected inhalation injury resulting from fire or scald burns, it's important that these patients be referred quite timeously. Then any patients with any circumferential burns over the limbs or the chest. And this is quite important because these burns can actually inhibit proper breathing and can cause compartment syndrome. This would also need specialized care and needs to be treated quite quickly. So then continuing for the burn referral criteria for adults, then any burn injury patients with any pre-existing medical conditions that could complicate management, that could prolong recovery or affect mortality. And this would include anything from, cardiac failure, diabetes, HIV, any underlying medical condition that you would think might hinder the treatment of this patient. So any patient with burns and any concomitant trauma. So we do sometimes see, as Dr. Marley presented earlier today, you might see quite complex traumas, with motor vehicle accidents or like underrepresented airplane accidents. And so those patients really need to be seen at a level 1 or similar trauma center. Then any pregnant patients that have sustained a burn, and this would include anything from early pregnancy, first trimester, second trimester, and third trimester. This would be very important to refer as quickly as possible. So then any burns patients with treatment requirements exceeding the capabilities of the referring center. And so as William Mapham referred this morning, we do have patients that have quite extensive burn injuries, in small rural clinics, small rural areas that just don't have the capacity or the skills or the knowledge to necessarily treat these burns adequately. And so if you feel at all overwhelmed by a burn in your burn center or in your small clinic, rural hospital, it would be very pertinent to reach out to any burn referral center or burn specialist to find out if this is if it's necessary to refer the patient. And then obviously any septic burn wound cases also needs to be referred to a burn center. So if we look at the criteria for pediatrics, so any burn patient less than 1 year of age. And I think this is very important because we do see some of quite extensive hot water burns and open flame burns in these young kids. And it's important that they get referred quite quickly as they deteriorate quite quickly. Then all burn patients from 1 to 2 years of age with any burn more than 5% of total body surface area. And then any patients older than 2 years with partial thickness burns greater than 10%. And then all pediatric cases where child abuse is suspected or for a non-accidental burn needs to be referred. Now that we've gone through all the referral criteria, we will go through all the burn centers that we have collected over our country. So first, I think there is just I have a problem. I don't see my map. So I'm sorry for that. We will share this on our website as well. So, but in South Africa, we have very few burn centers, and most of them are actually concentrated in our our smaller provinces. So in Gauteng, we have Dr. George Mukhari Hospital, Kalafong Hospital, Tembisa Hospital, Leratong, and Chris Hani Baragwanath Hospital. The only private institution that's known as an official burn center in Gauteng is Netcare Milpark Hospital. In the Western Cape, we have only Tygerberg and Red Cross War Memorial Children's Hospital. Sorry for that. And then in KwaZulu-Natal, we have Ngwelezan, Nkosi Albert, and then and the Pietermaritzburg complex. In the Eastern Cape, we have Nelson Mandela Academic Hospital, Cecilia Mokiwane Hospital, Frere Hospital, and Dora Nginza Hospital. Then some of the neglected provinces in our country would be the Free State, Northern Cape, and the Northwest. who have very few referral hospitals or burn centers. So in the northwest, there's Tsepang Hospital. In the northern case, it's Robert Mangaliso Sebukwe, or more commonly known as Kimberley Hospital. And in the Free State, our burn centers are concentrated in Bloemfontein, which has the Mediclinic in Bloemfontein, and then also Pelenomi Academic Hospital. Then in Limpopo and Mpumalanga, we also don't have very many burn centers. Actually, we only have 2. So in Limpopo, we have Mankweng Hospital, and then in Mpumalanga, Rob Ferreira Hospital. So you can see from this that there are very few official burn referral centers. And so a lot of the work actually gets done at some of the district hospitals and your larger academic hospitals. So it would be pertinent to contact those hospitals in your area and to familiarize yourself with the hospitals in your area that treat these burns patients. I do apologize for not losing my maps, but all these maps and all the referral criteria, as well as a table of all the hospitals listed, are available on our website. And so if you need any of the information, the contact details of the wards, the hospitals, the doctors involved, then you can just access that from our website. I think that's it from me. Over to you, Ridwan.
Thank you so much, Dr. Forster. Just as a reminder, do you mind just telling us the full website address again?
Okay, so it's www.saburnsociety.co.za.
Perfect. I'm sure the audience will take a look and have a look at the maps. Thank you so much for the presentation. I'm just looking to see if there are any questions at this stage. I don't see any from the audience. I encourage audience members to share their questions and interact in the chat box in the auditorium. Thank you once again, Dr. Forster, and thank you for all the work that you do. Our next speaker is Mr. Dion Essau. Mr. Dion Essau is a station commander in the City of Johannesburg Emergency Medical Services. He is an emergency management specialist. Mr. Dion Essau is now focusing on prevention and reduction of fires and injuries and works in the Public Information, Education and Relations, known as the PIER or Peer Division. Mr. Essau's talk is entitled Fire and Injury Intervention Programs in Schools and Early Childhood Development Centers.
My name is Dion Essau. I'm a station commander at the City of Johannesburg Emergency Management Services. The program presenting to you is our intervention or prevention strategies that we use and talk a bit specifically for kids as well as adolescents. The program that we run in the high school and primary schools is known as the Schools Emergency Response Teams, shortly known as CERT. Training consists of basic fire identification, fire marshal, and first aid awareness. We have 9 regions in the City of Johannesburg, and 80% of schools participated. Students get certified as CERT champions in the schools. So what this means is that they've been given a badge which they attach to their blazers, and this is the identification to the other school kids that these kids are trained as in first aid as well as fire marshalling. And they need to take instructions from these kids if there's an evacuation of a school during any incident. At this moment, we have had no fires at schools except for malicious fire setting of schools by criminal elements in our communities. The next one is the third program, the Teachers Emergency Response Teams. So having looked at the high schools and sought and then deciding that there's no ways we could train that same program within the ECDs, we then came up with a program that would target the teachers because the target audience of the preschools are mainly the teachers and not the kids itself. Because imagine training the kids on a emergency response team between the ages of 4 and 6, and this would just not be feasible. So then we target the early childhood development centers. Teachers are trained on basic fire evacuation and basic first aid. Certification is obtained by completing the required exams, and here we do the firefighting exam as well as the first aid exam. We're relocating of ECDs to lower floors in buildings. So in Johannesburg, we have a lot of high-rise buildings in the CBD, and what we discovered was that the owners of the ECDs would rent a floor, and this particular floor would be on the 15th or 20th floor of the building. And we identified that if there is an incident and you have to evacuate 30 to 40 kids out of the building, it would be total chaos. So what we do is we then go in with the building owners, and we negotiate that the preschools or the ECD be brought down at least to the ground floor. We had a fire at an ECD not so long ago, and the teachers, through the training that they received, managed to evacuate the school, and no injuries was reported. Then we also target the actual kids of the ECD. So the program called the Learn Not to Burn program. And this program, we target the kids under the age of 10, and we participate in all kinds of events, being campaigns to highlight the safety and the dangers of fires, etc. Burns is one of the leading causes of external deaths to children under the age of 10. At one stage, it was actually the #1 leading cause of deaths to children. The program in the ECD consists of the following. We offer the following presentations. The Learn Not to Burn includes your stop, drop, and roll, cooler burn, and how to call the emergency services. Then we have a juvenile fire setter program, and this program, what we do is we get the teachers would identify a problem child, and that plays with matches and lighters, and then we would go in as a team and with the parents sit down and discuss the dangers of fires with the child and the parents, and we've seen some amazing results. We also do seasonal campaigns. Water safety is one of our campaigns. Now in the summer season in Johannesburg, we are going out into the swimming pools and not teaching kids how to swim, but teaching them the safety at swimming pools. And a simple program is when you go to the swimming pool, make sure you have an adult with you. Then we also, with our enforcement colleagues from the road traffic side, we do motor vehicle safety, and one of the campaigns that we do is to teach the kids the Buckle Up campaign, and we would then go into schools and we would target the transportation of kids drivers, and we would then ensure that the kids are buckled up when they arrive at school. Bike safety, we encourage the use of helmets whenever they get onto a bicycle. Pedestrian safety, and this is a huge problem within the Johannesburg region, is that children would cross a road at any particular point in the road, and we would go in and encourage them to use the traffic calming measures, which is your robots, pedestrian crossings, and also teach them how to actually cross a road. We also teach the choking and suffocation, which is a huge problem for little kids. So we target the ECD teachers in this program. Poisoning prevention, and here you have situations where you find that when we do a door-to-door campaign, We would go into the house and speak to the parents about storing the paraffin in correct containers and not in cold drink bottles, and then a falls prevention program as well. In closing, the City of Johannesburg have reduced fires and injuries substantially. And what we do is we actually go and we have 6 districts in the City of Johannesburg, and we would then interview the firefighters and the officers at a particular fire station, and we would ask them the questions, almost like a survey, like, has fires reduced, did they have any burns of any kind, and their response to us is that they do not, they have not experienced much of it for the last couple of years or so. There is incidents, but it's very far and few at the moment. Our intervention programs have been running for the last 20 years, so it has been a huge success in the City of Johannesburg because we've had our challenges, and our education department every single day is out there changing behaviors. And then we intend moving our programs online, and this is going to be a huge opportunity for us to reach out to the rural parts of South Africa, where we could actually use the Microsoft Teams or the Zoom software to actually present our programs. So we don't physically have to be in the classroom anymore. Most of the schools in the City of Johannesburg have moved already over to Microsoft Teams, and we are just piggybacking on that program. So we're quite excited about reaching more kids and more different target audiences. We're also available for any sharing of information. So if this presentation strikes you as where you could assist, we could assist you in helping getting it off the ground in your region or your part of the world. We are available. We also want to provide leadership to obtain school-based fire safety and injury prevention commitment and introduce and continue fire and life education in the school's curriculum. We've had a pilot project with a school for special needs children, and it's been quite successful so far. So we're still in the process of trying to get this program fixed into the school's curriculum, but yeah, there's been some challenges along the way. That's my presentation. Thank you and be safe. As you can see, we have our fire mascot, which is a rhino. It's called Regional the Rhino. And it's not because of it being an endangered species, but because of the fact that it is also the firefighter of the animal kingdom. So when a fire breaks out in the veld through lightning or other causes, the rhino would actually go and stamp it out, and that's why we've adopted that as our mascot. At this point, I'd like to say thank you to Dr. Andrews for giving us this opportunity, and I hope that if you guys would want us to assist you with anything, we are quite capable. Thank you very much.
Thank you so much, Mr. Dianeso, for a very informative presentation on fire and injury intervention programs in schools and early childhood development centers. I don't note any questions from the audience at this stage, so I thank you once again and encourage the audience to continue interacting in the chat box live in the auditorium. Our final session for presentation for this morning's session is a trade presentation from the partner Baxter, and I hand over to Ronel van Wyk for this presentation. Thank you, Ronel.
Good morning, everyone. Thank you for attending this presentation. I'm the product specialist for Baxter in Gauteng region. So I want to introduce Tecile to you. Tesil is known as a fibrant sealant. It composes of two components. Firstly, fibrinogen, with a total protein of fibrinogen of 91 milligrams per milliliter, and a proteinin, synthetic proteinin of 3,000 international units per milliliter, and then also factor 13 with more than 40 millimoles per mole. We can go to the next slide, thanks. The thrombin part contains human thrombin, 500 international units per mole, and also calcium chloride of 14 millimoles per milliliter. So Tesil aids in the hemostasis, the cell sealing, adherence, and also wound healing. The Tesil clot, therefore, contains 30% more fibrinogen than in blood, and it is 5 times stronger than a normal physiological clot. You can also see the benefits of the high fibrinogen concentration. Can move over to the next slide, please. Tesil reproduces the last stage of the coagulation cascade. It can also be used in heparinized patients. So Tesil generates a fibrin clot from fibrinogen concentrate. The clot adheres to collagen in the damaged tissue. Diffuse oozing stop, especially when sprayed. Tesil is replaced with connective tissue and acts independently of the coagulation status. Fibrin, therefore, provides a hemostatic barrier. It provides a scaffold for migrating fibroblasts, and this appears in the first stage of wound healing, and it stimulates the fibroblast. So this promotes the migration of cells. For those of you that maybe not know, Tesil used to come only in a drip form, but we can spray it to cover larger areas, as you can see in the next slide. So normally you will have the 2 ml and the 4 ml, especially in private practice. In the state practice, we have a 10 milliliter of Tesil as well. So this will give you 5 milliliter fibrinogen, 5 milliliter of thrombin, or 2 ml, 2 ml, 1 ml, 1 ml. So when we spray it, the 2 ml will cover 100 centimeters, which is actually a large area. And then for your burn patients, because it's extensive areas, the 10 ml, especially in private, like Paraguay and Red Cross, the 10 ml is much better because it will cover 500 centimeters. So I can show you, we have done a few of them. On the next slide, you will see an adult male that is sustained, obviously, burn wounds. I think it was acid burn. And we have done both the legs on the same day. But the leg circled in green was done with Tesil spray. The mesh was, or the graft was also meshed because then we can cover a larger area. And the left leg was done the normal way. The normal dressings has been applied. In this case, they put the adaptic around or the jello net around with damp saline swabs. These dressings came off on the Tuesday morning. It was done the Friday, it came off on the Tuesday morning. So you can still see the clips in the left leg that still has to be removed. But the right leg was looking so much better. It's dry because, again, Tesil gives a hemostatic effect as well as a sealing effect. And then it aids in the wound healing. On the next slide, you will see, this is things that you see every day. Could you play the video, please? This is how we spray Tesil. This is a 7-year-old girl with burn wounds, quite extensive. We spray the Tesil so we could cover with 1 10 ml the whole area. What we have learned of this episode is Tesil polymerizes very quickly in 10 seconds. It is fully polymerized in 2 to 3 minutes, and the clot strength, 70% of the strength in 10 minutes, and full strength in 2 hours. But you don't have to wait 2 hours. So after you have sprayed, you can start putting your graft, and you don't have to use sutures or clips. And then you can apply your normal dressings. But a protein slows the degradation of the clot. So normally a clot will degrade in 4 to 5 days. This will take at least 10 to 14 days for tissue to be reabsorbed. And tissue is broken down by fibrinolysis and replaced with connective tissue. In this spray case, because it's a gel and it's so open, the theater temperature is quite high. So the tissue polymerizes very quickly. So we just realized we have to dilute this a little bit and spray smaller areas. So spray an area, put the graft, spray the next area, and put the graft. Okay, this is just to show you this whole area took about 3 minutes to, yeah, sorry, the videographer was a little bit drunk, I think. That was me. So this whole area to graft took about 3 minutes because we sprayed it. I can show you the next slide because this is now just the last placement of the graft. On the next slide, you will see before and after the graft was placed. So this is really a good outcome. This little girl was 7 years old. I suppose she still is 7 years old. I don't know if she had a birthday in the meantime. Points of friction like the shoulder, the graft came off there, but it was the point of friction. So when the bandages came off a few days later, 3-4 days later, the rest looked well. But a 7-year-old child, they normally rub and scratch and everything. And this is what I can tell you about tissue. It's really there to help us so that we can get these kids done or these patients done, especially on difficult areas, so that we can get them to heal better, faster, and so that they can go home, because we don't want them to be in hospital like another little boy we've done was in hospital 3 months. And then we did a graft on him, and 3 weeks later, he could actually, for the first time, go home. So this is the outcome we want. And this is the end of my presentation. Thank you very much. Anybody, you can go over to slide 8, please. Anybody that wants to make contact with us, please ask the Congress conveners just to get in touch with us. There's reps in all the areas. We can get you in contact, and let's really start working on this project. Thank you very much for attending. Enjoy the rest of the Congress.
Thank you so much, Ronelle. I would like to also at the same time encourage all audience members to also visit the sponsored trade partner booths. The virtual booth links are available through the main Congress link. And also there are some lucky prizes that are up for grabs for members who do attend all of the sponsors booths. So an incentive to please visit all the trade partners booths and some valuable information there. At this stage, we have come to the end of our morning session, a really insightful and incredible session. As Dr. Ronelle Parkhurst has noted in the comments in the chat, some brilliant presentations all morning, and I fully concur. And thank you for all the speakers thus far. Maybe if I can also read another comment from the chat from Landre Olaboye. Anuri's story is a very emotional one. However, finding way to help others through her experience is most fulfilling. Thank you for sharing your experience, Anuri. This brings us to the end of the morning session. We have a short break before we reconvene. We will reconvene after the break and continue at 11 a.m. So just over 15 minutes break. Please do grab a cup of coffee or tea, and I look forward to continuing the Congress at 11 a.m. South African time. Thank you. Good morning once again, and welcome back to the South African Burn Society Congress 2021. It's just gone past 11 a.m. On my clock, and we've had a really insightful early morning session on this first morning of the SA Burn Congress. As we started earlier on asking audience members to please share their location where they're logging in from in the chat box, and we'll try and pop up the word cloud to indicate the different locations that audience members are joining us from. We had lots of people from all over South Africa, various parts of the country, and here's that word cloud just popped up again. You'll see locations all over South Africa, but we've also, of course, had international participants as well, including from London, England, as well as Lagos, Nigeria. A warm welcome to all the participants, both locally and abroad. Please keep sharing your location in the chat box, and we'll keep updating this word cloud as the Congress progresses. There has been a slight change in the program where during the morning session, we did not have Prof. Jacques Goosen's presentation, but that will be done in the current session now. So the second talk in this session will be Prof. Jacques Goosen, and Dr. Michael Peck's presentation will be shared at a later time. I will keep you updated on when that will be rescheduled. We're just waiting for our next speaker, Dr. Linda Dudens. She's just currently setting up, I believe. So as soon as she is ready to go, we'll continue with the program. While we await Dr. Linda, I just also want to remind all participants to please visit the sponsored trade partner booths, which the links are accessible for all six of the booths are accessible on the main Congress link. And a reminder once again that there are some prizes up for grabs for those of you who visit all the booths. So there are some lucky prizes that are up for grabs. I think we've again had a slight change in the schedule. We're going to have Dr. Michael Peck's presentation right now, just getting the final confirmation from studio. If we're good to go. Yes, so we will now, just a slight change in the schedule, proceed with Dr. Michael Peck's presentation, Violence Against Women. Dr. Michael Peck is an Associate Director of the Arizona Burn Center, as well as Clinical Professor of Surgery in Creighton University School of Medicine in Phoenix, Arizona. Dr. Peck received his BA from Harvard, his MD from University of Colorado, and his Doctor of Science degree from the University of Cincinnati. He completed a residency in general surgery at the University of Arizona, followed by a clinical fellowship in burn surgery at the University of Washington, and followed by a research fellowship at the Cincinnati Shriners Hospital for Burn Children. He served as a medical director of regional burn centers at the University of Miami and the University of North Carolina at Chapel Hill. He currently serves as chairman of the Prevention Committee of the International Society for Burn Injuries and is a liaison between the ISBI and the World Health Organization. Welcome, Dr. Peck.
Thanks to the meeting organizers for the honor and opportunity to speak with you today on this important topic. My co-presenter, Ms. Yvonne Singer from Melbourne, and I have been working over the last couple of years with a devoted and energetic group of volunteers from the International Society for Burn Injuries, ISBI. Our work has been focused on preventing violence against women and girls by burning or acid attacks. Yvonne will later provide the depth of the discussion about the problem and potential solutions. Let me now provide you with some background on the broader issue of violence against women. One in 3 women worldwide experience physical or sexual violence, mostly by an intimate partner. Violence against women and girls is a human rights violation, and the immediate and long-term physical, sexual, and mental consequences for women and girls can be devastating. Violence negatively affects women's general well-being and prevents women from fully participating in society. It impacts their families, their community, and the country at large. It has tremendous costs, from greater strains on healthcare to legal expenses and losses in productivity. Importantly, however, violence against women is preventable. We can all work together to make private and public spaces safer for women and girls and to increase access to services for survivors. Let's start by defining the problem. Violence against women is any act of gender-based violence that results in, or is likely to result in, physical, sexual, or mental harm and suffering to women. This includes threats of such acts, coercion or arbitrary deprivation of liberty, and can occur in public or in private life. Most violence against women is perpetrated by current or former husbands or intimate partners. More than 640 million women over the age of 15 have been subjected to intimate partner violence. That's more than 1 in 4 of women aged 15 years or older. Violence against women is as serious a cause of death and incapacity among women of reproductive age as is cancer, and it causes greater ill health than malaria and road traffic accidents combined. Nearly 1/3 of women worldwide have been physically or sexually abused by a man at some point in their lives. Many, including pregnant women and young girls, are subject to severe, sustained, or repeated attacks. It is likely that the data that we have from both industrialized and developing countries underestimate the problem for many reasons. Some women may believe that they deserve the beatings because of some wrong action on their part. Others refrain from speaking out because of fear of reprisals or because of shame about their situations. The abuse of women is effectively condoned in almost every society of the world. Prosecution and conviction of men who beat or rape women or girls is rare compared to the numbers of assaults. Data from the World Health Organization compare the incidence of violence against women in Africa to worldwide estimates. Married or partnered women in Africa experience significantly more violence from intimate partners than their counterparts elsewhere in the world, some 20 to 30% higher. This may be because of the trend towards more violence against women in resource-limited settings. Globally, violence against women disproportionately affects low and lower middle-income countries and regions. 36% of women aged 15 to 49 living in least developed countries throughout the world have been subject to physical and or sexual intimate partner violence in their life, identical to what has been observed on the African continent. There are several countries in Africa that stand out because of exceptionally high rates of violence against women. Shown here in orange on the left are the lifetime estimates, and those in red on the right are estimates over the last 12 months. The dotted lines down the graphs indicate global averages. Countries in which the incidence of intimate partner violence over the last year is double that of the global average include Angola, the Democratic Republic of the Congo, Equatorial Guinea, Ethiopia, Liberia, South Sudan, Uganda, and Zambia. Some of these are recognizable as failed or failing states, wherein the government has lost control of its territory and its authority and can no longer provide public services, conditions which worsen the climate for treatment of women and preservation of their rights. Intimate partner and sexual violence is the result of factors occurring at individual, family, community, and wider societal levels that interact with each other to increase risk. Some risk factors are associated with being a perpetrator of violence, and some risk factors are associated with experiencing violence. Most risk factors are associated with both. Family violence in childhood is thought to provide behavioral scripts that influence the decisions and choices individuals make when selecting partners and activities. Violence in the family of origin, whether in terms of experiencing stern disciplinary methods or in terms of witnessing physical aggression by father to mother, quite often serves as a role model. Thus, women tend to accept such behavior as the norm, and men tend to perpetuate it. Since its outbreak, the COVID-19 pandemic has only intensified violence against women, particularly in the domestic sphere, exacerbated by the measures put in place to mitigate against the spread of the virus, such as lockdowns, social distancing, and other restrictions on movement. Emerging global data has shown an increase in calls to violence against women helplines. For example, in Argentina, in March of 2020, the number of daily calls to the helpline for gender-based violence increased by nearly 40%. In Mexico, emergency calls related to violence against women increased by 53% in the first 4 months of last year. Stay-at-home measures are compounding perpetrators' use of mechanisms of power and control to isolate victims of violence against women. Unemployment, economic instability, and stress may lead offenders to feel a loss of that power, which in turn may exacerbate the frequency and severity of their abusive behavior. At the same time, the crisis is generating additional barriers for women and girls' access to essential life-saving services such as counseling and justice resources, legal advice, medical assistance, and the provision of refuge. As the world is distracted by the pandemic, many perpetrators take on an ever greater sense of impunity, assuming that they have the freedom to act without restriction. While the prevalence and forms of violence against women in low and middle income countries may differ from those in higher income countries, the health consequences seem to be similar across all settings. Women who have experienced intimate partner violence are significantly more likely than other women to report overall poor health, chronic pain, memory loss, and problems walking and carrying out daily activities, as well as a range of chronic health problems such as headaches, chronic pelvic pain, back pain, abdominal pain, irritable bowel syndrome, and gastrointestinal disorders. Women who experience intimate partner violence experience higher rates of gynecological problems, including vaginal infections, pain during intercourse, chronic pelvic pain, and urinary tract infections. Physical and sexual violence during pregnancy is linked to many complications, including low maternal weight gain, miscarriage and stillbirth, and low birth weight babies. Both physical and sexual violence have been linked to a greater risk of adverse mental health outcomes, including depression, suicide attempts, post-traumatic stress disorder, sleeping or eating disorders, and psychosomatic disorders. Children who have been exposed to domestic violence are at greater risk for repeating the cycle as adults by entering into abusive relationships or becoming abusers themselves. For example, a boy who sees his mother being abused is 10 times more likely to abuse his female partner as an adult. A girl who grows up in a home where her father abuses her mother is more than 6 times as likely to be sexually abused as a girl who grows up in a non-abusive home. Children who witness or who are victims of emotional, physical, or sexual abuse are at higher risk for health problems such as poor self-esteem, depression and anxiety, as well as physical illnesses such as diabetes, obesity, and heart disease. Violence against women and girls brings huge economic costs to any society. The negative impact on women's participation in education, employment, and civic life undermines poverty reduction. It results in lost employment and productivity, and it drains resources from social services, the justice system, healthcare agencies, and employers. Annual costs of intimate partner violence were calculated at nearly $6 billion in the United States of America and over $11 billion in Australia. Research indicates that the global cost of violence against women could amount to around 2% of the world's gross domestic product, which is approximately equivalent to the size of the entire economy of Canada. What can be done? First, it is important to promote the economic, social, and political empowerment of women and girls. This includes supporting economic empowerment and livelihoods programs, social protection and safety nets that support women and girls, and access to safe and equitable education for girls and boys. This importantly also includes promoting the leadership and meaningful participation of women and girls at all levels of decision-making, where they can today remain conspicuously absent. The knowledge base on all forms of violence against women should be strengthened to inform policy and strategic development. Information that assesses and evaluates what policies and practices are most effective is particularly scarce. Governments should take responsibility for the systematic collection and publication of data, including supporting NGOs, academics, or others engaged in such activities. Violence against women must be given greater priority at all levels. It has not yet received the priority required to enable significant change. Leadership is critical. Much can be achieved with political will, but there's also a need for considerable investment of resources and for consistent assistance, especially to the least developed countries and countries emerging from conflict. A more cohesive and strategic approach is needed from all actors, including governments, the international community, and civil society. There are many examples of potential interventions. Successful interventions are those that prioritize safety of women and demonstrate the impact of gender-based violence, whose core elements involve challenging unequal gender power relationships, that are participatory and work at different levels, that address multiple risk factors through combined programming using a multi-sectoral approach, and that start early in the life course and address norms, attitudes, and beliefs at all levels of society. The health sector can play a critical role in preventing violence by changing attitudes and behaviors that contribute to violence against women and girls, not only among healthcare providers and other health staff, but also in the wider community. On a national level, the health sector can develop national laws and policies, ensure funding, and conduct public health campaigns to raise awareness that violence against women is unacceptable. At the institutional level, health providers can develop prevention programming targeting local communities. Within health institutions, providers and other health staff can participate in training to challenge harmful reactions of healthcare workers and ensure that staff interactions with survivors are supportive, non-blaming, and grounded in human rights-based and survivor-centered approaches. Health institutions can also reflect the unacceptability of violence against women and girls by providing informational media, such as pamphlets and posters, in hospital and clinic waiting areas. As extension and mobile workers, health providers can participate in radio programs and community special events, visiting schools and workplaces. This can also build confidence in the health sector's response and encourage survivors to come forward, disclosing the abuse they have experiencing and receive care and referrals. Data collection and analysis is critical to providing a better understanding of the nature, magnitude, severity, and frequency of violence against women and girls. Better data can help us understand the types and forms of violence women experience, as well as whether or not survivors receive support. Data also inform us what the consequences are for perpetrators and costs of this violence. Importantly, data can help us evaluate which prevention programs work and which don't. There remains a significant gap of comprehensive, reliable, comparable, and up-to-date data on violence against women and girls. While countries are increasingly using similar definitions and approaches, sizable gaps remain in our data, leading to an incomplete appreciation of the true scope of the problem, as well as hampering our ability to create effective prevention programs. At least 155 countries have passed laws on domestic violence, and 140 have legislation on sexual harassment in the workplace. But challenges remain in enforcing these laws, limiting women and girls' access to safety and justice. Not enough is done to prevent violence, and when it does occur, it often goes unpunished. For more information, please go to programs available on the World Wide Web from the United Nations and the World Health Organization. Starting in 2018, the Prevention Committee of the ISBI undertook the challenge of contributing to global efforts in prevention of violence against women and girls, specifically where the violence is characterized by the use of flames, chemicals, or scalding liquids. A working group of 28 volunteers from 6 continents has come together, representing a variety of professional backgrounds and World Bank country income categories. We are very grateful for the energy and commitment shown by these volunteers who have a strong passion for this topic. Let me end my talk by briefly reviewing 3 studies in the peer-reviewed literature, which will help us understand the scope of the problem of violence against women and girls by burning and acid attacks. Criminal attacks by burns on women in Jordan are highlighted in this retrospective study carried out of all proved cases of criminal burns in female patients treated at the burn unit of the Royal Rehabilitation Center in Jordan between 2005 and 2012. Of 13 women, 6 were burned by acid throwing, 5 by hot water, and 2 by direct flames from fuel thrown over them. Body percentage ranged from 15 to 75% of the total body surface, with involvement in most cases of the face and upper trunk. The mean hospital stay was 33 days, and the mortality rate was 23%. Violence against women exists in Jordanian society, yet burning assaults are rare. Of these, burning by throwing acid is the most common and most disfiguring act, with a higher mortality rate in domestic environments. Assault by burning in Dhaka, Bangladesh, occurs in a variety of forms, resulting from various causes and motives. A total of 311 cases of intentional burns from the burn unit of Dhaka Medical College Hospital from 2004 to 2011 were reviewed. The majority of victims, 68%, were female. Concentrated sulfuric acid was the most commonly used chemical for attack. Disfigurement was the principal complication, and mortality was 4%. Dowry-related issues, divorce, or other marital quarrels were frequent backgrounds for assault by burning. Kerosene oil was used to ignite 78 girls or young women, most often related to conflicts over dowry, with a mortality rate of 97%. 1/3 of victims in all burn groups were attacked because of dowry-related issues. Intentional contact burns were often inflicted on domestic servants. Psychological disturbances were reported in all victims. A few victims had been assaulted prior to receiving burns, and fractures and deformities were also present on examination at the time of presentation for burn treatment. Ophthalmic injury with frequent visual impairment or loss of sight was very common in cases of chemical attack. Legal and social support for victims and their families were frequently inadequate to compensate for losses. This was a retrospective study of 52 acid attack victims who were admitted to the plastic surgery department in Uttar Pradesh, India, between 2012 and 2017. Roughly more than 50% of cases recorded were under 30 years of age, most between the ages of 15 and 28. Relationship problems were the most common reason for the attack. All cases of acid attack survivors were disfigured. Nearly 80% were visually impaired. Hopefully, this brief review of these 3 studies has given you an appreciation of the horrific consequences of these assaults. Let me now turn the electronic podium over to my colleague, Ms. Yvonne Singer, who has devoted herself over the last few years to this pressing problem. Thank you once again for your kind attention today.
Thank you so much, Dr. Michael Peck, for a presentation on such an important issue, violence against women, an issue of pandemic proportions. We have had, as expected, some IT issues, but I think we have that all resolved. Thank you for your patience. Dr. Linda Dudens, I believe, is now ready to present. So we just had a slight change or swap in the program of the session. So our next speaker is Dr. Linda Dudens, and she'll be speaking on what makes a severely burnt pediatric patient different. Dr. Linda Dudens is a senior pediatric consultant working at Chris Hani Baragwanath Academic Hospital and the Pediatric Transplant ICU at Donald Gordon Medical Center. The pediatric critical care team at Bera look after patients in their 7-bedded Burns PICU. Dr. Linda is an examiner for the College of Medicine for Pediatric Critical Care. She has research interest, or her research interests are burns and traumatic brain injury, with over 10 articles and 800 citations. Dr. Durden started out as a physiotherapist, as she used to faint at the sight of blood. However, she was exposed to amazing mentors who shaped her career path in pediatric intensive care. Thank you, Dr. Durden.
Right. Can everybody hear me?
Yes, we can. Do go ahead.
Awesome. Thank you. Before I start, I would obviously like to thank the sponsors. Without their input, congresses like this wouldn't be possible. To the organizers for the invite to speak, and obviously to everybody else for attending this talk. Why do we want to look at what makes a severely burnt pediatric patient different? I think we need to consider what I'd like to discuss is concepts that children are not small adults. They are unable to maintain or do the stuff that adults can do. And that's often related to the big organ that's affected by the burns, the skin. And we have to consider things like correct diagnosis and an appropriate resuscitation. If you look at pictures from years gone by, in about 500, 600 years ago, you look at the little child on the side, and they were represented as miniaturized adults. Later on, people realized that children had big heads, long trunks, and very short little limbs. And this is the same for us in burn therapy. About 50 to 60 years ago, we also managed burnt, injured children by trying to extrapolate from adult treatment protocols. When I started out in the pediatric ICU burns unit, I thought it was a very depressing field, and sometimes it is, with a lot of suffering, tragic outcomes. But now that we've got dedicated wards, specialized ICUs, and doctors looking after the patients with nursing staff, we do certainly are seeing a better and improvement outcome in our children. What are the South African stats? What is happening in our country ourselves? Burns tend to affect the most vulnerable of our population. So the urban poor who live in informal housing, these homes are often very overcrowded. They have unsafe energy sources. And we don't have the kind of setup that developed countries have with dedicated centers. Dedicated burn centers in South Africa are a scarce resource. Most burns are looked after by general surgeons without the support of a pediatric intensivist. So if we have to look at the causes of why patients die and how this relates to children and adults, they used to die initially from burn shock. This is related to not getting in fluids and the type of fluids in the how fast we were giving it. And we've now developed lots of fluid resuscitation formulas in about the 1930s and 40s. And we've been able to change this burn shock and decrease the incidence of death related to resuscitation failure. In the following days, patients used to die from respiratory failure. We're now becoming much better with our respiratory positive pressure ventilation, limiting the amount of injury to the patient via the respiratory system. And so paradoxically, because we've decreased the rate of burn shock and respiratory failure, we're now seeing a lot of patients dying because of infections. And this causes late complications of organ failure and obviously increased morbidity and mortality in our unit. I keep harping, children are not small adults. And if you look at differences between them, it affects the renal system, the immature immune system. The respiratory system in itself, there are a lot of anatomical differences. They've got a huge head, a prominent occiput, as well as physiological ranges that are different for children as compared to adults, such as the respiratory rate. Children have horizontal ribs. The ribs are more pliable. If you look at the intercostal muscle itself, they're not fully developed until the child goes to school. They're obligate nose breathers. The airway itself is much narrower, so it can often get obstructed by debris or inflammation. So all these things affect how the patient responds or copes with a burn injury. Other than that, you also notice that most of them have an increased metabolic rate. They have a higher risk of getting a metabolic acidosis, and their ability to cope with something like a burn trauma depends on their psychological maturation. So burn affects the biggest organ in the body, and that's the skin. And the skin is comprised of different areas. The dermal matrix that has collagen and glycoproteins, and they maintain the elasticity of the skin. The epidermis is the next layer up, and it consists of different cells that continuously move upwards. And these cells are very important in maintaining or preventing water loss. Within this layer, you have sweat glands, Langerhans groups, hair follicles, and they have immunological properties that prevent foreign invasion from foreign invaders. The very top layer is your stratum corneum, and this is your outermost layer of skin, and there's numerous layers, and the cells in this layer are very resilient. They contain specialized skin cells and keratin, and they're constantly shedding. So if you look at baby skin versus the adult skin, you've definitely got changes in the depth of the layers. And the children also have a reduced subcutaneous fat stores. So it makes it difficult for us to assess how deep the burn is. This then makes the skin much more delicate and more resistant and less resistant to heat. Over and above this, there's a lot of discussion about body surface area. The body surface area to mass ratio in children is 3 times that of the adult. So they're going to lose a hell of a lot more of water, secondary to evaporation when you've lost your surface layer, and they're more prone to get very hypothermic. When you look at the different chambers within the system, intravascular, intracellular, interstitial, and the bottom component of the orange part, you'll see that children have a higher quantity of body water in relation to their weight, and so especially in the interstitial compartment. And so fluids in children in children who are burnt lose an incredible amount of fluid. If you look at their blood volume, children have higher blood volumes. They have about 80 mils per kilo compared to an adult that has 70 mils per kilo. They have limited glycogen storage, so they can have a high risk of becoming hyperglycemia if we don't give them glucose as part of their resuscitation fluid. When you look at the depth of a burn, the tissue damage is proportional to the temperature of whatever the offending injury is, as well as the length of the contact. But if you take something that's water that's 60 degrees and you want to see how long it will take to form a full thickness burns, if you apply this water 60 degrees to an infant, at less than a second, you'll get a full thickness burn. In an older child, 5 seconds, and only after 20 seconds in an adult. So we can see that the children are far more at risk of getting quite severe, deep burns. If we look, we know that we need to know what percentage of the burn, how much of the area is involved. Because if you look at the total body surface areas of the body that is being burnt, this correlates very closely to length of stay and to mortality. So the more burn you've got, the longer you're going to stay in hospital and the higher mortality you have. This also assessment of what percentage of the skin is burnt is also the cornerstone for how we actually determined our initial fluid management. If we don't assess this correctly, you can get over resuscitation or under resuscitation. If you depend on the amount of fluids that you use based on this body surface area. If you think that the burn is a 50% and it's actually only a 10%, you're going to land up inappropriately referring patients to ICUs, and then using it, this lands up being a poor use of our very limited resource. So there have been several measurements that have been used either in the field, in the resus area, or in the burns unit. The area of palm, this is looked at the palm, not your palm, but obviously the palm of the patient, and often used in the field. Wallace rule of nines, this was initially used in adults and found to be not suitable in children and has been modified. And if you look at the percentage contributed to by the head is 9% in an adult, where 18% in a child. And that is made up in the legs, where in the adults it's 18%, in the children 13.5. There's a modified Lunton-Brower chart, and this needs to be as accurate as possible. Quite difficult to do, much easier to do not in the field, but once you in the ICU and you can expose the patient quite nicely. Margin of error is very much reduced in smaller children, because if you don't calculate properly, you're going to change it from a minor burn to a major one, and this has profound effects on the patient. What's quite interesting and exciting is the newer methods. There's computerized imaging, there's a Mercy Burn app that you can have on your phone, because obviously not all the patients burn holistically in a certain area, so you can draw in what you need to do. At the bottom, it gives you time of burn, it gives you the weight of the patient, and you can fill in the date of birth, and then it'll help you work out what percentage of burn you expected to have, and therefore the fluids. This is obviously still in the realms of research, but it will be coming soon. But despite this, and if you look at all the research that's looked on about fluid therapy and what we have to do, there's still a huge amount of controversies. What type of fluid, how we manage the burns. And unfortunately, we are using resuscitation formulas that were developed about 30 years ago, and they've been accepted in part of our guidelines. But we are very aware that even though we use these, there are many, many studies that have shown that burn patients are either being over-resuscitated or under-resuscitated. And that's because we're not using very appropriate or indistinct endpoints of resuscitation. Most of us know about the Parkland formula, and this calculates the amount of fluid required to resuscitation and based on the percentage burn. And the question again with children is it related to the percentage burn, or should we be looking more at the body surface area as a component? Initially, when you looked at Parkland's, the formula didn't look at using colloid in the first 24 hours, and then later on in the next 24 hours it was used. It has been subsequently modified, where we're using 3 mL per kilo, again, on the percentage of burns in pediatrics. What's quite interesting is that if you look at all the policies, the most current practices use the 2 main formulas that most authors are recommending that we should use. And that's the Shriners-Cincinnati or the Galveston formula. The Cincinnati formula was developed at the Shriners Hospital for Children in Cincinnati. And it's similar to Parkland's, but what's interesting, you'll see on the side, is it aids maintenance. And the maintenance is based on the body surface area, that's the meters squared, and not on the weight. In younger children, the fluid changes, and the composition of that fluid changes with every 8 hours. If you look at Galveston, Galveston only uses body surface area, so it takes the burn as a body surface area, not as a percentage, so it takes out that complication. And which one is the better one used? There's been no head-to-head comparison looking at these 2 formulas, and we tend to always go back to the Parklands, but which really hasn't been very helpful. What now lands up doing is that you look at whatever formula you use. If it's not that been well validated, maybe we should look at our endpoints. What are we going to consider that the patient is adequately resuscitated? Urine output is often used, 0.5 to 1 ml per kilo per hour. Lactate, base excess. We are so obviously lucky in ICU that we can look at cardiac monitoring, BP, systemic venous oxygenation, which hasn't been studied in burns patients, only in septic patients. Concern is that if you give inadequate resuscitation, you can lead to burn shock. You get suboptimal tissue perfusion and in organ failure and death. And then obviously the other side of it is over-resuscitation or fluid creep, and that has been described by Dr. Pritt in 2000 for a long time. So we use urine output but we'll discuss maybe not the best one. We use lactate. Again, lactate clearance to guide your fluid resuscitation in pediatric burns has not been studied, and there's been no prospective trials. But a more continuous looking at everything might help us, but there is no silver's golden bullet that we can use. This looks at the reports of fluid creep and the number of patients who exceeded the Parkland requirements. And some articles talk about 100 to 90%. And I think the lowest one here is a 58%, where the patients exceeded by 58% the requirements of fluid that was calculated. So despite knowing that we may be over-resuscitating, it's still happening and being reported on. And we get this concept of fluid creep, and the pathogenesis is not quite clear. Some people feel it's because the patient's been over-resuscitated, too many fluid boluses are given. We also give our patients opioid. This lands up decreasing the blood pressure, and our natural response is to give fluid. Sometimes the management is done in non-specialist centers. And because of this, a lot of information about colloids and hypertonic saline have been introduced in formularies. But again, this too hasn't been validated. So the concept is that not only do you get a burn edema, but you get a fluid creep, and this makes it worse. And it affects certain compartments, has an effect on the renal system, the GIT, as well as the lungs and liver. Maybe I should have put a warning in before I started that there might be some pictures that some viewers might not want to enjoy. The development of compartment syndrome can happen in the extremity, can happen in the abdomen, and it's related to the thickness, a full thickness burn, usually circumferential, and it's also to the volume of fluid that has been used. And then on top of that, we get a systemic inflammatory response that usually is associated with these huge burns, and it causes a microcirculatory leak, vasodilatation, has an effect on your cardiac output and your contractility. Abdominal compartment syndrome is often presented with abdominal distension, oliguria, difficulty in mechanical ventilation, and decrease to your perfusion organs. And this is where the optimal hourly urine output goal is not quite well defined. Adults use 0.5, we use 0.5 to 1. The danger of this is when you see a decrease in urine output, you need to make sure that there isn't a development of an abdominal compartment syndrome, and then you don't precipitate, making worse by giving some more fluid. So we need to make sure that you examine the patient and look at it in full on all areas. Delayed or inadequate resuscitation. This is Jackson's burn zones. You get a middle area zone of coagulation. That's irreversible tissue damage. You can't change what's happened. And if there's coagulation of certain proteins within that area, there's dead tissue. What is important is the area under and around it. And that area is the zone of stasis. And there's decreased tissue perfusion here, but it is potentially salvageable. So if you make sure that you resuscitate adequately, you're going to limit the amount of burn damage, but if it's inadequate, you're going to extend the zone, and you'll lose the zone of stasis and just get a zone of coagulation. The area around it, the zone of hyperemia, is just when tissues increased, and there's minimal cell damage here. Venous cannulation, huge problem in children, difficult. They've got smaller vessels, sites are less accessible. The child's response to approaching a needle is completely different from an adult. So we have a lot of use of interosseous venous cut downs and the use of central lines. When we look at temperature control, the burn skin has no vascular control. It loses a lot of heat. We know that they lose a lot of fluid through the area, and damp dressings often cause a great culture medium. So it's covering your child with plastic so you can still see what's happening under. You can monitor the urine output, the catheters, the pulse oximeters, but still see through the plastic sheeting often is very helpful. If we look at the respiratory system, I'm not going to go through the whole differences in the respiratory system, but just try and relate it to those patients with burns. Obviously, they've got quite a prominent occiput. Intubation is quite difficult. They've got a smaller mouth, bigger tonsils, bigger tongue, and adenoid. So the oral cavity is smaller. The epiglottis is quite large and floppy, and it, in an inhalation, burns can often swell and obstruct. And the larynx itself is quite superior and anterior, and so increase your risk for aspiration. So we need to always consider the respiratory system. because edema is associated with inhalation and resuscitation obviously makes the swelling worse. So this just looks at the facial edema due to the severe inhalation and once we've resuscitated our patient. And the picture on the right looks at a bronchoscopy. You can do an oral tube, you can do a nasal tube, but what the most important part is that you may need to make sure that you fixate your tube properly. And that's often difficult, especially if the patient's got facial burns, because as the swelling progresses, it's going to make intubation that much more difficult. So we've gone through burn shock and respiratory complications. And the last one that we're now seeing a lot of, now that we've got better with handling the two, is what happens to the response to a burn. So if you've got a small burn, the response is local. You get the direct image, and all we need to do is prevent hyperperfusion and damage to the underlying dermis and obviously infection. When you have a bigger burn, you'll end up getting a systemic inflammatory response, and the tissue is damaged, get release of cytokines, free radicals, prostaglandins, and it sets up this whole pathway or inflammatory cycle. The cells become more leaky, you get decreased intravascular volume, and you get a lot of tissue edema. Because of this, you get a lot of effects within an effect on your neutrophils, your monocytes. Your T cells start to malfunction, and so it has an effect on your immune system.
Dr. Linda, so sorry to interrupt. Just in the interest of time, I'm going to need to ask you to please wrap up if you can.
I've timed it. Sorry. Okay, I'll be quick. Sorry. But obviously the systemic response is not clear. In children, we get an episode of toxic shock, and it's not related only to percentage seen in children. There's less than 2.5% of burn. So these metabolic responses are huge. And what's important that despite the wound that's healed, the metabolic rate in children is up to 150% up for a year. So if you look at your immune response of burns, we notice that our children have a higher incidence of infection, and our burn wound infection is about 5.6 per 1,000 children days. The last thing I actually want to say is it's very difficult to determine sepsis in a burns patient versus the systemic inflammatory response. And a lot of the burn severity scores just look at surface area. We know that our children do far better than adults do. The only thing that affects it is obviously inhalation, injury, and infections. But the most important, exciting thing for us in pediatrics is the cytokine profile. And we're seeing that there's some differences compared to adults, but there are downregulations of certain cytokines and upregulations in pediatric burns. And so it makes us realize that one size doesn't fit all, because you're going to get, patients where we can actually modify or change related to the cytokine storm. We can treat it, which will not be the same as what you do for adults. And it once again will show us that our children are not small adults, and that the therapeutic interventions might change. Things like propranolol, oxaliplazole, growth hormone will all affect this. Thank you. Sorry about going over time.
Thank you so much, Dr. Giddens. So sorry for interrupting. Certainly a wealth of information there, and time just flies by when we're so engrossed. I think it's such an important topic on understanding what makes a severely burned pediatric patient different. Just a quick reminder to the audience to please keep interacting, share your questions and comments in the chat box in the main Congress link, the audience or auditorium link, and to interact with the speakers in that platform. Our next speaker is Dr. Maria Botha. Dr. Botha has been working as a clinical microbiologist for Empath Laboratories in Johannesburg since 2001. She graduated from University of Pretoria in '94, receiving the Bachelor of Medicine degree cum laude. After completing her internship at Steve Biko Academic Hospital in Pretoria, she spent 7 months working as a medical officer at Sizwe Tropical Diseases Hospital in Johannesburg. She subsequently worked for 5 months as a medical officer in the Department of Medical Virology before commencing her registrarship in pathology in Jan 97 at the University of Pretoria. She obtained the fellowship of the Colleges of Medicine of South Africa in pathology, medical microbiology in October 2000, and the Master of Medicine degree in, again, medical microbiology from the University of Pretoria, cum laude, in April 2001. And Dr. Botha is currently based at Natcare Milpark Hospital in Johannesburg. The title of Dr. Botha's talk is Antibiotics and the Critically Ill Burns Patient. Thank you.
Thank you very much, Ridwan. Thank you, everybody. Can you all hear me?
We can. Are you able to share your presentation?
I am.
Thank you.
Can everybody see that?
Yes, we can.
Is it shared?
I think you've just shared the wrong window. Just go to the presentation window and share that.
Shared?
Sorry, Dr. Botha, we just can't see your presentation at this stage.
Sorry about that. Is it being, can you see it now?
Something is, yes, it just loaded. No, it just loaded. You just had it right, Dr. Botha. Yes, so just redo that and put it in full screen and we should be good.
No problem. Is that good?
It's busy loading. Yes, perfect. Thank you.
Okay, thank you. So thank you everybody for affording me the opportunity. It's a big topic and I know we don't have a lot of time and I can't cover all. This is not going to be a talk about dosing, giving you formulas for dosing and specifics like that. And I'll tell you a little bit why just now. So I think Dr. Linda has also alluded to the fact that infection is the leading cause of death after extensive burn injuries. And although we've made a lot of progress, over the years with early excision and grafting and the use of topical antibiotics, we now face the growing challenge of antimicrobial resistance. Our organisms of interest, early on, when if you've got a fresh patient, it's your community acquired organisms, not that they're not virulent and a problem. Those of you who have seen a florid Staphylococcus aureus sepsis knows what I'm talking about. But what happens is that, at least with these early infections, our narrower spectrum antibiotics like Augmentin would be perfectly acceptable for treatment. Then we enter the next wave, which is our gram-negative organisms. First, usually we see our Enterobacterales. We used to call them the Enterobacteriaceae group, now called Enterobacterales. They're basically the organisms that live in our gut, our enteric gram-negative bacilli, and then our more organisms that live in the environment, like Pseudomonas aeruginosa and Acinetobacter baumannii. And then later on, after about 2 weeks in hospital, we start seeing our fungal infections in patients who might now have been on broad-spectrum antibiotics. And the two worrying strains or species for me, it's our azole-resistant species like our Candida parapsilosis and our Candida auris, and these dominate in certain of our centers. And then by azole resistance, obviously, I mean that they are resistant to fluconazole, which is a cheaper and easy to use antifungal, but that has now become redundant in many centers for this reason. So the scourge of antimicrobial resistance has given us a couple of new terms that we loosely throw around, we talk about a multi-drug resistant organism. What does that really mean? We tend to use it loosely, but if you have to basically give it a definition, it would mean that the organism, and we usually refer in this case to a gram-negative, is resistant to at least 3 of the following 4 drug classes. That would be your penicillins and cephalosporins, which we lump together, for your carbapenems, your aminoglycosides, and your fluoroquinolones. And of particular concern, resistance to the beta-lactam group of antibiotics, by which I mean the penicillins, the cephalosporins, and the carbapenems. These are wonderful drugs, and they are bactericidal drugs, and they were traditionally our backbone of therapy. The fact that they're bactericidal means that also that they work fast, and when you don't have a lot of time with a septic patient, you want something that gets in there and works. I mean, they still in my mind, I feel if there's a beta-lactam on board, then I'm happy. And they, as I say, the efficacy and their relatively low incidence of adverse effects, it's what makes them so wonderful to have in our armamentarium. Now, you would have, those of you working in large centers would have heard the term CRE. This basically stands for carbapenem-resistant Enterobacterales. But of a lot of worry to us is the fact we should actually be talking almost about a CPE, because we have seen the emergence of organisms from this group that are producing enzymes called carbapenemases. So we would like to actually call them CPEs, carbapenemase producing Enterobacterales. And I remember as a student when carbapenems came out, I think the first one that I was ever exposed to was imipenem. And these were really our catch-all antibiotics for years. It was like domestos, it killed everything. And now, unfortunately, we can't rely on the carbapenems anymore. As empirical therapy, knowing that we're going to basically definitely cover the patient for any gram-negative infection that he or she may have. And we now often have to resort to combination therapy with often more toxic, less efficacious, more expensive, and often hard to obtain antibiotics. So this is just a laboratory report of what one of our carbapenemase producing Klebsiella pneumoniae antibiograms look like. And you can see all the R's. You can see that that we report carbapenemase under the heading of Klebsiella pneumoniae. This one is an OXA48 carbapenemase. These are not just of academic interest for us to know which enzymes are around. I'm not going to get into it in full detail, but certain antibiotics work better with certain enzymes, or there's been more studies done on them. For example, in America, the KPC enzyme is very prevalent, and there's been more studies done on that than on OXA48, which is the one that I see in most of the hospitals where I operate. So you will see that we've done MIC testing at the end on the right for the carbapenems. We need to do this as it gives us a more clear idea of the level of resistance and whether we can still use one of these carbapenems in combination with another drug. And you will see that for example, meropenem has an MIC that still defines it to be in the sensitive range, and we would, for example, in this case, want to use meropenem, and we might combine it with amikacin, for example, and see whether we get a good outcome. So this is just an example of a lab report. Those of you, all of you working in burns, know that these two organisms are often a huge problem for us and may actually sometimes lead to us closing units. I certainly lived through Acinetobacter baumannii causing a unit to close, and they are. The fact is that they can survive so well on wet and dry surfaces, and unfortunately, because they are environmental organisms, they have good survival skills. You know, the environment outside of the human body is also a very challenging place for an organism to be. So they often are resistant to all antibiotics that we test in our antibiograms, including last resort antibiotics such as colistin. And they've got numerous, multiple mechanisms of becoming resistant to these antibiotics. And this is an example of a drug-resistant Acinetobacter baumannii in a urine. You can see all the R's. We may test for an Acinetobacter in a bloodstream. We might test for tigecycline, which are two other salvage antibiotics that we may use. Both of them are expensive and have lots of side effects and are often difficult to get hold of. So our gram-positive organisms, multi-drug resistance in gram-positive organisms of Africa appears to be less of a problem than elsewhere in the world. And I'm referring now mainly to MRSA and VRE, vancomycin-resistant enterococci. But of worry to us is the advent of Candida auris, yeast that we're now seeing a lot in South Africa and in the bigger centers, definitely. And it has the ability to develop resistance to multiple classes of antifungals. And it's a sticky organism, so it sits on hardware. It makes a lovely biofilm, and it therefore has a propensity for causing outbreaks. This is an example of a Candida auris that we recently isolated from a patient in a urine. And you can see that it is only sensitive to your echinocandin group of antibiotics. It's resistant to amphotericin B and to the azoles. And we have even we've had strains resistant even to the echinocandins. So just a quick word, the whole issue of empirical antibiotic therapy and surveillance cultures. It's difficult for us to treat a patient with burn sepsis empirically for the reasons that I've now discussed. So in a lot of our units certainly at Mill Park, we do surveillance cultures in the form of weekly tracheal aspirates, for example, culture debridement, doing dressing changes, central line tips. But I think what we need to remember here, very important for us to discriminate between colonization and infection. And the purpose of these cultures should be purely to provide information regarding the organisms a patient is colonized with and their antibiotic susceptibilities. A positive culture should not prompt commencement of antibiotic therapy in the absence of us making a clinical diagnosis of infection or sepsis, which I know can be difficult in a burns patient. But we really try to use these as surveillance cultures purely to guide us in our choices of empirical therapy should the patient become septic. And units should consider the costs, the risks, the benefits of various screening approaches. Prophylactic systemic antibiotics, there's no evidence that this has a place in the treatment of burns. And it seems counterintuitive to flood our units with an even greater load of antibiotics in our current situation. So there's really an absence of good quality trials, even for perioperative prophylaxis for excision and grafting. The studies are not great. They use different drugs, doses, duration of treatment, and they often designed to evaluate efficacy but not safety. Dosing, as I said, it's a tricky thing in burns patient. The hypermetabolic state in patients with large burn injury causes increased renal clearance of our commonly used antibiotics. So we have to strategize around optimal dosing, using higher doses, increasing administration frequency and prolonged intravenous infusion times, which we do in our units. Limiting our dose increases is our toxic effects, but it's very difficult to give standardized dosing recommendations given the intra-patient and inter-patient variability of this hyperdynamic state. And in an ideal world, we would have individualized antibiotic dosing for every patient through the use of real-time therapeutic drug monitoring. However, in South Africa, this is only really readily available for the aminoglycosides, gentamicin, tobramycin, amikacin, and for vancomycin. And then in the case of the antifungals, we can do it for voriconazole, but unfortunately, we're still a way off from being able to do it on an individual patient base for a greater spectrum of antibiotics. So for this reason, I can find no official guidelines for dosing in burn patients at this time. Also, there is really no official guidelines for how we should approach the treatment of extensively drug-resistant gram-negative bacteria, and there's yet to be a formal formulary coming out, giving us proper guidelines. We base it on opinion pieces, on some studies that are done, but basically it's often a complex treatment, and it should be individually talk about these patients, the microbiologist, the pharmacist, with the clinician, and we take into account the identity of the organisms, the MICs of antibiotics such as the carbapenems, colistin, and tigecycline, and drug toxicities and limiting factors, renal hepatic failure, bone marrow suppression. And really, you do need a multidisciplinary team to approach these infections. The Infectious Diseases Society of America recommend novel antibiotics. We're starting to see them. We have ceftazidime avibactam available in South Africa, but it is very expensive and difficult to get hold of. It's a Section 21 drug. It's very, very expensive. So that at this stage is not, we don't have we don't have a magic bullet to address this problem of highly drug-resistant organisms. So I think my message here is that preventing and treating infections in a burn unit depends on teamwork. And it's really, in an ideal setting, one should have very regular team ward rounds in your burn units with your role players, infection control, nursing staff, your clinicians, your pharmacists, your laboratory staff, and your microbiologists. And antimicrobial stewardship without the rigid application of infection prevention principles is unfortunately also a futile endeavor, as you all know. And then, as I say, we cannot wait for the arrival of miracle drugs to cure our increasingly resistant population of resistant microbes. We have to work carefully with the antibiotics that we currently have, use them responsibly and wisely, and sometimes creatively. Thank you very much.
Thank you so much, Dr. Botha. Maybe just one quick question from the audience.
Yes.
How many burn surgeons use hypochlorous acid on burns, and how fast from admission? This is from Dr. Allard at Chris Barnett Memorial Trauma Center.
I'm very bad at answering that question. I was kind of trying to skirt the issue of localized therapy of burns. I'm sure that one of my more learned clinician colleagues would be know more about. For me, it's a foggy area, what gets put on wounds. So I don't know, doctor. I'm hoping that this will come to light later on.
I see a response from Dr. Gary Dos Passos in the chat that he regularly uses it from the outset.
Okay.
Thank you once again, Dr. Botha, for a really informative presentation.
Thank you so much.
Our final presentation for this morning session is by Dr. Koti Baxter. Dr. Baxter is a specialist anesthesiologist in the Division of Pediatric Anesthesia, Department of Anesthesia and Perioperative Medicine at University of Cape Town. She is based at the Red Cross War Memorial Children's Hospital and manages patients coming for diverse procedures ranging from simple to complex. She has a particular interest in anesthesia for cardiac surgery, burn surgery, and organ transplantation. She is part of a dedicated team managing the neurosurgical treatment of patients with Moyamoya disease and supported the establishment of an ENT service that performs complex airway surgery. Dr. Baxter has also been involved in the pain service at the Red Cross War Memorial Children's Hospital, and the title of her talk is Highlights Burns Anesthesia. Thank you, Dr. Baxter.
Thank you, Ridvan. There we go. Right. I am a pediatric anaesthetist, so that's my disclaimer. I have not actually done much in terms of adult burns anesthesia. And I work in a place with a nice busy unit, so I have made burns one of my areas of interest. So this talk is essentially just to highlight a few things that I've learned, things that have changed over the years that I've been involved in burns anesthesia. And hopefully towards the end, we'll also talk a little bit about things that I still want to learn in terms of burns. Let's see if I can advance. There we go. Okay, so anaesthetists want to talk about airways all the time, and burns patients give us fantastic airways to play with. In the acute patients, often issues with edema and inhalational injury. And one of the things that have helped us over the years now is the advent of video laryngoscopy, not only for us, but also for our ICU colleagues. They love seeing pictures and videos of what the airway actually looked like when we intubated the patient in theatre, and that just helps them with their further management of the patient as well. Other thing that is where the pendulum is swinging back again is we used to use lots of uncuffed tubes, and now we've got better quality cuff tubes, especially these micro cuff tubes where the cuff sits nice and far towards the tip. They've taken away the Murphy eye to move it down away from the cords, a soft polyurethane cuff. And now that we've got more cuff tubes and more appropriate cuff tubes, and we can use pressure manometers to ensure that it's not too tightly inflated, I often rather use a smaller size tube, and there's more space and it's a more gentle tube sitting in the patient, and hopefully I will cause less secondary trauma with my intubation. Many other issues, especially as the patients and the go down the pathway of their burn management. One thing I do want to highlight is this lovely paper that was published by my colleagues, Rebecca Gray and Professor Heinz Roeder, of a unique way to stabilize these tubes in theatre. Now, this is for in theatre. We do not use it in ICU. In theatre, we haven't had any injuries or any problems with it, but in ICU, you may cause pressure necrosis if you leave it like that for too long. So we use a nasogastric tube down the nostril, back out the mouth, put the two ends together, and then use a cable tie to pull these three things together, the tube and the two ends of the nasogastric tube. Nice and tight nasogastric tube, cable tied nice and close to the mouth, and then you've got an extremely secure tube. I must say these don't fall out easily. Quite easy at the end. You just cut through that nasogastric tube and you extubate your patient again. If the patient has to go to ICU though, it's very difficult to remove the cable tie. You have to use a blade here next to the face of the patient. Don't like that much. So then we often use a nice sticky things, plaster like Sleek, and we just tape these three things together. And you have to be a little bit more vigilant. That can often get a little bit wet. If it gets wet, it can also get slippery and you can have issues. Other thing is our ICU patients are already intubated via the nose, and so we will take the dressings off and take the strapping of the tube off, and then we can use this technique. But I would suggest if you do that, have your ET tube lie flat over the mouth and still put your securing Sleek close to the mouth, not close to the nostril. Because if you do drop down your tube, you will extubate the patient, and that's often what happens. If you secure it here, it drops down and you accidentally extubate your patient. Okay, or you could of course avoid all of this and just use a native airway, and that's where ketamine comes into its own. I think the one place where ketamine is really used as an anesthetic agent, not only analgesic and sedative, is in burns anesthesia. So we took this lovely paper from people done in New Zealand, where they showed us what the pharmacokinetics of ketamine is in children, realized that the recipe we were using for ketamine total intravenous anesthesia, or TIVAS, was probably underdosing our patients, and that's why we were seeing such a lot of tolerance. Patients were just waking up a bit. So we revised our infusion rates and adjusted it to this, but because we had our own mixes that we were making up, we changed this a little bit to this recipe. So we now use induction dose, 1 to 2 milligrams per kilogram, and then you start with your infusion rate at 12 milligrams per kilogram per hour for 20 minutes, go down to 8, and then use 4 for the remainder of the anesthetic. Psychomimetic effects are not a huge issue in children, prepubertal children. There's lovely work done for us by the emergency medicine guys, and children in general, if they do see funny stuff, it's usually friendly little rabbits and things. Like it's not as if it's disconcerting type of effects that they get. We used to routinely give glycopyrrolate as an anti-sialog. I also looked at that. There's no evidence that it decreases adverse airway events. In fact, there was one study where it showed an effect, and it was actually they had more adverse airway events. So I've stopped using glyco routinely. I now only use it if a patient really starts giving me trouble with a lot of secretions. These patients do move. It's a dissociative anesthetic, but you must make sure that the movements are not directed. If they are directed, that may be a sign that the patient is light, of course. If the patients do move too much, or if you're struggling to maintain them just with that high infusion rate, then it's very useful to add in propofol. I usually just use a low dose infusion, and that settles in beautifully. It also helps to decrease the cardiovascular effects. So you get less hypertension, less tachycardia, and just actually makes for a much nicer anesthetic with ketamine. We do still see tolerance over time with ketamine use, and therefore I really reserve it for the times when I want a native airway. In other instances, I may just use my normal gases again. Ketamine is very good at maintaining airway reflexes. That's why you can use it without putting anything in. So do not put something in. If you are only running ketamine, do not use a laryngeal mask airway, or don't try to intubate without a muscle relaxant. You will run into trouble. Anaesthetists are very well known for our instructions that patients must be nil by mouth, which is exactly what burns patients don't want. The one thing that's done really well in our unit now is our patients are not nil by mouth for oral medication anymore. If I look at the drug charts, it's beautiful. They've had their 6-hourly medicine. In fact, often I'm in theatre, it's 8 o'clock in the morning. I have to go check because my patient has probably had paracetamol at 6 o'clock, so I cannot give my paracetamol in theatre. And then Baxter brought out a new clear fluid guideline where we can now have clear fluids up to 1 hour preoperatively, which hopefully makes for a little bit of leeway in terms of clear fluids, at least. I know there are centers elsewhere in the world where they do not have any limit on clear fluids. You can have clear fluids up to the time you come to theatre, but in South Africa, that's not the case yet. I must mention pain. I'm glad to see there are many other people talking about pain. I think the only thing I want to say is that requirements vary. Patients are individuals, especially burns patients, where there are many changes to their physiology, so we have to adapt to that. A big change over the last 14 years or whatever that I've been doing this has been the advent of ultrasound. Ultrasound has revolutionized vascular access for us. We can now ultrasound a vessel, find it, and then cannulate it. So this child, for instance, he'd had many drips already. He didn't have good veins. Even these saphenous veins here where we often go were non-existent. But if you ultrasound up his leg, you can find the saphenous there. And that's how we managed to find that vein, cannulated it. And then we used this long line. We have 40 millimeter and 60 millimeter lines. So this may be 6 centimeters and sitting there. If we do this nice sterile technique, secure it nicely, especially if you use a nice big vein, we have had many joyful hours of use of these kinds of catheters. You could also put a formal midline catheter, which means you find the axillary vein and put the catheter so that the tip sits there in the axilla, and those have these very good data and evidence that those can last really long. Now, of course, that we can ultrasound, we can use it for anything. So we can use our internal jugular veins, subclavian veins, femoral veins, but we can also access the brachiocephalic vein right here from the supraclavicular area coming down into the chest. And that you can only do with ultrasound. So that's just another option for us for vascular access. Blood transfusion, always a big issue, many reasons not to do it, quite a few reasons to do it, often causes fights. For me, the big issues are the immune suppression. I don't want to cause more need for antibiotics and also fluid volume overload, because we often resuscitate quite nicely and keep up in terms of volume, and then suddenly the HB is 5. And then we give the blood, but then we overload patients. What I suggest is that you have a plan for your unit. In our unit, it really became an issue. We eventually had a nice multidisciplinary team discussion, got expert opinion, made a table where on the one end we said, if you come for this size work, so if you're coming for a 5% debridement of graft and your HP is that much, you will fall somewhere into this table. So either you will have no need for blood products ordered, or you may need just a group and screen, or you may need blood ordered, etc. And we used that for a while, and then we audited it, and it was quite accurate. And subsequently, I think we just started trusting each other more again. Definitely very useful to ask the person who saw the wound most recently. They will often say, oh, it's only a 2%, but it's very granulated, it's on the scalp, it's very septic, etc. We expect it may bleed more, and then make decisions based on that. We do what we can to minimize blood loss. What I find really difficult is estimating blood loss. I mean, there's looking at it, but then there are all these things. So we use glycis, a lot of glycis, and it contains adrenaline, which gets absorbed. So you get hypertension, tachycardia, the ketamine and the glyco can also give you the same problems. Patients may have a resting tachycardia from their hypermetabolic state. And then I put my blood pressure cuff in the leg and it works 3 times. And next thing I see the surgeon's got the leg over his shoulder because he's taking some donor skin, and it really becomes difficult. So that's one area where I hope in future I will be better. One thing I think about quite a bit nowadays is I realize that patients, and even the children that we work with, are hypercoagulable based on fibrinogen, high levels of fibrinogen, platelet effects, low levels of anti-clotting factors, etc. So they are hypercoagulable, and they are more likely to actually get through a theatre session without needing clotting products. But do they or don't they? I don't know. This was done in children. Unfortunately, they didn't compare nothing to FFP. They compared a little bit of FFP to a lot of FFP, and they could show that there was no difference. Just of note, they didn't even use platelets because they were afraid of adverse effects and antigens and things. But I think what was more useful to me was this adult study where they did rotem. So it's full blood clotting testing, and that's much more useful than any INR or PTT or anything. And on that early first excisions, they had the patients in 2 groups. The one was do what you always do, and the other group was let's do a rotem analysis and then decide based on that whether this patient will need clotting factors, platelets, FFP, etc. None of the patients who were treated with a rotem analysis technique needed FFP or platelets, and only very few needed a fibrinogen. And to me, this feels a little bit more in keeping with what I see. In our unit, we very seldom use any FFP or platelets or clotting factors for that matter. So this is a big area that we need to research and find out whether we actually need clotting factors and how often we're going to need it. And then the other area that I want to learn more about is about the patient who visits the theatre for the first time, that first night they've just come in and they need to have ischorotomies and dressings, etc. Usually the patients that come up to theatre have had their initial resus and they're on their Parkland formula now and they are sort of stabilizing. But then as an anaesthetist, I give them anesthetic agents, and that drops your blood pressure and depresses your myocardial contractility. And the standard anesthetist's reaction to that is to bolus fluid. And I'm not sure whether we are causing harm with that, because we're doing something temporary with our drugs. We're managing it with extra fluid, and extra fluid we know can cause wound conversion and wound sepsis and all of those other bad effects. And then we're taking our temporary anesthetic agent away again. So there has been some research in ICU in terms of potentially using vasopressors earlier and rather holding back a little bit with fluid resuscitation. So that's going to be the other thing that I want to learn about. So maybe in 5 years or 10 years' time when I'm here again, I will want to have answers to give on this. Thank you very much.
Thank you so much, Dr. Baxter. Some really great highlights in burns anesthesia. I don't see any questions specifically from the audience. So I encourage members to interact on the live chat box in the live auditorium link. Thank you once again, Dr. Baxter. I think that brings a conclusion to this morning's sessions. We have run over time. We do apologize for that. I apologize for cutting into your lunch break. We will give this a 5-minute break and continue with the program just past 12:30. So I do apologize for taking away from the food break, but I think you can all agree with me that we've had lots of food for thought instead. So we'll have a 5-minute break and continue at 12:30. And just a reminder that there are also the breakout sessions as well, the nursing and allied sessions. The links are available from the main Congress link. See you in a few minutes. Good afternoon. Welcome back to the South African Burn Society Congress 2021. We're about to head into the afternoon session, but before we do so, just a quick word cloud once again. This time we'd like to ask you audience members to please share your job designation so we get an idea of the medical professionals that are attending. So if you can, please respond to the live within the live chat box in the main auditorium link, indicating your job profession, your job designation. We just see a lot of doctors, of course, naturally within the audience, 75% currently, up to 80% now, with physiotherapists up to 20%. I'm sure we do have lots of nurses, occupational therapists, speech therapists, and dietitians and others. So please do participate in the poll indicating your job designation. I see some dietitians have responded, but mostly dominant with doctors in the audience, over 80% of respondents being medical doctors, be it surgeons, including trauma, plastic surgery, ICU specialists, but we know that there are many healthcare and medical professionals within the field. So we'll keep that going, job designation poll going later on in the Congress. I believe our next speaker is ready, and our next speaker is Prof. Mayani Moeng. Prof. Moeng is a registered trauma surgeon and head of the trauma unit at Charlotte Maxeke Johannesburg Hospital. He's the chairman and academic head of trauma at WITS. He has both local, national, and international academic activities with a keen interest in critical care. Prof. Moeng is actively involved in critical care of closed ICU units at the Charlotte Maxeke Academic Hospital Trauma Unit and Mill Park Trauma Centers. As the chairman of the disaster committee at the hospital, he plays a major role in the organization and training for mass casualty incidents. The title of Prof. Moeng's talk is Albumin in Burns. Thank you, Prof.
Thank you very much for that introduction. I hope my voice is clear and I hope that my video is sharing very well. Can you see it clearly?
Yes, all good. Thank you.
All right. Much appreciated. What I'm going to try and do in the coming few minutes is just to indulge you on this issue relating to the role of albumin in severe burns. And I really appreciate all that has been said, and thank you to the organizers for a very lovely and a good meeting. But I think at this level, for most of us, we should be clear about where and what albumin is. We know it's a very, very significant protein in our system. We know it constitutes up to about 60% of the total proteins that we are aware of in terms of the system. And again, it is synthesized by the liver, carries a lot of roles and plays a major role in assisting and helping with a lot of proteins as well as other materials that are very important in terms of our homeostasis. We know that most of the calcium is bound to it in about 40%, but what is at the cornerstone of what we are discussing within the trauma and the burns is again its role and its ability to contribute positively towards the oncotic pressure, but that is known very, very well to all of us with a half-life of about 17 days. Over and above those physiological functions that I have highlighted, we are aware that again, it also plays a major role in terms as being a negative acute phase reactant. And having said that, it is not unusual for our burns patient within a critical care environment to actually end up with low albumins. And again, that has also been seen in other conditions, including where there is either decreased synthesis with chronic liver, whether there is issues with increased losses, where there are increased protein malabsorption conditions, and the story goes on and on. But I would like you, for the sake of this presentation, to realize that unfortunately, in most of our critically ill patients, in one way or the other, the more severe they are, the more critically ill they are, we will face some form of changes in the level of our albumin. Having said that, different preparations are available. And again, to keep at our mind that as we administer them, we need to remember, like any other drug, that there are associated side effects, as you can see depicted lower in that picture. So why the interest? Where is it coming from? And by the way, this human albumin was developed way long time ago in the 1940s. And up to today, there's still this issue about the controversies of when and when not to apply it. If you look back, one of the first prospective trials was in 1975. And even in these days where we are having a lot of science available, you really struggle to find robust, big studies that are looking at its role. And the issue about cost keeps coming back over and over in our population. But what is being at the center of the controversy is that does it fundamentally change the outcomes in those populations? And that's where the debates and the variables are going to do. And I just want to take you into that world a little bit later as we go on. Is hypoalbuminemia an issue in critically ill, including our Burns patients? Definitely. When you look at a whole cohort of those patients that are sick, in about 82% of the adults and sometimes 76% in children, we will find an albumin that's less than 25, by definition being low. Obviously, this creates concerns about issues around capillary leak. I've already mentioned other causes that can be looked into. And again, we have had different studies that have looked, and they had meta-analyzed about 290 subjects, 290,000 subjects. And out of that, one thing that they came up with is that it was quite clear that as we drop our albumin, the mortality increases by 137% increase for every 10 gram drop in that level of albumin. It is also clear that when the patient has got low albumin, we tend to realize increased mortality, increased morbidity, increased length of stay, as well as increased cost. And those are the issues that are said. But again, we are needing to figure out whether when we are administering albumin, does that change at all? So the current understanding and clear way of this rejuvenation and our thoughts around albumin have started a long time ago. If you look at the SAFE trial, which was an Australian, New Zealand's trial that was looking at the 4% albumin versus normal saline, all that they could say is that the people that were resuscitated with normal saline did not have worse mortality, did not have longer health length of stay, and they did not require renal replacement more than the other group that was there. But please be careful that in the sub-analysis, the patients with trauma, especially the ones with head injuries, tended to do worse compared to the other group. And again, this study did not include the Burns, but it was one of those issues that allowed us to start thinking about a solution that we can use within our resuscitation phase to try and see whether we have thrown away this drug that has been there for years. We have seen other studies that have come across as well. If you look at the Albio study as well, again, a prospective randomized trial, about 1,800 critically ill cases of the area, then they were using 20% albisol. And their aim was that, listen, if hypoalbuminemia is a problem, can we maintain our albumin above a certain threshold and see whether this makes a difference? So they were chasing against low albumin. And I'm afraid, again, the only issue was that there was quick resolution of the shock in this group of patients. However, there was no difference in the 28-day mortality, just less accumulated fluids. Again, asking, have we changed anything by altering the state in terms of albumin, or have we just become happy that our albumin level has normalized and has got to the level that is fine? People have asked around sepsis, which is very common in Burns again. And again, using albumin as a choice, it's again supported by some of the societies, as you see written there. but no direct specification in instruction, and people are left to use the albumin according to what they feel within their clinical roles. When they looked at that SAFE trial and they just looked at the patient with infection, they tended to have a little bit of a decreased ratio when you were separating them from the rest of the group. They tended to be a little bit of a trend and a decrease in ratio for death, but the ICU length of stay, the ventilation, the renal replacement therapy did not show any difference. And again, another one, which was the ERS study as well, also did not show any mortality difference when the albumin was used in this group to try and see if they can be able to resuscitate them with it and help to mitigate against patients with sepsis. What is guiding us in terms of possibly a role of Albisol or a role of albumin in our ICUs? When we're having that edematous patient, again, combining albumin with Lasix, again, if you look closely, these are smaller studies. They are not robust enough to make us change. And one of the things that we've experienced, all of us in our world now, is that there's been a greater trend to people paying more attention to the fluids that they are utilizing, even in the burn patient. And if you can manage your fluids better, there will be a less need to rescue your patient later with this combination of this care. But I want to take you through some of the trials just to make you aware of why we still have what we have here, then I'll conclude. If you look at it very clearly, this was again one of the oldest trials. It was a BJS trial years ago, but I want to highlight specifically on the burns. And if you look at the burns, the numbers were not so great. And again, they were looking at different sizes of albumin or different percentages of albumin. Let's look at what their conclusions were. When you look at this chart, on the left of the chart, or as you all know, that will mean it favors the drug that you're using. Whereas on the right side of the chart, it will be more towards a control. They did not. And even if you zoom closely to the burns group, in those studies, and by the way, these were old studies, they still questioned whether albumin really saved and changed the outcomes of these patients. And in this case, I'm emphasizing as well around the burns management. And what was their conclusion? Even though albumin has been there for years, even though it has been registered for emergency care, unfortunately, there was a relative risk of death that was increased in the albumin group, and therefore they didn't find that the utilization of this in the context of patients, and as I've shown you the few papers for burns, made any fundamental differences other than to assist with the issues of fluid management. Let's go to another trial now. This is a 2017 trial as well. And then in this way, what they were doing, it was actually a systematic review and meta-analysis. They actually, having excluded everything else, ended up with about four studies. And if you look very closely, some of these studies are repeated in the earlier BJS trials. So no wonder, and it's not surprising that when they plotted their chart, again, looking at those patients, things did not necessarily go in favor of artificial administration of Albisol in this group. And again, as much as it had that, one thing that was clear was that the fluid management was easier and they required less volume of fluid. However, and this is around specifically on the burns, there was no mortality benefit. And again, I just need to caution you about the number of cases that they've had. We look at another study as well, and this is a 2016 study, looking again at another meta-analysis. And interesting enough is that here they combined the randomized with a non-randomized trial. And again, it becomes a problem, even though there were bigger numbers in the non-randomized trial, it becomes a problem when you do meta-analysis with slightly different trials in your group. And again, what is our problem? Old studies that we are aware of. And if you look at it very, very clearly, that was a total number. It came about 700 or so of the patients that were ultimately put into their study. Then, when they looked at them, there were no big differences in some of the cases, and they looked at the numbers. But out of interest, now they started to weigh in and eliminate some things and work around the statistics. And suddenly, when they've done that, you seem to have a little bit of some benefit when it comes to mortality, including the early studies that were done. Looking at that, obviously, they show that their compartment syndrome as well as respiratory complications were a little bit less. But I want you to be careful because some of these patients were not randomized and there's an element for bias on it. So this, contrary to the other studies, was giving us a different issue. So albumin supplementation from where we stand, again, another study, this one was a study that looked at maintaining it above 20. And again, you can see the difference between patients that had albumin versus those that did not have albumin in blue, and the amount of administration of Albisol in those cases. And when they looked at it, the groups and the numbers were not huge. The volumes of fluid were a little bit less. But if you concentrate on the last picture, there was no major statistical differences in this subgroup. And what was interesting as well towards the end, again, was that in terms of the heading, as you can see, the label saying hypoalbuminemia supplementation is unnecessary and costly, irrespective of having similar groups, smaller groups though, but similar matched patients. They found that even though they had higher serum albumin by administering albumin, there was no significant result. And actually, this was a more expensive, and they were looking at a tricker of 20 grams for their administration and supplementation. Now, just to finalize, now moving a little bit towards the east, and this is in China. Again, another study that has come in, and if you look at it, the conclusion on that study, again, the administration of large amounts of albumin supplementation for correction of prolonged hypoalbuminemia in major burn patient had no significant benefit of mortality. So my slide, one but last slide, I think albumin solution, again, we are aware that internationally, if you look at this study, it was a study that was looking over the years, comparing 2007 and 2014. Yes, we are using less colloids in our ICUs, even more so in 2021. If there's a colloid that might have started to be used a little bit more, it's albumin. My request is that as we are moving towards the use of this medication, can we think clearly about whether it does benefit our patients? I'm going to finish with this as a conclusion, Mr. Chair, if you do not mind. Albumin, yes, is important for our physiology, and it's even more so in our critically ill. Major burn patients are also going to end up requiring that. But the albumin supplementation and chasing after it specifically remains controversial, and there has not been any major impact on mortality other than the benefits on fluid management. And I'm asking and I'm suggesting that we must still use it with caution if ever it is necessary, and possibly in fluid management, and a larger prospective multi-center trial needs to be done so that we can be able to say, this expensive medication, does it really alter outcomes in our burns patient? Thank you very much for your attention.
Thank you very much, Prof. Moeng. There is one quick question from Taryn. She says, thanks, Prof. What is the role of nutrition, EN and PN, and albumin?
Thank you very much. Let me just stop sharing. I think from our point of view, just to be clear, I was just addressing the use of Albisol supplementation. It is very critical to make sure that we feed our patients urgently. I mean, nutrition is not debatable in a burns patient. There's no doubt about it. It's important to make sure that we build the protein load in a proper way. And in this case, we are talking about a supplementation of nutrition, but not necessarily the IVI solution. So I agree with the question that has been asked that, yes, it's important to make sure that we supplement their feeds efficiently. And I think it's going to be covered even later on one of the dietitians' talk as well. Mine was this solution that we love so much these days. And the question is that, is there any evidence for it or not? Thank you very much.
Great. Thank you so much once again, Prof. Moeng. Our next speaker is Prof. Adelan Buganza. Prof. Prof. Adeline Muganza is the director of the burn unit at Chris Hani Baragwana Academic Hospital at the University of Witwatersrand in Johannesburg. He received his medical degree at the University of Kinshasa in 1988. He is a fellow of the Royal College of Surgeons in Ireland. He became a specialist surgeon at the University of Witwatersrand in 2003, a fellow of the College of Surgeons of South Africa, and fellow of the American College of Surgeons in 2016. He is an author of many publications related to thermal injury. He is a prominent national and international speaker. His special interest lies in the research of new technologies and skin substitutes for burn injuries. Prof. Muganza is the past president of the South African Burn Society, as indicated this morning, and is currently the secretary of the American College of Surgeons South African chapter. He also has extensive experience in intensive care management of severe burns. Prof. Muganza is one of the leaders in global surgery, focusing to improve surgical care in low-income countries. Thank you, Prof., and we look forward to your presentation. Prof, we can just ask you to unmute. I think you're still muted. Prof. Adeline, I think, yes, you are still muted. I think there should be, if you can minimize the window and come back to the studio tab, there should be the unmute option at the bottom of the screen. So I think if you exit your presentation mode for a second, unmute first, and then go back into the presentation mode. There we go.
All right. Okay. Can you see my presentation now?
We're just waiting for your presentation to show. If you can.
Do you have it now?
No. You need to share your presentation again from within the studio tab.
Okay, let me do it again. Sorry for this. Okay, I'm just putting it back again. Share. Can you see it now?
It's coming. Yes, I think you can just, perfect.
Okay, all right. Is it on a full presentation now? Eh?
Yes, please go ahead.
Can you hear me?
Yes, we can hear you. And the presentation is showing. Thank you. You're welcome to go ahead.
Thank you very much. Sorry for the inconvenience. And I would like again to congratulate the team as the past president of the South African Burn Society and the member of the society. I think they are doing a great job. COVID is inhalation injury due to a virus. I hope that I'll convince you. So when we heard for the first time that there is a disease called COVID, we were very concerned at the burn unit because of the surge in the intensive care admissions and especially the limited number of beds that we have. Again, the relocation of equipment. I can tell you that all our high flow oxygen were transferred to the non-COVID ward, including some personnel. And more we start hearing about the clinical presentation of COVID-19, and we just realized that there were many similarities with inhalation injuries that we've been treating for many, many years, even in the treatment. Just to refresh you quickly, the inhalation injury, closed space burns during explosion, potentially burn above the clavicles, and we know that it increased mortality up to 40%, in some situations even up to 70%. We know that during inhalation injuries, you'll get
Prof. Muganza, we seem to have lost you. You've frozen on our side. We're probably experiencing some network issues. Yes, unfortunately, we seem to have lost Prof. Adeline Muganza due to network issues. Unfortunately, yeah, technical difficulties with the current situation. Hopefully, we'll try to get Prof. Muganza back as soon as his network is back. We may go to Dr. Asma Salu in the meantime. I just want a confirmation from the studio that I should proceed with Dr. Asma Salu's presentation in the meantime. Thank you for your patience and bearing with us through these technical difficulties. Just quickly looking at the program, we've got Dr. Gareth Chasink scheduled to speak, as well as Dr. Asma Salu. I think we'll stick to the program then, and we'll continue with Dr. Gareth Chasink and taking that presentation. I'll introduce the speaker as Dr. Gareth loads the presentation. Dr. Gareth Chasink, after completing his matric at Dale College in the Eastern Cape, traveled abroad to the USA to begin his undergraduate pre-med degree. He then attended medical school at the University of Cape Town, completing his degree in 2005. Following this, he worked on the University of Witwatersrand Medical Circuit, completing 38 months as a general surgery registrar and 5 years as a plastic surgery registrar. Since then, he has run a burns unit in Leratong Hospital and Baragwanath Hospital, working closely with his mentor, Professor Russell Walton, in his cosmetic practice. Welcome, Dr. Gareth. If you are ready, please do share your presentation.
And it should be sharing already.
Perfect. We're just waiting for your presentation to come up. It's not showing up on the studio just yet.
Okay, let me try again.
Would you like us to share the presentation from our end?
No, I've made some changes. So let me just quickly see why this is not coming up. I've lost you completely. I've got no access to any bar.
Okay. If you go into the studio window, and the share button should be visible at the bottom.
So I've done that. It says it's sharing. StreamYard is sharing your screen. Have you got it?
Okay. I've got a heads up that it is sharing.
Okay, I'm going to go through to the slideshow then. Can you see my full slideshow? And the way the Google Drive is working, it won't show me any comments. I've only got a full screen ahead of me.
It's perfect. We can see your presentation. Thank you. Please do go ahead.
Great. So my discussion today is discussing EPO in burns from an anecdotal observation in our unit. Working with Prof. Muganza at Baragwanath unit, we end up having quite significant and extensive burn injuries, as you can imagine. And now with the gym closed, we're getting quite a lot of varied types of burns. We made an anecdotal observation of a patient that was using EPO, and I'm going to go through a little bit of information about that. So EPO is a glycoprotein. It's a pluripotent molecule. It's expressed in the kidney, a couple of other tissues in response to hypoxia, and it regulates erythropoiesis. Its additional tissue effects are noted in nitric oxide mediation. It relaxes the arterial vessels. It produces angiogenesis, and it inhibits apoptic cell death. And there's significant tissue regeneration with this molecule. The patient was a 36-year-old male. He was a Jehovah's Witness, and that's why we were using EPO in him. And he had flame burns to his head, neck, and chest, approximately 25%, and they were full to partial thickness, requiring escherotomies, as the tissue was so significantly burnt. And he had one debridement, which resulted in his HB sitting at around about 6. And because his HB was so low, we were limited in any potential further surgical procedures. We were forced to delay his skin grafts, and his HB didn't rise. So we chatted to his representatives with the Jehovah's Witness group and started him on hematinics and EPO. 2 weeks anecdotally, we noticed that there was better than expected wound healing. And by one month, we noticed there was approximately only about 5% of his full thickness burns left, and all other wounds had epithelialized. And this raised this question, why did he heal so well and effectively compared to a parallel patient that was lying in the ICU cubicle next to him with almost identical burns and almost identical percentage? So this is a picture of the patient the first week of admission. So you can see there's full thickness burns on this patient. I'm not exaggerating, and they're only partial thickness. He had slough, full thickness, and on the right arm he had an escherotomy, and on the left arm. This was him in his third week of admission. 5th week, and this was in between his 6th and 7th weeks of admission. So I did a little bit of literature review on the patients with the EPO, what EPO effects have on burns, and there is some literature out there, but it's very conflicting. So I'm going to look at 2 different articles just to discuss it with you, and then to ask if there are any people that have advice or questions, and then also just to raise the idea that maybe we should be looking at doing a little bit of research further in this field. So the first paper was a randomized controlled trial, a regenerative effects, efficacy, and safety of EPO in burns and scalding injuries done in Germany. It was done over 13 specialized burn units. It was a prospective placebo-controlled randomized double-blind trial. And they wanted to see if there was improved wound healing, reduced morbidity and mortality in patients that had 2nd and 3rd degree burns. So the medication that they used was EPO, 150 international units per kg, or a matched placebo, and they used it alternative daily, subcutaneously for a maximum of 21 days. They had 116 patients in their trial, and 84 received study medication, 45 EPO and 39 placebo. They did a sub-analysis of the completely reepithelialized sites on day 6, 10, 12, and 14, and 16. And then they did a review of these different sites. And they found that the reepithelialized study sites in the EPO group at day 6 and 10 were much improved, but that this improvement decreased by about day 12. So the primary endpoint analysis revealed inconclusive results, because only very few of the patients were completely reepithelialized 100% by that time, with a 23% versus a 30%. But they said this was statistically insignificant. So there were several secondary endpoints that they looked at. They looked at the SOFA score, which was their morbidity, and EPO level in the blood, and wound healing onset. And they found that clinical and statistical significant results in favor of the EPO group. The results of the SOFA score indicated a lower morbidity of the EPO group, suggesting higher progenitive effects, and there were higher EPO levels might influence this faster onset of reepithelialization in the first 10 days of treatment. And they said both of these different points could reveal new therapeutic options for us. And they did a little bit of literature review regarding the EPO effects, and there's a discrepancy that exists between very promising results from preclinical investigations in 2008 by Bryans and Seremi and the results of the clinical investigation by Lundy et al. In 2010. So this paradox relates probably to the different timing and dosing regimens that were used in these studies. The dosage of EPO used in the preclinical studies was frequently supraphysiological, and therefore the described EPO effects could not be repeated in the lower doses used in the clinical trials that Jelkman used. So in animal studies, they found that the EPO application was often very close time frame to the actual trauma, which might be why their results were so good. So regarding the more detailed analysis in the study, the wound healing over time, they observed that the reepithelialization group at day 6, 10, and 12, but this benefit ended by about day 12. And the publication of rodent models describe a faster onset of reepithelialization in an EPO group, with impairment of wound healing after repetitive EPO applications. So there was almost an inhibitory effect if used extensively. So they compared the wound healing over time with EPO levels. They said there was a fast onset of wound healing that was observed with correspondence to high EPO levels in the first 7 days. So I went and looked for this animal trial article, and I found it. And this erythropoietin prevention of experimental burn progression. So it's a well-designed study, and they're looking at trying to decrease the burn zones, and we know the burn zones quite well. And they were trying to investigate whether the systemic erythropoietin use administration could prevent secondary burn progression in an experimental model. So they used the burn comb model, which they put 4 rectangular burn surfaces interspersed with 3 unburned surfaces to allow progression from those unburned sites. And they used 21 Worcester rats, which were in a randomized control group, to receive intraperitoneal EPO at 500 units, which is quite supraphysiological, once a day for 5 days, starting at 45 minutes after the burn, or at 6 hours after the burn. Now, realistically, in our situation, this timing and the benefit so close to the burn in a setup clinically is not really realistic. But it's a good indication to show what benefit you can get from administering EPO, and then we can look at the mechanisms of how it works. But EPO in this group, they used the recombinant human EPO, and it was mixed in a certain way, and then they used 500 units per kg of EPO intraperitoneally. They freshly prepared the solution, and they kept it at about 8 degrees and 45 to 60 minutes until they used it. They then looked at the histological analysis of the burn to see what the inflammation and neoangiogenesis looked like, and then they did a planimetric evaluation of the wound progression, and then they did laser Doppler flowmetry to assess the perfusion. And they all performed these on day 1, 4, and 7, and then once a week they did a scar contracture assessment. So the burn progression was significantly decreased in the EPO 45 group but not in the EPO 6 group. So in 45 minutes, the burn progression showed that the mean burn depth score was 3.3 versus a 4.7 burn depth in the EPO 6 and a 7 burn depth in the placebo trial. So this was paralleled by faster reepithelialization of the perfusion in the EPO 45, and then the reduction in progression resulted in decreased healing time. So this shows quite promising results. If we have a look at EPO and we think about the potential benefits of it as an addendum to significant burn injuries, or even if we looked at it as a treatment protocol for admission patients for a short period of time, although cost is prohibitive, there is a mechanism of action here that we need to investigate. There's also interesting that pramabolone, which is a white cell progenitor treatment, has been shown to benefit wound and burns treatment. So, and this is a red cell progenitor. So we should actually look and see whether these two, what mechanism of action these have, and how we can try and facilitate or use them going forward in these significant burn injuries. Thanks very much.
Thank you so much, Dr. Gareth Chesink. I believe there's one question from the audience, from Dr. Ronelle Parkhurst, asking, is it available in state yet?
So currently, I do have access to it in state, and we order it from pharmacy. I have spoken to pharmacy about it at Baragwanath, but there is a little bit of resistance of us using it without significant clinical trials. So the answer to that currently is no. We don't have it available to use at our discretion, but hopefully we can look at setting up support sort of protocol in the future where we can do a little bit more of a study. So if anyone has any suggestions, I think we should look at it.
Great. Thank you, Dr. Gareth. I don't see any further questions. Yeah, thank you once again for the presentation. And I think there are some engagements and interactions in the live chat box on the main auditorium link of the Congress. Thank you once again for the presentation. So I believe we'll be going back to Prof. Muganza, unfortunately, who had some network issues a few minutes ago. And we, in the meantime, kept rolling with the program. So we will now try and go back to Prof. Adeline Muganza to complete the presentation that you started earlier. Welcome back, Prof.
Thank you. Do you have my presentation again? I'm sorry, we had the load shedding.
Yes, your presentation is visible. Thank you.
Okay, I'm not sure how far I went, but what I was saying is COVID is inhalation injury due to a virus. So I was saying that we're very concerned that when we heard about the COVID, there were few dedicated burn centers and the surge in the intensive care admissions, that the resources constraints, we had to relocate many of our equipment to the no-COVID, like the high flow oxygen and some of the personnel. And the more we hear about the COVID, we found that there were many similarities with inhalation injury and COVID-19. And just to remind you about the inhalation injury, we said that it can happen in a closed space when there is explosion and potentially burns above the clavicles, and that can increase mortality up to 40%, in some patients up to 70%, especially if they're elderly. Then we know that during inhalation injury, you get debris of necrosis and inflammatory exudate, bronchospasm. Most important, during inhalation injury, you have damage to the alveolar capillary membranes that can lead to severe ventilation perfusion mismatch and hypoxia. Then we know that during inhalation injury, it's not only about the lungs which is affected. We can have activation of the body inflammatory response and the direct tissue injury. That activation of body inflammatory response can actually lead to multi-organ dysfunction. And many of the smoke products that we know can actually reduce the oxygen carrying capacity and can be neurotoxic, and some of the products can even be can lead to cardiac dysfunction. And we've seen patients with severe metabolic acidosis with a high lactate just because of smoke injury. Then what we found, if we compare the two, inhalation injury and COVID, we noticed that both can increase actually the major inflammatory response, not only to the lungs, but to the whole body. And that can lead as well to other organ dysfunction, but mainly the respiratory failure. And these patients, if they stay longer in the ICU, they end up by having immunosuppression. And the most important is the sepsis that you see in COVID, and we do see it as well in a patient with inhalation injury. And this is just a picture I got from someone where you found the inhalation injury actually this COVID can affect all different organs, mainly the lungs. And if you look at this chest X-ray today, someone would say this is COVID until proven otherwise, but it's not COVID. This is a patient with inhalation injury. And we know even in inhalation injury, in the first 24, 36 hours, the chest X-ray can be normal. We can see some atelectasis, but with time, then we start to see signs like ARDS or pneumonia. And that's what we see as well with inhalation injury. And most important, those who did CT scan for patient with inhalation injury, in the first 24 hours, a few hours after the injury, they found some damage to the lungs, which you can't see on a normal chest X-ray. And that has been described as well for COVID-19, as you know, that CT scan will give you earlier findings. Now, if we leave the two patients, majority of these patients will clear, which means that the lungs will be fine without any intervention sometimes. And few of these patients will go into respiratory failure due to pneumonia, and some of patients due to ARDS. And those patients who develop pneumonia is not only what we see in COVID, but mainly as well in inhalation injury. You are aware that today people are talking about pulmonary fibrosis. pulmonary fibrosis as a complication for COVID-19, but we knew that for many, many years that patient with inhalation injury, they end up sometimes by having pulmonary fibrosis, especially in elderly and patients who had the issue of smoking and lung disease in the past. I'm not going into details of this, but just to tell you that the way we're treating patients with who are ventilated with COVID-19, it's exactly the way we do with patient with inhalation injury, low tidal volume, high PEEP, sometimes patient on high flow and CPAP. So what is quite different between the two management? In burns, we are very aggressive in terms of inhalation injury. We start with invasive ventilation. And then if patient gets better, then we go to non-invasive CPAP, high flow, oxygen mask, and nasal cannula. But in COVID, as you know, today we've changed our mind. So we're not anymore aggressive in terms of ventilation because these patients don't do well. So we start with a nasal cannula, oxygen mask, and so on. But the tools are almost the same. Just before I finish, this patient, 35-year-old, presented with inhalation injury, obese. She was intubated and ventilated. Unfortunately, she was extubated by mistake in the medical ward after 24 hours, but she was COVID positive, as you can see, and transferred to us. So when you look at the nebulization, what we have for nebulization, almost the same thing that we're using for inhalation injury. And heparin nebulization has been used for many, many years. It's not something new that we're using in COVID. There are many papers in burns where heparin has been used for inhalation injury. So this patient was excised and had a skin graft, and patient did well. So in summary, Mr. Chairman, I would like just to say that I'm convinced that COVID-19 is inhalation injury due to a virus. Thank you very much.
Thank you so much, Prof. Muganza. I think you have convinced the audience that COVID-19 is inhalation injury due to a virus. I don't see any comments to the contradictory. Thank you so much for the presentation, and thanks for your patience through the network issues.
Thank you.
We'll continue with the next presentation, which is by Dr. Asma Salu. Dr. Salu is a pediatric intensivist currently working at the Red Cross War Memorial Children's Hospital in Cape Town. She recently moved from Chris Hani Baragwanath Academic Hospital in Soweto, where she worked in the pediatric ICU for almost 10 years. In addition to her pediatric critical care training, she completed a fellowship in ECMO, ECLS, at the Hospital for Sick Children in Toronto. With clinical work, Asma also has a keen interest in medical education and is an instructor on the Advanced Pediatric Life Support and Pediatric Basic Assessment and Support in Intensive Care courses. She is also passionate about improving general medical and critical care for all children. Pediatric pain is one of many topics that she has a keen interest in. Dr. Salu has a special interest in humanitarian aid and has been on a number of national and international relief missions as part of Gift of the Givers medical team, a local NGO involved in disaster relief. The title of Dr. Asma Salu's talk is Acute Pain Management in Burns.
Good afternoon, everyone. My name is Asma Salu. I'm a pediatric intensivist at Red Cross Hospital in Cape Town, and I'm going to talk today about pain management in pediatric burns patients. Burn pain is severe, and the sequelae and adverse effects are well recognized, yet good pain control remains inadequate globally. Rather than being a recipe or a guideline, my talk will focus on the physiology of pain and pain pathways in burns patients, and these principles apply to both adults and children. I'll then focus on why children are more vulnerable to painful experiences, followed by a brief amount about the paradigms of pain, and then we'll end with a very brief mention of treatment options. And that's usually what everyone wants to know about. But after understanding the background and principles of pain, one will be able to make much easier choices and decisions about therapeutic options. Pain is perceived at the time and site of the burn by local nociceptors, and through transduction, this action potential signal is transmitted to the spinal cord. Once transmitted via the afferent nerve through the spinal cord, this pain response is modulated in the spinal cord, brainstem, and midbrain before it reaches the cortical areas of the brain where pain perception takes place. This pain perception and processing is also influenced by the higher functions, and then via the efferent system, a response is formulated to the pain, and one removes one's finger from the flame. With acute traumatic injury, like in a burn or ongoing pain, which is classic in burn injury as the skin remains denuded and there's persistence of acute pain, what happens is one has peripheral sensitization that happens, which is then via neurohormonal responses translated into this effect called primary hyperalgesia. Primary hyperalgesia is a state that has enhanced sensitivity and responsiveness to noxious stimuli, and this is manifested as increased wound sensitivity or prolonged discomfort. With continued pain, peripheral sensitization leads to central sensitization, which in turn leads to secondary hyperalgesia, which refers to delayed alterations and feelings of noxious sensitivity in the surrounding uninjured tissues. This usually leads to increased incident pain, splinting, and prolonged disability, as well as exaggerated pain responses, which usually manifest as paresthesia, hyperesthesia, and difficulty and reluctance to engage in rehabilitative activities. With persistence of these noxious stimuli, there's neural and glial remodeling, which leads to long-term plasticity, which then results in chronic pain. And with chronic pain, there's also neuropathic pain, which is essentially pain that is as a result of plasticity or this structured remodeling. And because of this pathway, one can understand why there's a large neuropathic component to burn pain. No talk about children is complete without the reminder that children are not small adults and are definitely not one big homogeneous group. With different ages, stages, developmental levels, and situations, analgesic needs vary, and it's important to understand all of these variations so that one can provide good analgesia to all of these patients at different stages of their lives. Good pain control is necessary for more than just humane reasons. The consequences of poor pain control are long-lasting and dire. If we look at neonates and infants who have been exposed to early life pain, there's immediate impacts and long-term impacts. Usually in the immediate phase, there's increased excitability, release of cytokines, which are then followed by anti-inflammatory responses and endorphin release from the periaqueductal gray matter, and these result in hypoalgesic pain responses. So in the immediate phase, these patients often have a hyposensitive response to pain or a very blunted response to pain. But with continued pain and persistence of pro-inflammatory cytokines, this then becomes a very hyperalgesic response, and it's quite a discoordinated, dysfunctional response that happens quite early on in life. And together with neural hormonal responses and remodeling, this actually results in altered brain morphology, and there's been a number of studies that actually show this. There's reduction in gray and white matter volumes, and these reductions persist into infancy, childhood, and adolescence. It's also associated with abnormalities in cortical thickness and decreased regional volumes of the brain, like the cerebellum, thalamus, and cerebral cortex. And as you can see in this picture, there's the dotted area, which is the normal thalamic size, on an MRI with the spectral imaging that's superimposed, and you can see that the functional area of the thalamus is much smaller than the actual thalamic area. They also present with axonal disturbances and significant volumetric reductions in the different motor and sensory areas of the brain. These alterations in morphology also manifest as changes in cognition and behavior. In terms of neurobehavioral and emotional responses, patients can often present with pain catastrophizing behaviors or internalizing behaviors, where children present as very anxious, depressed, and fearful. It also affects their cognition and attention, and these patients often present with lower IQs compared to their peers, and also have visual perception issues and difficulties with problem solving and solving of puzzles, and they also have gross motor and fine motor delays. So when we're faced with a burnt child, one is not sure of their early life pain experiences, and now with their current pain experience, our role is to provide the best and the most optimal analgesic experience so that we can prevent these adverse responses from happening, because these persist right into adulthood. If we look at the consequences of inadequately managed pain, these happen on a physiological, psychological, and at a socioeconomic level, and manifest in a variety of different ways, like increased stress responses that we know about, immunosuppression, delayed wound healing, thromboembolic events, and chronic pain. Whereas on a psychological point of view, they present with fear, irritability, impaired emotional bonding in children, which has lasting consequences into adulthood, as well as anxiety, depression, and PTSD. There's also socioeconomic consequences like decreased quality of care, decreased patient and parental satisfaction, as well as increased cost and morbidity. And the impact on healthcare workers is often underreported, where with chronic exposure to patients who have poorly managed pain and very fussy, anxious, irritable patients, healthcare workers often sadly become desensitized and uncaring, and this leads to a high rate of burnout amongst healthcare workers who are caring for burned patients. A number of different factors affects a child's perception of pain, and it's important to understand these different factors so that we can provide holistic pain management. Some of the predisposing factors are genetics, early pain exposure, maternal substance abuse, and personality types, and even young neonates can have different personality types. In terms of the context of the pain, its expectations associated with this, the patient's culture, their past experiences, the environment, both the environment which they come from and the current environment they're exposed to within the hospital setting, and their rapport and relationship with staff, all of these affect their perception of the pain. In terms of cognition, their attention level, whether they're distractible, their self-belief and reappraisal also affects their perception of pain. And then mood, obviously, if there's underlying depression or anxiety and catastrophizing behaviors associated with this pain response, it's going to have a greater impact as well. In terms of the burn wound, often people, or it was thought that the deeper burn wound and with the loss of nerve endings, pain is less. This doesn't always hold true, and the pain response is very variable. And things like the type of dressing, the tension of the dressing, all impact on this pain response. The presence of infection also enhances the pain response, movement as well. And then donor sites, actually, because of the level at which the skin is cut, usually have quite a significant pain response. And then in terms of drug factors, the timing of analgesia, being able to tailor the analgesia to the different needs of the patient, and we'll talk more about that when we look at the paradigms of pain, and then obviously the side effect profile of these drugs. It's important to remember all of these factors when we're dealing with patients with burns pain, so that we can provide good holistic care. I'm very passionate about using scoring systems about assessing pain, and most doctors would never dream about treating a patient with hypertension without actually measuring a blood pressure, but it's always amazing to see how people happily thumbsuck analgesic options for patients without any measure. And there are tools and scales available, so if there's anything that you take home from this lecture is that please use pain scores and pain scales, firstly to assess the level of pain and then to assess the response to pain. And often healthcare workers, nursing staff, doctors change shift, and there's no way of being able to objectively assess pain unless we use these scales. And there's a variety of scales available, as you can see in the picture, and I'm sure some of you are familiar with the different Wong-Baker scales or the numerical scale. One that's very useful is on the right hand corner of the slide, the FLAC scale, and that can be used from early infancy and neonatal life right up to adulthood, and there's even adult pain scales which I've pasted there. So these are available, and it's important that we utilize them. So if we look at the different paradigms of pain, and it's important to understand these paradigms because it helps us to guide the use of analgesics for the different phases of pain. So the first one is background or continuing pain, and this is the pain that's present at rest. It's usually as a result of the thermal injury itself, and it may persist for days to weeks following the burn. Breakthrough or acute pain is spikes of pain that happen probably related to medication running out or infectious causes or related to anxiety, whereas neuropathic pain is more of a chronic process that happens because of this plasticity with the damaged nerve endings and regeneration happening, and this type of pain usually lasts for months to years following the burn injury. And then procedural pain in terms of debridement, dressing changes, mobilization, and that's different from post-operative pain, where during the procedure or operation, these patients would have a general anesthetic, so their pain needs are often taken care of during the procedure, but post-operatively, they have this predictable, very temporary increase following, for example, excision of a burn wound or grafting and pain at the donor sites, and this type of pain persists for between 2 to 5 days following this operative period, and it's important to take into account and adapt the analgesic needs peri-procedurally. Then in terms of rehabilitation, obviously that comes with its own set of pain in terms of mobilization, and then in terms of anxiety, apprehension, and depression, one needs to understand how it contributes to the whole paradigm of pain. And then in terms of adjunctive things like itching and being able to treat those discomforts, which can also contribute to pain in a burnt patient. One of the challenges for physicians is that the burn pain is constantly evolving. There's lots of variability in the pain, even in the same patient in different contexts, whether when the patient's sleeping or at rest, whether with a dressing change or peri-procedurally. We need to try and tailor all of our pain and analgesic targets towards trying to deal with this constant variability. There's also alterations in pharmacokinetics, and drug handling is altered with these massive fluid shifts that happen in burns patients, also the changing volume of distribution, as well as augmented renal clearance in these patients. Also, over time, the patient's psychological needs evolve. There's repeated infliction of pain with dressing changes and rehabilitation, and so we need to tailor our analgesic response to this. Opioids, which end up being the mainstay of treatment and utilized for long periods of time, you end up developing tolerance, and opioids also contribute to hyperalgesic responses, so it's often important to take that into account. Pain management is a team effort. It's everyone's responsibility to make sure that there's adequate and optimal analgesia provided. We can do a whole talk on non-pharmacological measures, but it's important to always take them into account. And then if we quickly touch on the pharmacological options during the different paradigms of pain, opioid infusions, PCAs, and oral medications are good for controlling background pain, whereas IV opioid boluses, non-steroidals, and paracetamol are useful for breakthrough acute pain episodes. Your anti-epileptics like gabapentin and your tricyclic antidepressants are useful for neuropathic pain, whereas procedural pain usually requires a general anesthetic or drugs like ketamine or Presidex. And it's important to add good cover for your post-operative pain, like we've mentioned, in the form of long-acting opioids like methadone, or you can add non-steroidals or PCAs during this period. And then in terms of rehabilitation, benzodiazepines can be quite useful in terms of assisting with muscle spasm and anxiety. And then anxiolysis. Benzodiazepines also help with anxiety, and then obviously if there's depression, SSRIs can be useful. And then in terms of itching and other adjunctive therapies, the antihistamines are quite useful, like Phenergan, Allergex, and ondansetron is also quite a useful drug that can help with that. So in summary, as healthcare workers looking after burns patients, we must have a good understanding and awareness of the pain needs in pediatric burns patients. We need to be able to adequately classify and evaluate the pain. Pain assessment tools are paramount, together with providing non-pharmacological measures before actually providing optimal medication, and doing this while taking into account the different pain paradigms so that we can provide the best and most optimal analgesic response to our patients. Thank you very much for listening.
Thank you so much, Dr. Asma Salu, for an extensive presentation on acute pain management in burns. I don't see any questions from the audience at the moment. Once again, encourage all members to please interact in the live chat box in the main conference link in the auditorium. Thank you once again, Dr. Salu. Our next speaker is Dr. Alexandra Schulz. I believe Dr. Schulz is joining us from Munich in Germany. Dr. Alexandra has extensive working experience in human medicine, currently with a private practice for plastic surgery and aesthetic medicine. She also does medical consulting, training, and workshops, is a private lecturer in plastic surgery and a reviewer of scientific journals. She's also been a senior medical expert, senior physician in plastic surgery, amongst other various working experiences. As I continue to introduce Dr. Alexandra, can I just ask you to please unmute yourself, Dr. Alexandra. I think you've gone in presentation mode, so you'll need to exit that, unmute, and then go back into presentation mode, please. Whilst Dr. Schulz is doing that, I'll continue the introduction. Thank you. Dr. Alexandra Schulz also has extensive working experience in business administration. Her education experience in both human medicine and business administration is quite extensive. So is her publication list much too long and lengthy to present in this session. I would like to welcome you, Dr. Schulz. The title of the presentation being Improvement of Scar Quality After Enzymatic Debridement versus Traditional Surgical Debridement in Facial Burn Injury. Thank you so much. Please do share your presentation.
Thank you so much for the introduction. I'm very happy to be able to present at this conference today. I'm a big fan of South Africa, I just have to say that. And yeah, this is my topic. I would like to guide you through enzymatic debridement with a special focus on facial burns. So this is me. As the introduction said already, I'm a board-certified plastic surgeon in Germany. This is my private email address. I would kindly ask you not to take any pictures or not to record my presentation, but if you have any questions, don't hesitate to send me email to my private email address. And in the end, I will share a literature list with you of all the publications that I published to this topic. And I can also send them to you, no problem. First of all, I have to mention that I do have a conflict of interest with this topic because, yeah, this is me with a pineapple in my hands. The company company that produces the product, which I will present, is called MediWound. It's an Israeli company, and the product is called Nexobrid. And I did a lot of research on this topic, and I was supported by the company during this research. And I also did my junior professorship, my habilitation called in Germany in this topic. So yeah, this is my conflict of interest, I think I have to mention. And I would like to start with an African citation, which I like a lot. It says, if you want to go fast, go alone, but if you want to go far, go with others together. So these are my friends from my hospital. It's the Cologne Meerheim Hospital. It's in Western Germany, and I had a big team of doctors and nurses that supported me in my research. And without all of them, it would not have been possible for me to do that, right? So I think I have to mention that. And we did our research between 2011 and 2018 together, exactly at this hospital. This is the Meerheim Cologne Medical Center, Western Germany. It's a huge public hospital with a huge department of plastic surgery, and we had one of Germany's largest burn centers, which offers 12 beds to severe burned patients. Okay, so my topic today is debridement of facial burn scars. So this is the problem. These are two patients which were treated at our hospital before I started with my research, and I had a look at these facial burns, which prevent these people. We all know that, to have a normal social interaction after their injury, to go back to their work. And we know that most of them are super unhappy with their burn scars. And where are they more obvious than in their faces, right? So we all try to work on preventing these burn scars. And how is it? When do these burn scars start? They start with debridement. And this is why we tried to find a way to do a very selective debridement. And this was our result after 200 treatments with enzymatic debridement. So we could improve facial scars and scars all over the body clearly. We published in hands and genital burns, for example. And yeah, I think this is a clear improvement. It is quite easy to use, and it is very easy to achieve it. And therefore, I would like to guide you through the process. So as I said, the problem is selectivity of debriding the burn wound, right? Because the ground of the burn wound is not flat and even, it is uneven. And there are a lot of studies, including these studies of Garfunkel and friends, and they could show that in 154 biopsies, more than 40% of vital tissue was found in the scar debrided either by tangential excision with a VEC knife or with a Versajet, right? So selectivity is our problem. How can we remove solely the burn scar and remain all the vital tissue untouched? And interesting enough, the first right steps in this direction already happened in 1943 during the World War, when the US military started the Subcommittee of Infected Wounds. They had another goal. Their goal was to be able to treat all the burn victims which came to their places without bringing them all to the OR and without doing surgeries on all of them. So what they were looking for is an agent which you can apply on the burn wound and which dissolves the burnt scar efficiently. And they had a look at different substances from plants, from bacteria, from animal, from acid origin. And one of them was sufficient. It was bromelain from pineapples. And Gary Klein picked up this topic and he submitted this publication. He worked as a physician in 1965 at the Children's Hospital in Washington. And he found that bromelain in pigs is very efficient to dissolving the burn scar, though he needed 3 times, so 3 treatments, and each treatment took around 2 hours. Unfortunately, this only worked very sufficient in pigs and not in humans. So in humans, it was only around 50% efficient. But at least one surgeon was very impressed by this development, and his name is Leo Rosenberg. He is a burn surgeon from Israel, and he bought the patent from Klein these days and started to work on it during the next decades. And finally, in 2012, he introduced a product in the European market called Nexobrid. And this is a mixture of proteolytic enzymes. It's a secret recipe, more or less, but all of the substances come from the pineapple stem. And here you can see the product. And this is how the burn wound looks like after debridement. And the whole debridement process takes around 4 hours. So let me quickly guide you through the process. It's very easy. Here we see a burn phase, right? At admission, we evaluated the burn depth, right? Like 2nd B degree, perhaps 3 degree, a third, so full thickness burn degrees somewhere. And yeah, so we just mix 2 substances together, and then we apply a gel on the burn wound. And we cover it with a film, with a opaque film, and leave it on the wound for 4 hours. So this patient is intubated during the process, but we also do it in analgesic sedation, and with some patients also with a regional block or with local anesthesia, it's possible as well. Then we divide the burn wound in different areas. And as you see here in the middle, this is how the burn wound looks after removed the dressing. You see the whitish dermis, and you see red bleeding spots, right? This is quite unusual, this picture. We are not used to that from Versajet. But yeah, very, very selective debridement. And this is how it should look like. And then we clean the wound and apply a Supratil, which is a dressing which keeps the burn wound moist. You could also choose different dressings, but the burn wound has to be kept moist because the healing time will take around 2 to 3 weeks. And this is the patient after 2 weeks. You see, when we change the dressing, just some areas left. So selectivity of the enzymatic debridement really works with our proteolytic enzyme mixture. And this is a proof for this. You see an arm tattooed and selective debridement performed. And when we remove the bandage, you can see that some of the pigment is taken from the depth of the burn wound, though the majority of the tattoo is still intact. So the selectivity of the debridement is really, really interesting and impressive. And this is how a hand, for example, looks after debridement. It is interesting that the debridement is so selective that we have different burn depths very close to each other. And what we do now is having a very close evaluation with the whole team after the debridement process. And the only areas that we still would go for skin transplantations are these areas that are 2nd B to full thickness burned, right? Like this red surrounded area. And the rest, we would cover it with a dressing which keeps the burn wound moist and wait for spontaneous healing. So by the whole process, we can minimize the areas that have to be treated by skin transplantation, and by that, of course, we get a better scar outcome. And these were the first 20 patients. So we had a look very closely and saved all the data in a database for the first 20 patients that we treated in our department, because we wanted to know how easy is it to pick up this kind of treatment. And it was quite easy. So also in the first 20 patients, we were quite successful. We had a look and we found that the majority of the patients, 95%, could be debrided efficiently only by the first debridement. And we could treat them at the day after the admission to the hospital. So we don't have to wait for OR capacity anymore, which is limiting our treatment sometimes. This is quite easy, and that was our standard procedure. And we found that 70% of all the wounds could heal completely spontaneously, which was interesting as well. But yeah, we saved so much vital tissue, right? And how did we treat these patients? So where did we treat them? Because what is limiting our capacity of treating patients is OR capacity. So we don't have so much OR capacity, right? Because we have a lot of patients. So we are interested in treating patients apart from the operation room. And this is what is possible with this kind of enzymatic debridement. The majority of the patients were treated bedside or in the intervention room at the intensive care burn unit. So patients were treated under plexus, regional or local anesthesia, or under analgesic sedation. And only when they showed additional injuries which needed to be treated in the central operation room, then we took them to the central operation room. And we asked patients for their satisfaction pain-wise with our treatments and compared them to other patients. And this is what we published as well in Burns. Just one thing that I would like to mention before I show you pictures is that it is not recommended to use any kind of silver-containing treatments before the enzymatic debridement, like flamazine. This is a solution which is very, very popular in Europe, so we like to put that on any kind of burn wound, but unfortunately it contains silver ions, and silver ions will inhibit the capacity of the enzymatic debridement. So don't treat the burn wounds before the enzymatic debridement something, just apply disinfectant solution on the burn wound. We, for example, use either octinisept or Prontosan, and that works perfectly. Let's come to the facial burns. We published our study in the journal Burns in 2017, which compared 13 patients with enzymatic debridement to 13 patients treated with surgical debridement. And yeah, this is how our study was made up. And all our patients were between 18 and 78 years. And there was no statistical difference between the area that was treated in the study, between the enzymatic group and the surgical debrided group.
Hi, we seem to have lost Dr. Alexandra Schulz. I think some more network difficulties at this point. Dr. Schulz, you seem to be frozen. So I think, yeah, as soon as the network connection returns, we'll hopefully rejoin with Dr. Alexandra Schulz. We've completely lost her connection at this point, unfortunately. We also did have a few questions, but I will, of course, wait for to try and get Dr. Alexandra back before we take those. Perhaps I can read some comments from the live chat box in the meantime. Teboho notes, this is so amazing, Dr. Alexandra. Ronel asks is Nexobrib available in South Africa? And hopefully we'll get Dr. Alexandra to respond to that question as soon as she rejoins. I note that Dr. Dos Passos replies to Dr. Ronel's question by saying not when he last checked, about a year ago. We'll wait to hear more from the speaker herself. I think we're trying to just then get the next speaker, and this will be Professor Jacques Goosen, who we moved from earlier in the program. So Professor Jacques Goosen will be sharing his presentation at this point. While I think, Professor Goosen, if you can please share your screen in the meantime, hopefully we can set up your presentation to keep going while we've just lost connection with the previous speaker from Germany. I think we're just waiting for Prof. Goosen to share his screen. In the meantime, let me introduce the speaker. Professor Jacques Goosen is a general surgeon with subspecialty in trauma surgery and intensive care at Netcare Union Hospital, a South African level 1 trauma center. Prof. Goosen's special interests include trauma critical care and burn injury. For many years, Prof. Goosen was a professor in the trauma unit at the University of the Witwatersrand. Professor Goosen, if you can please share your presentation from the studio tab, and I'm sure I'll get an indication as soon as that is shared. In the meantime, we do welcome you, Prof, and thank you for joining us. I note the title of your presentation being Controversies in Burns.
Good afternoon, ladies and gentlemen. I trust that you can hear me and see me. I can't see my own presentation. If you could assist me, because I did upload it. Or
Sure.
give me an indication.
We certainly can see you and hear you. I think if you are in the studio tab, there's a share button at the bottom of the tab. If you're able to click there, a little box with a plus inside.
I did.
I don't think I've got an indication that it's visible yet. Nothing on our side as yet. Perhaps if you can try resharing again, Prof.
There we are. I can see myself, which makes me happy. Share the screen. Share the screen. And that's where we end.
So I think you must select the image of your screen in that share screen window. And then click share.
I have the image. And I can, yes, I have my image, but I do not have you.
So if you select that image and then click share, I believe.
There was something. Okay. I think in the interest of time, let me do the presentation because there's not rocket science attached to it. I trust that everybody can see me, and I'm going to dispense with the slides. My interest in burns started when a patient about 5-6 years ago was driven around Johannesburg with reported 98%, 90% burns, and nobody would take him because there were no beds. Or maybe people were concerned that we were transferring the place of death. It turned out to be that he had mostly superficial burns, and it also turned out that he didn't like the hospital where he was admitted to, and but he got better, and he left after 25 days with his burns in a fairly good state. The issue was that his temperature was 31 degrees. Now, what to do with a patient with a temperature of 31 degrees, because that is a death sentence. So enterprising anaesthetists put the patient onto cardiopulmonary bypass. An hour and a half later, his temperature was normal, and the debridement treatment could continue. But let's look about cooling in burns. The management of burns is based on advanced trauma life support, the standard ABCDE formula, and the E part is important because it contributes to mortality. Now, the first part is that burns lose heat, enormous amounts of heat, because the temperature regulation, the skin is the prime temperature regulating organ in the body. It's lost. And then we add insult to injury by exposing the patient, washing them down, leaving them half naked, and oh yes, sometimes remembering that we should actually re-warm the patients. The result is very often that the patient passes the critical 35-degree cut point, below which enzyme activity becomes significantly compromised. Below 34 degrees centigrade, for instance, the coagulation cascade stops working properly and you're dealing with a coagulopathy. That is good to know. That is all well and good. When we re-warm the patient afterwards, it requires roughly 35% the energy to re-warm the patient as compared to the energy required to maintain the temperature. In addition to that, the patient who has now been insulted with a vasoconstrictive hypothermic insult now is exposed during rewarming to a pro-inflammatory reperfusion type of insult. So you've added 2 insults for each and every episode of hypothermia. So we know that hypothermia is a killer. Even in elective patients, elective surgery, admissions to ICU with a temperature below 35 degrees increases mortality. So much more so for patients with burns. Let's look at the evidence for cooling a burn. Now, what is cooling a burn? Cooling a burn is not necessarily getting it cold. It means that you are washing the burn down with tap water within 3 hours of the burn. That is it for 20 minutes, 3 hours, less than 3 hours, and no more than that. The guidelines show an improved outcome. The Australians published a study where patients were cooled down preoperatively, and it showed an improvement in immediately after the burn, and it showed an improvement in terms of survival, in terms of skin graft take, in terms of ICU days, in terms of all of the parameters that they measured. So there is absolute benefit in washing down the burn, and I use the word washing down with tap water at room temperature within 3 hours of the burn. Now, what about the cottage industry, the industry of cooling the burn actively, proactively cooling the burn? If you cool a burn down, you move the temperature of the burn wound below the core temperature, and you move the patient down the local area down to the temperature 35 degrees or less, where you start getting cellular toxicity. And there's sound experimental evidence that cooling a burn down by dropping the temperature, not as bad as ice, but by other products, you will cause local vasoconstriction, you will cause cellular toxicity, and the patient will end up with a worse outcome. Dr. Despasos this morning made a note about the problems arising from patients who are encased in commercial products which so-called soothe the pain, cools the burn, and stops the burn. And to protect them, they have a little bit of foil around to keep the heat in. We know these patients, they arrive at a temperature of 32 degrees centigrade because it's not 20 degrees or 20 minutes of cooling with tap water. It is 2 to 3 hours of lying in a bucket full of gel, which drops the temperature, and there is a clear increase in mortality rate in these patients. Now, to add to this, we need to look at the other issues around the immediate management of the burn. And what do you do after cooling the burn? Well, the general consensus is that one should use a non-adherent dry dressing. I'm not so sure I know what that is. A towel is definitely not non-adherent. The towel sticks to anything, a hospital towel, a blanket, or whatever. A clean cloth is criminally adherent. And I would like to propose the use of plastic wrap for applying to the burn wound once the burn has been washed down. Number one, it's extruded at 278 degrees centigrade. So number two, it's sterile. It's produced in a sterile fashion. Number two, there's no ingress of bacteria within the roll of plastic wrap. Number three, there is some evidence, predominantly from the military, that it improves pain. The evidence is sketchy, but the fact is that one of the main benefits of using plastic wrap as an emergency treatment for a burn is that you can control temperature. Back in the days when I was working in the mining industry as well as the public facilities, there wasn't money for using external rewarming devices, the ones that hug you like a bear. And we simply had to maintain temperatures because these patients were dropping their temperatures while we were operating and working on them. We wrapped them up in plastic bags, a lesson that we got from camping. And we even saw people on the street living under plastic. So it's a suggestion. It's not based on any science. If we look at washing the wound, because once we lavage the wound with tap water, we've provided benefit. Once we've covered the burn with an appropriate cover until such time as the patient can reach hospital, we've done good. What about cleansing the burn? Now, there is no distinct evidence, but practice suggests that of the cleansing agents, chlorhexidine is the least toxic. It's a Cochrane review referring back to a previous question about hypochlorite. If you look at the Cochrane review, hypochlorite is included to be excluded. The least toxic antiseptic is chlorhexidine. But realize that chlorhexidine varies from 0.5 to 4%. And the suggestion or the guidelines indicate, as well as animal studies, that chlorhexidine 0.5% is safe to use, and that includes neonates where there are concerns. Be careful. Number two, that the cleansing effect of 0.5% chlorhexidine is adequate. Just to add to that, although it's stated to be safe to use chlorhexidine and alcohol, I would advise against it. Common sense says alcohol should be taken by mouth in a relaxed fashion or sprayed on the skin if you want to sterilize the skin, but very definitely not on a burnt patient's skin. To summarize, there's clear evidence that outcomes are improved if one washes the burn with tap water for 20 minutes, if less than 3 hours after the burn. Secondly, there may be benefit in using a cling wrap. Thirdly, there is more or less evidence to use chlorhexidine as a wash. Lastly, to wash down even the chlorhexidine with sterile water, and absolutely important, above all else, protect the patient's temperature. Thank you.
Thank you so much, Prof. Goosen, for the talk and providing such clarity on controversies in burns. I don't note any questions from the audience as of yet. So I thank you once again for the talk, and thank you for joining us this afternoon.
I reversed it enough. I could do it without the slides. Thank you so much for the invitation. Appreciate it.
You did it perfectly, not needing any slides. Thanks again. Unfortunately, we lost Dr. Alexandra Skulls earlier, halfway through her presentation due to network issues. But the good news is that we do have Dr. Alexandra back in the studio. And so I'd like to invite her to please join us again to please complete your presentation that you had been sharing with us earlier. Welcome back, Dr. Alexandra.
Thank you so much. Yeah, excuse me, I'm like a terrier, I always come back. So I would like to guide you quickly through the presentation about facial burns, which we published in the Journal of Burns 2017. And this is how we designed the study. We included 13 patients in each group, in the enzymatic group and in the surgical debridement group. And all subjects were between 18 and 70 years old. And the burn death area that we treated in the study was statistically equal in both groups. The study was signed by the ethic committee of the University of Wittenherdecke. And this is the patient, one of the patients from our study. The burn death was evaluated at second B to full thickness death at admission. And yeah, you know that already. This is how we apply the gel. Then we cover the wound with dressing. And after 4 hours, we see this picture. So the debridement was successful when you see white dermis and small red bleeding spots, because then the wound bed is perfused. If you only see white dermis, then it is not completely debrided. Something went wrong, but this rarely happened, right? If you do it properly, this is what you see. And then you clean the wound, and then we applied Supratil. You can apply any kind of dressing which keeps the burn wound moist. This is the only interesting thing. I saw a question already in the chat. Yeah, just keep it moist. And we covered Supratil with a fatty gauze, and then we just waited, and we trimmed the dressing every day when we found that tissue was already healed. And after 3 weeks, we saw that only a defect at the forehead remained, so we did a skin transplantation here. So the advantage in this patient was to reduce the area which we had to cover with a skin transplant as much as possible, and we could reduce it on the forehead. And this is how the gentleman looked at admission after 12 months and after 24 months. So yeah, and let's have a look at figures. What we found in the enzymatic group was that all patients could be treated apart from the main theater. So all of them were treated either bedside or at the intensive care and burn unit. All of them were treated under analcosedation or local anesthesia. All of them got Supratil, and only one patient needed a skin grafting. And if you compare it to the surgical debridement group, you find that all patients in the surgical debridement group were treated with a Versajet, of course, but in the main theater, all under general anesthesia, and 9 of them got a skin graft, and some of them also needed 3 surgeries. And this is the reason why the healing time in the enzymatic group was much shorter. It was only 19 days. And sometimes this was due to OR capacity limitations, right? Because sometimes we just simply have to wait longer until we can perform another skin transplantation if skin transplants gets lost. If we have a look at the early outcome, we find that enzymatic debridement was also superior, because all patients could be treated at the first day after admission. This was on our standard. 77% of the wounds were more superficial burn than initially assessed. Of course, this is not surprising, because we debride very selective. We keep a lot of vital tissue, and we were not used to that, right? Not used to seeing an uneven burn surface after the debridement. Therefore, most of the wounds healed spontaneously, 85%. Yeah, and if we have a look at the scarring, first the Vancouver scar scale after 3 months. The enzymatic debridement group was superior in scar pliability and height, significantly superior to the enzymatic debridement group. And we also had a look at objective data with the Maxameter, Kutometer, Tevameter, Visioscan, and the O2C device. And we had a look at the same patient in areas which were burned, and we treated them, and at the same patient for areas which were not burned, so healthy tissue, healthy skin, and we compared, so that we did not have any bias between patients. And we found that for all of these different aspects, there was no difference after 12 months. Only if we compared both groups, we found differences. So clearly, the scars after 12 months in the surgical debridement group were less red compared to the enzymatic debridement group, because simply a spontaneous healed surface, of course, stays a little bit more perfused, more red. We know that. And in the surgical debridement group, patients got, in the majority of the cases, they got just a skin transplantation, and this is a little lighter, right? But this was just a case for a few months. After 12 months, it was equal. And if we have a look here for all these other aspects of scar quality, objective, the viscoelasticity and pliability, and following the posers, pigmentation, thickness, relief, pliability, stiffness, all of these different scar quality aspects were superior after 6 and 12 months in the enzymatic debridement group compared to the surgical debridement group. So the scar quality in enzymatic debridement was clearly superior for a lot of aspects. Let's have a look at the last patient. Admission, you know these pictures already, the treatment process, and again, very close, you see the whitish dermis and just bleeding spots. And this is how it has to look like. Then we applied Supratil again, but of course we could have gone with any other dressing which keeps the wound bed moist. And here you see the gentleman, last picture after 8 weeks. After 3 months, 6 months, and after 12 months, he was quite happy with the scar quality. We only found a slight hypopigmentation in his forehead, and the rest of the scar quality was quite good. And these were all these patients with burns of their faces, which were judged as at least second B degree at admission. And yeah, you see the outcomes. All of them came when I had my last talk about my habilitation about this topic and showed me their faces again, and I was quite happy to see all these happy faces. Thank you so much. If you want to get my literature list, please send me an email to my email address. The literature is all about this topic, about enzymatic debridement when it comes to genital burns, hand burns, treatment of the faces, but also about the mechanism of action. So what do we have to prevent? We did a lot of research on that. This is my email address, and yeah, I really appreciate to be allowed to have 2 speeches here today. Thank you so much.
Thank you so much, and really appreciate you joining us and completing your presentation. There were a few questions or comments, which I'll read three of them. I think you've already addressed 1 or 2. What is the maximum surface that can be treated with Naxobrid? Who is paying for the treatment? Which dressings do you use after the treatment?
Mm-hmm. So the maximum surface that I treated personally was 44%. And we treated this patient under analogous sedation at the intensive care burn unit only. So that works perfectly. We cover the application of the dressing and the first 30 minutes. And after that, we reduce analogous sedation completely and go back to pain medication. Only that works. And as I said before, you can use any kind of dressing which keeps the burn wound moist. But this is important because we are waiting for spontaneous healing and we don't want the burn wound to get dry. That's all.
Perfect. Thank you so much once again.
Thank you so much.
So we round up this session with some videos from sponsor Smith & Nephew.
Our world is rapidly changing. Around the globe, communities are developing new ways of managing their life, work, education, and health. Coronavirus has rapidly driven change, transforming how we connect and interact with our healthcare. When it comes to the needs of wound patients, though, some things are not working well. Despite innovations in treatment, patient outcomes are still less than ideal. Wound patient numbers are still increasing, impacting working-age adults as well as older people. Budget pressures are making it difficult to access more effective specialist products and care. Inconsistencies in diagnosis and practice are compounding these issues. We understand the daily challenges you face managing patients with wounds. Together, we have the opportunity to establish new standards of care. We're seeing greater adoption of early intervention strategies, with opportunities for further innovation in patient-led care. At Smith & Nephew, we're committed to improving the lives of patients. Alongside our customers, we won't settle until we've solved the challenges of preventing and healing wounds, because they hold back too many lives. We're developing better ways of improving outcomes for patients, ensuring the right treatment for the right wound. We're continuously searching for ways to improve how care is delivered. Your challenges are our challenges too. By meeting and exceeding you and your patients' needs, we can make real change, continually shaping what's possible in wound care.
BioBrain is a transparent biosynthetic wound dressing and is used as a temporary skin substitute for patients with predominantly partial thickness wounds. It is constructed of a perforated silicone film bonded to a trifilament nylon matrix optimized to assist in adhesion to the wound surface. A film of collagen peptides has been bonded to the nylon matrix to aid adhesion to the wound surface. By placing BioBrain's fabric side onto the wound, it will adhere and then protect the wound as fibrin and serum are trapped within the matrix. When in place, BioBrain is also transparent, enabling visualization of the wound. Deep within the protected hair follicles, the process of re-epithelialization begins. Epidermal cells begin to proliferate and then migrate across the surface of the wound. Re-epithelialization beneath BioBrain will proceed over a period of between 10 and 12 days. Cell proliferation and migration along the inner aspect of the matrix eventually dissects the BioBrain, leaving a healed epithelial surface.
The VersaJet 2 hydrosurgery system can help you optimize your surgical debridement procedures. With correct usage, the VersaJet 2 system will enable you to efficiently ablate tissue with precision while preserving viable tissue. Using a piece of raw meat, this brief tutorial will demonstrate the proper technique to use during surgery. After the VersaJet 2 system has been properly set up and primed, adjust the power setting on the console to the appropriate level for the anatomical area you are debriding. To determine the optimal power level for your procedure, begin at a low level, increasing as needed by stepping on the arrow buttons on the foot switch. When you are ready to begin, invert the handpiece and hold it at least 7 inches away from you before you step on the activation pedal. Once you have activated the handpiece, allow it to calibrate. Invert the handpiece into the wound to begin the hydrosurgical debridement. The actual debridement of non-viable tissue occurs in the operating window. Align the window with the tissue area to be excised. Press the operating window against the tissue and move the handpiece tangentially over the tissue area at a swift and steady pace. Be careful to maintain your pace or you will create grooves in the wound bed. The science behind VersaJet 2 is unique yet very simple. Saline travels across the operating window and into the excavation window at speeds as high as 1,000 miles per hour. These high speeds cause the saline to ablate any tissue it contacts and also create a localized vacuum. So, as tissue is excised, it is immediately evacuated through the evacuation window. The amount of tissue you debride depends on the power level used, the pressure applied on the handpiece used, the exact or plus, and the angle at which the operating window is applied on the wound bed. When you have finished the debridement procedure, invert the handpiece away from the wound and yourself. Then remove your foot from the activation pedal. If you take your foot from the pedal before you have inverted the handpiece away from the wound, residual saline in the system could trickle back into your clean wound bed. The VersaJet 2 system is ideal for debridement procedures in general surgery as well as specialty surgical areas. It may also be used for cleansing of the surgical site in applications that, in the physician's judgment, require sharp debridement and/or pulsed lavage irrigation. In burn, VersaJet 2 provides the precision needed for numerous procedures, including debridement, site preparation, graft bed preparation, tissue preparation for negative pressure therapy, biofilm, infection, and more. Preservation of viable tissue is important in debridement of chronic wounds. The VersaJet 2 system gives you precise control, allowing preservation of valuable viable tissues. The system allows efficient debridement in vascular surgery, podiatry, and other chronic wound procedures. Orthopedic and trauma procedures often require not only precise excision, but also need effective removal of contaminants and debris from the wound bed. The VersaJet 2 system is specifically designed to ablate non-viable tissue and concurrently evacuate debris and slough, which may be beneficial on procedures including open fractures, total knee revisions, septic revisions, road rash, embedded debris, and gunshot wounds. In the areas of plastic reconstruction and general surgeries, the VersaJet 2 hydrosurgery system allows the precise selection, excision, and evacuation of non-viable tissue while sparing surrounding viable tissue and controlling the depth of the debridement. Procedures include soft tissue reconstruction, skin grafts and flaps preparation, revisions, debridement of acute and chronic wounds, dehisced primary closures, and many more. With the VersaJet 2 system's advanced hydrosurgery technology in your hands, you have the precision and control you need for all types of debridement procedures. If you need additional information on the use of the VersaJet 2 system, contact your local representative.
BioBrain is a transparent biosynthetic wound dressing and is used as a temporary skin substitute for patients with predominantly partial thickness wounds. It is constructed of a perforated silicone film bonded to a trifilament nylon matrix optimized to assist in adhesion to the wound surface. A film of collagen peptides has been bonded to the nylon matrix to aid adhesion to the wound surface. By placing BioBrain's fabric side onto the wound, it will adhere and then protect the wound as fibrin and serum are trapped within the matrix. When in place, BioBrain is also transparent, enabling visualization of the wound. Deep within the protected hair follicles, the process of re-epithelialization begins. Epidermal cells begin to proliferate and then migrate across the surface of the wound. Re-epithelialization beneath BioBrain will proceed over a period of between 10 and 12 days. Cell proliferation and migration along the inner aspect of the matrix eventually dissects the BioBrain, leaving a healed epithelial surface.
Thank you. So that brings us to a conclusion of the post-lunch session. As you may have noticed, we are running slightly behind the schedule. So those of you who are joining us for the abstract session, please note that we are about 30 minutes delayed. So we will take about 15-minute break and reconvene at 2:45 South African time with the abstract session. Thank you for your patience and look forward to seeing you in just under 15 minutes. Good afternoon. Welcome back to South African Burn Congress 2021. We're now into the final session for today, the first day of the Congress, and this brings us into the abstract session. Each of these slots will be picking up the pace with only 10 minutes for each of the presentations in the abstract session. To start off this session, we have Dr. Ellen Rogers, and the title of the presentation is Perioperative Temperature Management.
Good day to you all. My name is Alan Rogers, and I'm a burn surgeon at the Ross Tilley Burn Centre in Toronto. I'm going to be presenting a follow-up to a talk I gave to the same forum 4 years ago in 2017 in Cape Town, where we discussed quality improvement interventions that might be applied in the context of perioperative burn management. As you all know, early excision and grafting remains the gold standard management for extensive deep burn injuries, but this exposes susceptible patients to hypothermia perioperatively. Hypothermia affects a large proportion of all surgical patients, and there is some good evidence to suggest that it increases the mortality risk, causes bleeding and a need for more transfusions, has a relationship to increased infection, and also delayed recovery from anesthesia. Relevant to our population as well is a delayed wound healing that results, particularly with reference to graft loss. Patients with burns are more susceptible to hypothermia and its effects for a number of reasons, not least because of their deficient epidermal barrier and the fact that the burn surgeries require both a donor and recipient site, necessitating exposure of a large surface area. They are inherently more susceptible to infection, and we know that hypothermia has a close relationship to that too. When we started our work almost 5 years ago, we evaluated whether we had a problem with perioperative hypothermia in our setting. And so to test this hypothesis, we had to collect some baseline data, which we did. We presented this in the form of a study published in Burns, where we reviewed the outcomes of more than 1,000 patients who underwent surgery in our setting and did a deeper dive for those who had burns over 20% body surface area. What was clear was that those patients who developed perioperative hypothermia were more likely to develop both infectious and non-infectious complications. We also determined that we had a problem that could be addressed because more than a quarter of these cases developed temperatures below 36 and had negative consequences. At the time, Dr. Rizzo and colleagues produced this paper, demonstrated that there was relatively little evidence for the strategies that were in use to prevent its development. And when they undertook a subsequent survey, they showed that most units used the adjustment of ambient temperature and forced air devices to prevent its development, felt that it was important, but there was very little evidence to suggest or to support their practice. And so we developed a team and we looked at the factors that may be contributing to the development of hypothermia in our setting, not least exposure at the start of the surgery, the relatively low ambient temperatures that were being used, as well as other practices that may increase exposure intraoperatively. So we did a baseline diagnostic phase and we carefully evaluated the various factors, tried to reinforce intraoperative measures as far as one might, but felt that we could offset the inevitable drop at the start of surgery during exposure when patients are being prepped and draped, that might be effective. And so we introduced this intervention and applied it over a period of time. So we warmed the patients who had temperatures below 37.5 at the start of surgery prior to surgery for about an hour to 2 hours, and demonstrated that we could reduce the incidence to around 14% rather than the baseline data. And based on this information, we added this to the order set so that the nursing staff were obligated to apply pre-warming, pre-operative warming, and it was part of the protocol management. And we felt that this was an effective strategy to help our problem. The next question we had was, what were the ambient temperatures appropriate for our patients, both in the operating room and on return to the burn ICU? And in order to make conclusions, we obviously had to have good data, and we used this device at Sensor Push, which is a small 4x4 centimeter device that collects temperatures and humidities every minute, stores data for a 2-year period, and pairs with a smart device. And we placed these in all the rooms, the operating room and the resuscitation areas. Carefully monitored all these temperatures and evaluated them, and then we intervened by increasing the temperatures on 2 occasions simultaneously to replicate the possibility that a hypothermic patient was returning from the operating room and needed to therefore increase the temperature quickly. As was demonstrated, the mean temperatures of the rooms were not too low. They were 23.5. But when we looked closely at the 2 interventions, it was, unfortunately, we were only able to increase the temperatures of the rooms by about 1 degree. And in fact, only 2 of the rooms were increased by more than 2. And we felt this was grossly inadequate and required facility engineering assessment to address. In certain rooms, we might need alerts for high-risk patients. Obviously, perioperatively, the operating room temperature would also need to be evaluated. And so we did a study over a 6-month period looking at correlating the operating room temperature with and evaluating it and correlating that with patient core temperatures. And so we looked at 261 operations with a mean duration of over 200 minutes, and found that 33 patients, in other words, 27.7%, were hypothermic in 43 cases, 16% of cases. These numbers are very close to those that I showed you earlier. Interestingly, we then looked at the mean ambient temperatures for those who, in average, were 24.8. But those who were hypothermic had a much lower temperature than those who were normothermic. Hypothermic patients had larger burns in general than the normothermic group and required longer surgeries and would require a regression analysis to assess the p-value there. The rate of hypothermia, interestingly, varied between the 4 surgeons, with ranges between 8 and 30%, demonstrating that without correlation with duration or burn size, that there may be some practices that could be affected in the future. As a result of these findings, we adjusted the burn OR minimum temperature to 23 degrees and applied some bundles of measures and standardized protocols that we might apply in the operating room. And so what I've done today is demonstrated some simple measures that might be undertaken in one's unit because we know that perioperative hypothermia has significant consequences. that certain measures can be applied to prevent its development, like preoperative warming and ambient temperature monitoring and adjustment as needed for each patient. Thanks again for the opportunity to present my work, and I look forward to any comments or questions.
Thank you so much, Dr. Rogers. I don't see any comments or questions from the audience as yet. Dr. Alan Rogers is in the chat. I do encourage audience members and participants to interact in the chat box in the main auditorium link. Thank you once again, Dr. Rogers. Our next speaker is Dr. Zain Mehta. And Dr. Mehta is presenting on complete penile skin reconstruction with autologous foreskin advancement in a pediatric patient. Thank you, Dr. Zain.
Thank you. I'm, as stated, I'm presenting a novel penile skin reconstruction strategy. This was performed as a case study and was performed in the Red Cross Burns Department here in Cape Town, where I am a registrar in the plastic surgery department. So we present the case of an 8-year-old boy who suffered 50% flame burns to the torso, all 4 limbs, and the external genitalia. Thankfully, his hands and feet were spared. His path was a long one, which required numerous debridements as well as a sanitizing, diverting stoma. And due to the large surface area and limited donor skin, a meat graft was utilized for these large areas. The penis was then covered using a relatively novel approach to penile skin reconstruction following burns, which I'll detail later. So these are the pre-operative pictures as he came in for his initial debridement. As you can see, it's quite extensive, and here's ischiotomies in these arms as well performed. So penile burns represents considerable morbidity for a patient and is a complex problem to deal with adequately for a burn surgeon. There are psychological and functional issues that one must take into consideration, especially for the developing pediatric patient. We believe that these are the fundamental issues that one must consider when tackling penile burns in dealing with ideal coverage. One must not overlook the psychological impact on the final outcome of penile management, which is tied to aesthetics, which itself is linked to the young boy's self-esteem as he traverses from adolescence into adulthood. Functionality is equally as important, and one should aim to maintain tactile sensitivity as well as preservation of erectile function. In the pediatric group, where continued growth is expected, the ability to grow and expand with the child without the need for subsequent surgery is optimally desired. And finally, where possible, the options for reconstruction should provide the lowest morbidity for the patient. Skin coverage of the penis has been described in many ways, from simple skin grafting to locoregional and free flaps, each with its benefits and drawbacks. Skin grafting typically is the most commonly described method of skin coverage. However, this provides suboptimal outcomes and can be technically challenging to provide a good result. Skin graft requires at least 2 lines of fixation, and often quilting is necessary as the cylindrical shape necessitates this. The shape and the position of the penis also comes with difficulty in dressings, particularly dressing the graft, as illustrated by this medieval-looking traction device, which describes good results but is hardly an ideal solution to immobilizing a graft for take. It also comes with the problems of providing asensate skin that is aesthetically poor and prone to scarring and contractures. Skin grafts may, however, be necessary if other options are not available. Other options include local regional flaps as well as free flaps, but not all regional flaps provide sensibility to the penis, which is a considerable drawback. The scrotal flap, as described here, is well described but provides a relatively poor match, as the skin is very different to native penile skin and requires a second operation to divide the flap and leaves potential donor side morbidity. The radial forearm is the most commonly used free flap for penile reconstruction, and it provides a sensate penis, but aesthetically the outcome is quite poor as it is a relatively bulky flap when transposed onto the penis. And free flaps also require expertise which is not readily available in all settings, and it can leave a donor site defect which can result in morbidity. So I'll briefly describe our method of reconstruction, which is relatively novel as it has only been partially described in a case study in a non-circumferential burn to the penis. It is a simple technique that can be performed without specialized personnel or equipment. Initially, you prepare the bed as you would for any graft. In our patient, the area involved was from the junction of the internal and external pubis down to the base of the penis circumferentially. We did tangential debridement of the non-viable tissue down to the dartos or lamina propria. In our case, we utilized both the WEC knife and the VersaJet 2 system to limit the amount of debridement necessary to gain a viable bed. However, VersaJet 2 system may not be completely necessary in all situations. We provided good hemostasis and a well-vascularized bed. This is just a schematic diagram basically portraying the steps involved. Initially, just as a normal penis with an intact foreskin. Obviously, in our case, the outer pubis skin was non-viable. What it should look like post-debridement with just the inner pubis available, which was then everted and unfurled and then inset at the base of the penis in the final diagram. This is a picture of intraoperatively the debrided penis. As you can see that it has a good, well-vascularized bed, and you can just see the edges of the intact inner pubis. This is after the unfurling and advancements of the inner pubis as the outer penile shaft skin with fixation at the base of the penis. These are post-op pictures at week 1. As you can see, there's still quite a lot of edema, and we were unsure of whether or not near the raphe and the suture line, whether there would need for a Z-plasty revision at some stage. However, as the weeks went on, the aesthetic look improved, and months post-op, all that swelling had settled down and was left with a very aesthetically good outcome. As you can see, there's no need for a Z-plasty revision there. So we feel that this method of skin coverage provides significant advantage and very limited disadvantages. The only real consideration we feel is whether there's donor skin available to use or not. Theoretically, we felt a Z-plasty may have been necessary once the suture line scarred down, but in this case, it was not necessary. The advantages of this procedure are that it fulfills the criteria earlier outlined very well indeed. It provides native, elastic, sensate skin, which provides a good aesthetic match and restores functionality even as the child grows. It sidesteps the need for complex dressing as it has a single suture line, as well as minimizing scarring compared to the traditional skin graft options. Just as an add, we recently done a second case, and this is just to provide you with pictures of the second case that we did. Shows you the initial intraoperative post debridement, the suture line for the initial advancement flap, and a week post-op on the left, and on the right-hand side we have the 3 weeks post-operatively. Again, showing a reasonable result. Still a little bit of swelling that presumably will resolve with time. Thank you for listening to my talk.
Thank you so much, Dr. Zain, for the really thorough presentation. I'm just noting to see if there are any comments or questions from the audience. I don't see any as yet. So please do share your comments and questions in the chat box in the link on the live auditorium page. I think just a quick comment from one of the audience members saying a super outcome. Very well done.
Thank you.
Thank you so much for the presentation, Dr. Zain. Our next presentation is by Dr. Vikita Nandan on the presentation titled Knowledge and Attitude of Guyanese 15 years and older towards Skin Substitutes for Burn Wound Coverage in Guyana 2021.
Good morning, everyone. This morning, I'll be presenting on knowledge and attitudes of Guyanese 15 years and older towards skin substitutes for burn wound coverage in Guyana. As was mentioned, I'm Dr. Nandan and I work at the Georgetown Public Hospital Cooperation. This study was undertaken as part of the completion for the Masters in Burn Care that was done at Queen Mary University of London. It was done with the support of Professor Gutas, who was the course lead, Dr. Rajkumar and the others at the Burn Care unit of GPHC. Some of the other persons listed here would have assisted with data collection and the logistics to get around the country. The talk follows this outline this morning. To refresh our memories, burn injuries are the fourth most common cause of trauma, of which 95% of the burden is faced in the lower to middle income countries. While the gold standard has always been for early near total excision of major, partial, and full thickness burns in immediate closure, this cannot be achieved using autologous split thickness skin grafting, even with meshing, when the total burn surface area that is affected is more than 40%. Therefore, skin substitutes become imperative. And of the skin substitutes, allograft skin is what would be the most ideal. Allograft skin transplantation is not new to us, but it has been described from as early as 1881 and has been solidified in 1949 with the establishment of the United States Navy Skin Bank. To familiarize ourselves with where we're talking about, the country Guyana is found on the South American continent, and sometimes we're often mistaken for Ghana. We are bordered by Venezuela, Brazil, Suriname, and the North Atlantic Ocean. To the right of the screen, you're going to see the map of the country, and this outlines the 10 administrative regions through which villages were selected for data collection. So, the rationale of the study in Guyana, we have no tissue banks nor nationally established protocols for tissue donation, and our burn care unit sees an average yearly admission of 57 patients. The LD50 has been 49% total burn surface area following serial debridement and closure. While we may have the human resources available, skin substitutes are lacking, as well as maybe additional resources. So, if we would want to find out about the tissue bank, we will need to start with a baseline, since the success of the tissue bank is dependent on donors, and it will bring in awareness, education, culture, etc. The aim of the project was to assess the perception of Guyanese 15 years and older on the use of skin substitutes for wound coverage, taking the following objectives: assess the current level of knowledge of skin substitutes, assess the attitude of Guyanese 15 years and older, and identify the main factors that persons will consider before tissue and organ donation. The study followed a descriptive questionnaire-based cross-sectional analysis that used stratified convenience sampling. The questionnaire was modeled from a study that was done in Karachi, Pakistan, and was published in 2019. It was piloted to our local setting and validified in that manner. The research site, as mentioned, was Guyana, and these were the villages that we selected the sample from during the time of January to March of 2021. For our inclusion criteria, persons were required to be Guyanese, ages 15 years and older, and the reason why it was limited to just Guyanese is because if the results of the study is used to guide lawmaking, then it has to reflect the will of the citizens. And the sample size was taken to be 500 persons. The study variables were knowledge, which was defined as understanding of a given topic, for example, organ or tissue donation; attitude, which would be the feeling towards a particular subject, as well as any preconceived ideas that participants may have towards the subject. My scoring system was knowledge, using a poor to fair excellent scale, and same thing for attitude. And then these variables were used for continuous into SPSS. For the results and discussion, the demographics, the study population was similar to that of the general population, where 34%, as you can see on the bottom of the pie, came from region 4 and 12% each came from region 3 and 6, which is similar to our general population. And these regions are along the coastline, so it's heavily populated because of ease of access. The male to female ratio was 42 to 58%. For the age distribution of subjects, just about half of the population was under the age of 35. And this may be a limitation because the study was done at the height of the COVID-19 pandemic in our country, where restrictions were still in place. Older persons were advised to stay at home. Persons had transitioned to a working from home method. And for the schools, the older students were now returning to school to sit there to prep for their exit examination. Hence the high percentages as you would see it there. Most of the study participants would have achieved at least a secondary school education that was there, and the ethnicity, this is also a reflection of how it is, with the East Indian and mixed being the higher populations, followed by the Amerindians and the Africans. For religion, Christianity is our largest following, followed by Hinduism, and then the other religions to a lesser extent. So to answer our objectives, the first was the current level of knowledge of skin substitutes among Guyanese 15 years and older, and it was found that 42% of the study population had average to full knowledge. Knowledgeable respondents had significantly more support for the establishment of a skin bank than less knowledgeable respondents. The knowledge for the debridement, autograft, and the different types of skin substitutes, you can see in the green is where persons were aware. The red, people said no, they didn't think it was possible, and then there were those who said they did not know. There was a high percentage of participants that were aware of autografts as compared to allografts, but despite this, you'll see later on that persons were still willing to donate if it was necessary. For the awareness of tissue and organ donation, the kidney and heart, there was a higher percentage of persons that were aware of these as compared to skin banking and donation. And this similar awareness of solid organ donation has been reported in Nigeria and other studies that were carried out. For the source of information that was done, you can see it in blue and orange here, and the blue represents what was currently available, and then the persons were asked if I wanted to teach them more about the topic, what would be their preference. You can see that movie and TV series was currently the highest that was known, and this here is reflected by similar studies that were done. The traditional media was of little value, and this here was similar to a university college hospital study that was done among doctors and nurses. Conversely, in India, for example, the media was indispensable. In terms of preferences, you'll see that most persons prefer that a healthcare worker speaks to them about the topic. This may be explained or attributed to two reasons. One, in many of our communities along the regions, there's limited access to electricity and internet, and there has always been a trust in face-to-face communication amongst our population. So usually, and especially in the smaller villages, if there's somebody who is thought to be a learned individual, then persons may flock around them in the afternoons and they will sit and they will have a talk, or as Guyanese call it, a gaff. And this is the way that a lot of the information is shared about. So it may guide how we would want to do our awareness talks at the time when this becomes necessary. To answer the second objective, attitudes of Guyanese 15 years and older towards tissue and organ donation, it was found that just about 50.6% of the population had a positive attitude, but the positive attitude was significantly associated with increased level of knowledge. Here. The attitude towards donating and accepting bank skin, more people were willing to accept than donate. And it was found that this has been the global trend, especially among persons of color. While culture did not outright forbid donation of skin or organs, persons were of the opinion that they wanted to be buried or cremated as is. And there was a Gallup survey that was done that showed similar findings. However, the literature is sparse on the true relationship between culture and donations. For the third objective, and this was to identify the main factors that persons will consider before tissue and organ donation, relationship to the person was the highest, followed by severity of injury. Not a major deciding factor was religion and disfigurement concerns. Now, those that are willing to donate if necessary may guide us to the fact that with awareness measures, we can have potential donors to the skin bank. And of those who were willing to donate, more persons were aware of live donation than cadaveric donation. So it may be attributed, therefore, to the lack of knowledge of the types of donations that happens, and also sometimes that this need to donate may be an emotional decision. Therefore, knowledge becomes important, as we will have to consider the ethical ramifications that it's going to have. And while there has been no difference in the uptake of allografts that are from a live donor versus a cadaveric donor, there has always been the psychosocial implications that have been documented time and time again. For the cadaveric donations, the persons would have expressed that they would prefer to consent before death, and that this will not be cannot be reversed by their living relatives. I mentioned the donation based on the relationship here. So some of the limitations of the study, I would have outlined that the conduct was subjected to COVID-19 guidelines. Knowledge section may have been subjected to a recall bias. And because of the paucity of literature specific to tissue donation, the literature review was extended to include organ donation, as it is thought that the ethical and legal considerations are going to be similar. In conclusion, Guyanese have a positive attitude towards skin donation, but poor to average knowledge. Increased knowledge was predictive of favorable attitudes. Awareness measures are needed, and the questionnaire can be repeated to assess effectiveness of awareness measures as we move, or if we wanted to consider the development and establishment of a skin bank. Thank you very much.
Thank you so much, Ms. Nikita Nandan, for a very interesting presentation on the knowledge and attitude of Guyanese towards skin substitutes for burn wound coverage. I don't note any comments or questions from the audience, but I do encourage you to stay on the live chat and do interact with any comments with the audience. Thank you once again for the very interesting presentation.
Thank you very much.
Our next speakers are Dr. Nathan English and Dr. Gary Dos Passos, who will be presenting on burn wound debridement, a novel surgical technique.
Good afternoon, everybody. To South African Burn Society and to all attending, thank you for having my presentation. I'm Nathan English, and I'll be presenting on burn wound debridement, a novel surgical technique looking specifically at the management of the hypergranulated burn wound. And I would like to credit Dr. Gary Dos Passos for pioneering this technique and for his contributions to the talk. So by way of introduction, I'll be speaking about what hypergranulation tissue is, looking at debridement, the various techniques, and then once we're done with that, we're going to be describing the novel orthopedic wire debridement technique. So granulation tissue, it forms at the site of injury, in this case a burn wound, in order to provide a lattice work along which epithelialization can occur. When this process is overwhelmed, it results in an area of hypergranulation. The risk factors would include excessive wound exudate, external friction, and prolonged foreign body irritation. Clinically, it is recognized as a red friable mass which extrudes above the level of the surrounding healed skin. And you can see macroscopically it would impede epithelialization as it acts as a mechanical barrier preventing keratinocyte migration across the wound bed. And due to the fact that these wounds are colonized with surface biofilm, they are inhibiting signaling pathways between the keratinocytes, once again rendering the wound recalcitrant to healing. These are just a few examples of how hypergranulation looks. This is involving a right forearm of a child, and then this is the thorax. And looking at the left inner aspect of the arm, you can see the surrounding healed skin with the hypergranulated area at the flexural surface of the antecubital fossa. So what is debridement? It can be described as the removal of devitalized and contaminated tissues whilst preserving critical structures. And in this case, it would be the healthy dermis. One then asked the question, why is it necessary? I think when looking at factors affecting wound healing, under the local etiological factors, hypergranulation is noted there, and the treatment thereof would be to debride that from the wound bed. Looking at the various techniques, we'll be going through a few of these in the next couple of slides, but more importantly for this talk, we'd be expanding on the mechanical debridement techniques. So autolytic debridement is essentially when the body uses its own proteolytic enzymes to break down necrotic tissue and rid the wound bed of this devitalized tissue. And in using this technique, various hydrogels, honey dressings, as well as moisture exposure burn ointments are used to facilitate this. Enzymatic debridement would involve various ointments containing collagenases, which break down collagen in devitalized tissue, and these can also be used with various ointment carriers. Bromelain-containing solutions, which have been derived from pineapple stems, are also used, and these have comparable results when compared to sharp surgical excision in the literature. Biological debridement therapy is largely larval debridement therapy, not commonly used in burns, although it has been described, more commonly used in chronic wounds such as venous stasis ulcers. Looking at the mechanical now, importantly, would be sharp surgical excision using planar instruments such as the Humby blade or the Humby knife, the wet blade for more meticulous debridement of areas such as the web spaces of the hands, and then the dermatome. While it's been primarily described for the harvesting of skin, it can also be used to debride wounds. Hydrodebridement therapy, this is essentially using the VersaJet machine, which uses a pressurized jet of water and a Venturi effect of airflow to allow you to debride and simultaneously remove debris as you go along. I think the downsides of this technique would be the fact that it's quite expensive. There are few consumables, and it's one set per patient. Other techniques would include laser and ultrasound. Whilst not commonly used in the burns fraternity, it can be used. Once again, it is quite expensive with a number of consumables. For lack of a better term, the good old scrape can be used, and this can be utilized using the back of a BP handle, a metal ruler, as well as a wooden spatula. So now getting to the orthopedic wire debridement technique. Due to the paucity of the randomized controlled trials comparing surgical and non-surgical debridement of hypergranulated burn wounds led to the intervention of this technique. So essentially, the orthopedic wire debridement technique is described as a surgical debridement technique using a 1.25 millimeter malleable orthopedic wire grasped between two ratcheted instruments such as the needle holders. So the inherent mechanical properties of the wire contributes significantly to the effectiveness and the efficiency of the technique with a multitude of surgical benefits. So firstly, in comparison to other planar surgical blades such as the Humby knife, the round body surface allows for effective debridement of the friable hypergranulation tissue whilst being relatively atraumatic to the underlying dermis. Secondly, the malleability of the wire allows for the manipulation of the curvature of the wire in order to replicate the contour of the body surface affected by the hypergranulated wound, thereby allowing you to evenly distribute the pressure across the wound bed. And then thirdly, by adjusting the intergrasper distance of the cutting surface, it allows you to customize the instrument based upon individual wound configurations of patients, allowing a single type tangential excision of both curved and flat body surface areas. So the method would include firstly assessing the wound configuration, seeing what parts of the wound are curved, what is flat. Secondly, it would be to setting the intergrasper distance and the curvature of the needle. And importantly, you can see the assistant applying really good counter traction. Once this is achieved, downward pressure is applied and the instrument is drawn towards the surgeon whilst maintaining constant downward pressure and good counter traction. You can see then as the instrument is drawn towards the surgeon, it allows for the single type tangential excision, rendering a healthy wound bed underneath. The following video is just depicting what we've just described. You can see the intergrosper distance being set up, and the curvature had already been established based upon the curved area of the child's arm. And you can see now, so downward pressure is being applied. The instrument is drawn towards the surgeon, and the intergrosper distance is constantly adjusted based upon the wound width. And you can see how you can then customize this depending on how broad the wound is. And you can see the entire mass of hypergranulation tissue is removed as a single pass. So this is looking at the surgical benefits now. This is a cross-section of the malleable wire. You can then, this just reiterates the curved bodies, at least the curved surface of the wire itself in comparison to other sharp planar instruments and how atraumatic it is to the underlying healthy dermis. And then this diagram is depicting the equal pressure distributed across the wound bed. You can see with using planar instruments, you can result in quite a bit of pressure applied to the center of the wound, which can potentially result in an overzealous debridement of potentially healthy tissue, which could have healed by secondary intention. So the indications would include ideally a non-chronic hypergranulated wound. However, it can also be used in chronically granulated wounds, but you can see in this video how more difficult it can become for, unfortunately, this video seems to have a trouble. I just want to find out if you could play the video on hypergranulated wounds now. Okay, we'll move on to the next slide. So this is just covering the advantages of the technique. So firstly, it's dynamic. It allows for the constant adjustment of the cutting edge. It protects the healed wound skin. It's cheap, it's easy, and it's easily reproducible in both the first and third wall setting. Thank you very much.
Thank you so much, Dr. Nathan English, for really a novel and very interesting surgical technique, and really excellent work. Thank you so much.
Thank you.
I will move on to the next presentation, which is going to be shared by Sister Michelle Second. The title of the presentation being Nanocrystalline Silver Gives a Hand Up.
Hi, good afternoon, everybody. Hi, good afternoon, everybody. My name is Michelle Second. I have my own private wound care practice in Midrand, Johannesburg, South Africa. And it's been a very interesting lectures and talk so far. Thank you for giving us opportunity to show you this amazing product. This patient came to me as a referral from quite a far distance, and he had a hot oil burn on his left hand. He was 28 years old, which I think was one of the better benefits that helped to assist his healing that went so rapidly. Next slide. His initial assessment, his burn was on the 6th of February this year, and it was hot oil. He was making chips, and the oil bubbled up and made his hand into a huge blister. His emergency treatment was the burn shield, which is mainly hydrogel with a bit of tea tree oil, and it's 96% water, and it was in a latex glove with his hand when he came to me. He had only been given analgesia, and he had some antibiotics, and that's about it. So I got him 5 days later. So this hand had been literally soaking in that latex glove. And this is, as you can see, quite a burn, mostly on the inside of his hand. I cut away most of the blisters that were there. They were already popped, and a lot of the exudate was all mixed in. But the patient had quite a high pain threshold. He was about 7 out of 10, but he was very brave. Next slide, please. So, you wonder why nanocrystalline silver. As we know, it is quite a costly dressing, but it is a cost-effective dressing, and I'll show you why. The patient also had a very long distance to come to me. It's a good hour and a half drive to come to me. I did offer other people to do his dressing, but the patient insisted. So he had no medical aid. So, you're thinking also still costs, but to me, this was cost effective because of the long duration of the dressing. It was high inflammatory response in his hand, and I needed a quick reduction of the inflammatory response, because with that, you know that you're going to get the antimicrobials, the antibacterials, and it's also going to bring the pH down, which will help to bring down the inflammatory response. His pain will also be less once the inflammatory response was down, and the risk of infection was less, and the increase of his exudate, the MMPs, will be down due to the inflammatory response being down. So for me, it was really a bonus to use the nanocrystalline. Next slide, please. Okay. This was, as you see, 7 days later. I was also blown away. It looked very, very nice. His pain was down to about 4 out of 10. He had reduced inflammation. There was a lot of proliferation, a lot of epithelialization on his hand. His range of movement for his fingers. He is a dart. I'm trying to think of what, like a graphic designer. I'm technically challenged, so all these computer things. So he needed his hand. Part of his income is with his hand. So this was very important to him, and it was a great concern that it should be able to move and work as it did before. So this was one of the things that the nanocrystalline, bringing down the inflammation, was able to do, and risk of no infection was really great. Then I introduced him to a soft ball to try and get him back to his normal activities of daily living, because it was one of his main concerns. Next slide, please. As you see, his dressing, I did minimal. Basically on the interior of his hand that was already epithelialized and starting to mature, I literally used Vaseline in that area, petroleum. And then he was able to use his fingers and encouraged to bend and try to continue doing his normal duties and stuff at home. He found it quite difficult trying to dress himself, so that was one of his challenges, is trying to do his buttons on his shirt or trying to do the buttons on his pants, that to try and get his fine motor with his fingers. Next slide, please. This was his 3rd day assessment when he came through to us. He was pain-free. He had range of movement complete. He was independent, doing his normal activities of daily living. He was thrilled to pieces. I was thrilled to pieces, because it's only been literally 21 days and it's healed. And I was really, really impressed with that. Next slide, please. This is the patient's final wound that he sent me on the 5th of March. So basically within a month of having his hand burned, he was back to normal duties with his work. He was able to do his computer work. He was able to help himself at home. And I was very impressed with it. And for me, nanocrystalline is one of the things I really, really like to use on a patient with burns. The cost effective, next slide, please. The cost effective for me, initially, when you look at the cost of 4,953 Rand for his month of dressings, worked out to, if you did a daily dressing, of 235.88, which is truly, truly, truly cost effective for this patient. And literally, he only came once a week for a dressing. He was very cooperative. He also altered his diet, and he took in a lot of fluid, which obviously we needed, and he upped his proteins. And so I think the benefit was the patient also did a lot of work on himself and getting himself healed. So I'm very, very thrilled with this patient's outcome. Next slide, please. As you see, he was pain-free. It was a fast recovery back to his normal activities of daily living, and he had a recovered limb which he could utilize. And as we know, having COVID the previous year, everybody's looking after their jobs, so he could actually go back to normal day living, normal working, doing what he was doing best. Thanks. Next slide. Thanks.
Thank you so much, Michelle. The recovery really is incredible.
Yeah, it's phenomenal, phenomenal.
Really is, and this is the beauty of such a setting and a congress. You see that thanks to the correct medical care, victims can carry on living their lives, be part of society, and as you say, this particular individual could go back to their job, and importantly continue. Perhaps a quick, maybe rather naive question: have you applied the nanocrystalline to other victims or in other cases?
Yes, I actually use it quite a lot. It's my, I want to say, go-to for most of my burn patients. If they've been treated at an ER or they've been treated at the GP sometimes, and then they get referred to me, I really love nanocrystalline silver. It's the best. It's really stunning. Works so well on the patients. I know it's very expensive initially, but if you look at it in the long run, you know, when you say to someone, 235 Rand, if we did a daily dressing, it really, 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 it really worked well. Yes, I was very sparing with the nanocrystalline. Trust me, I was very sparing. We cut it in little slips, wrapped it around his little fingers. So we stretched it as far as it could go.
Just a quick question. Was your fee included in the 4,957
Yes.
of the nano silver dressing?
Yes, that was his whole cost. I actually, I went back into my accounting system. It was the whole cost was 4,957.
Incredible. Well done, and thank you again for a lovely presentation.
Thank you. Bye.
Thank you. Our next presentation is by Sister Anka Aisel with the presentation titled The Use of Party Balloons in a Burns Unit.
The use of party balloons in burns care, presented by Anka Aisel, registered nurse at the Life Cosmos Hospital Burns Unit in Witbank, Mpumalanga, South Africa. Burns care is complex. During the previous Burns Congress, one of the speakers said that burns care is like Marmite. Either you love it or you don't. I love Marmite and I also love burn care. And in our burns unit, we are always looking for ways to improve our care of our burn injury patients. Our goal is to help the patients heal as soon as possible and as well as possible, so that they can go back home to integrate into their family life as soon as they can. We put a lot of activities and a lot of actions and a large multidisciplinary team together to make this happen for our patients. In our unit, homely patient-centered care is in the middle of everything that we do. Rehabilitation starts at day one, and teamwork is so important. Clinical excellence is the glue that keeps all these circles together. Therapeutic actions and creative play is an integral part of our daily nursing activities. Quality care is a challenging goal for the team of a burns unit. In our unit, dressing changes are done on Tuesdays and Thursdays. So Friday, Saturday, Sunday, and Monday I usually refer to as eat, sleep, and heal days. Although physiotherapy and occupational therapy happens daily, long periods of inactivity happen between these dressing changes and therapy sessions, and boredom easily sets in for our burn patients. Lack of activity and movement are challenges that face young burn victims during their recovery. young patients that were running and playing the one day and became a burn victim the next day easily becomes bored when they start to heal. Many of our patients are referred from outside of town. A severe burn injury is sudden and traumatic. The parent or caregiver has to pack and prepare in a stressful, hurried situation to accompany the patient to our burns unit and to stay for an extended period of time. Often packing a toy is not a priority, and that favorite teddy bear or that toy car is left behind. Happy and active patients heal faster with less complications of bed rest. We identified the need to get our patients out of bed and onto their feet, and with little busy fingers that can do something during the day. They needed to be busy in the day so that they would sleep well at night. Creative play became an essential part of rehabilitation. Our team faced a challenge. How could the burns team assist with therapeutic activity and creative play within the limits of safety, infection control, and a non-existing budget for toys? The humble party balloon came to our rescue. The humble party balloon costs around 50 South African rand for a packet of 50. Balloons come in many colors, as many as you can imagine, and many shapes. And patients get to choose their favorite color of balloon. Maybe someday we can even learn how to make animal shapes out of the balloons. Each patient has their own balloons to play with as they please. And if we lose a balloon or two in the process, we just get another one. Balloons are disposable. For safety, the parent or caregiver gives constant supervision to prevent injury. A party balloon can be so much more than just a party balloon. And in our burns unit, we have discovered just that. If you inflate the party balloon, you can use it like a soccer ball. It's good for kicking and running. You can use it like a volleyball. It's good for throwing around, catching and lifting over your head. If you fill that party balloon with flour, it becomes a stress ball, good for squeezing and exercising the hands. If you fill that party balloon with water and make sure you tie it tightly, it becomes a weighted object, like a gym weight, good for lifting and strengthening muscles and hands and arms. If you take the party balloon and you give it a face, smiley face with nose and ears and eyes, it can become the imaginary friend. And if you use the party balloon as a party balloon, just for color and enjoyment and brightness in the hospital room. In our unit, party balloons has become part of our toolbox. Our toolbox full of things and activities and procedures that we use to help our patients heal faster. The common party balloon was found to be very useful in helping to provide care to our patients, as it is activity-inducing, versatile, disposable, colorful, and cheap. Thank you.
Thank you so much, Anka, for a really lovely presentation. I don't see any comments or questions as yet. Just waiting to see if any do come through. But I want to thank you once again for joining us and sharing your presentation on the use of party balloons in a burns unit. Our next presentation is by, thank you once again, Anka. Our next presentation is by Ms. Eleonora Lozano, and the presentation is entitled The Management and Rehabilitation of a Child Using a PPAM Aid Device.
Good afternoon, everyone. Can you hear me? My name is Eleonora, and I'm a physiotherapist from South Africa. Obviously, I'm currently working in the Red Cross War Memorial Children's Hospital in Cape Town, and I'm just going to talk to you today about the management and rehabilitation of a child using a PAM aid assistive device. I would like to take this opportunity to say thank you to the SABS committee for including this abstract and presentation. Obviously, we would have all loved to have the opportunity to see each other in person, but this virtual event's been amazing. Just a little comment about Red Cross. The burns unit admits 1,000 patients, children a year. And the patient I'd just like to talk about is patient M. She was admitted on the 10th of July, 2020 in the first wave of our COVID pandemic peak. She was an 11-year-old female who was involved in a shack fire. She was attempting to cook food for her and her sister. She sustained 45% flame burns and inhalation burns, which was a 55% injury. She sustained full thickness burns to both her legs, which were done, ischiotomies were done. She sustained deep partial thickness burns to her face, posterior trunk, buttocks, pelvis, and both of her upper limbs. She was ventilated and admitted to the ICU, and unfortunately, her 2-year-old sibling demised in the fire. She required bilateral lower limb amputations, and initially a guillotine below knee amputation was done, and the amputation was then revised to an above knee amp on the right and a through knee amp on the left-hand side. From the get-go, we needed a large team involvement, but more specifically social work involvement and lots of counseling. Prior to actually getting consent to the amputations, her father didn't want to do the consent, didn't want to do the amputations. There was a big period of denial, and they were also dealing with the burial and funeral arrangements of her sibling. So it took quite a lot of time for the family to process that and then just give the go-ahead for the amputations. As I said, from the get-go, a huge multidisciplinary team was involved, from the ICU team, orthopedic doctors, surgical team, the burns team, the pain team, and peds palliative care team, as well as the allies of physio, OT, dietitian, social work, psychology, and psychiatry. She required a colostomy, which was done, and she was discharged from the ICU on the 22nd of July. In total, during her burn stay, she required 13 surgeries, which I'll just touch on a little bit more. She was seen from day one in the ICU, where she was ventilated and sedated, and the main goals of therapy there were to maintain a clear chest, maintain range of movements by doing passive movements and positioning, and the occupational therapists were also seeing her, and they manufactured an intrinsic plus splint for her left hand. She was transferred to the burns unit on the 22nd of July, where at that stage she was awake and alert and on room air, and goals from that stage was also to continuously maintain a clear chest, range of movement through active exercises, passive movements, stretches, positioning, and then increasing her activity and her mobility. So those are just some of the images that we did through in a rehab process. And if I had to, just look at everything as an overall, her journey felt like one step forward, 2 steps back, especially every time she needed to have a surgical procedure. Towards the end of July, she required debridements and BTM application. So at that point, we were unable to do some active movements and passive stretches. So we just had to optimize her positioning and maintain her clear chest. From day 5, we were allowed to start active exercises again, sitting her over the bed, working on her transfers, her stretches, weight-bearing exercises, stump exercises, and encouraging as much independent ADLs as possible. She also developed Pseudomonas during her stay, which required daily dressing change. But finally, once that was all clear, she underwent meek skin grafting, and then a little bit later on, patch grafting towards the end of her stay. She, just to add on the occupational therapy in terms of their goals, also working on fine motor, ADLs. The teacher at Red Cross, as well as her own school teacher, would bring in some schoolwork. So that would also be done during her stay. And then just an overlap with working on transfers, her exercises, and then scar management. Then we were able to loan a PAM aid device, which is also known as a pneumatic post-amputation mobility aid device, from Groote Hospital, the physiotherapy department there. And they used the PAM aid devices for patients, amputation patients, more in the adult environment, because these, as you see, the PAM aids are quite big. They're not manufactured for children. But thankfully, our patient was able to fit into a small device. So you see the steel cage, which represents the legs, and then It's plastic, almost air balloons that get pumped up and they sit around the stumps. So we were able to get her out of the unit for the first time on the 19th of August, take her out in a wheelchair, and then work on her standing and facilitated walking through the parallel bars. And this is also just to show, we had quite a lot of sessions from that point on to getting her standing and working on her walking. One of the doctors that was working in the unit at the time is also a bit of a seamstress, and she helped our patient design her own dress as part of motivation. And this was actually the moment where she got to do a bit of a dress fitting. And also in the same breath, it was the first time seeing herself in the mirror. She was very reluctant at that stage, and it was very overwhelming for all of us to see her at that point. These are just other examples of, getting her walking without the parallel bars. So, progressing from her dynamic standing, walking, working on all of her balance, throwing the netball, which is something that she used to play. So that was a great motivator for us. And one of the big things that helped us with this case was her own strength and motivation and sass. And I was allowed to use this picture to, represent the diva that was in her with that part. And it was just one of those things that worked in her favor. Just with regards to everyone's had COVID-19 challenges, PPE was one of the big things. So our friendly, smiling faces were lost. So you had to smile through your eyes, as I'm sure most of you had to learn. And then lockdown restrictions. So every time we had the change in waves and whatnot, the hospital environment also changed. Our patient had her own challenges that she needed to deal with during this journey, and she did suffer with PTSD, especially with regards to losing her sister. For a very, very long time, we couldn't discuss her sister or bring up her sister, as she would break down and cry. But thankfully, towards the end of her stay, it became the motivating factor. Once she got walking, she said, she wants to be able to walk and go and visit her sister's grave and do that not from a wheelchair. She also didn't want to return to her home environment, despite that they didn't lose the shack and whatnot. That was also something that she needed to work through. And importantly for us, whenever we needed to do her passive stretches, it would replicate the sensation for her of being on fire. So we needed to just be mindful of this and work through it non-pharmacologically with breathing and pacing and obviously just medication. As I'd mentioned, she had a total of 13 surgical procedures up until her discharge point. And as I say, many ups and downs through this journey. One of which is not really a great milestone or celebration, but she celebrated her 13th birthday in the unit with us, and we were able to just throw her a little party. But she had made the request of, she wanted to give the nursing staff and children in the unit cupcakes and cakes, so we did that for her, as well as her own cake. And then on the 19th of November, she was transferred to Maitland Cottage, which is a step-down orthopedic facility associated with Red Cross, where she spent a month getting her rehab, and she was discharged just before Christmas. So she had a month's holiday and went back to Maitland at the beginning of the year, where she was fitted and received her prosthetic legs. So this is just part of the journey and process of her learning to walk with her legs again, both through the parallel bars as well as the walking aids, and then finally onto crutches. She has had her colostomy reversed, and she has gone back to school, and she is still attending our scar management clinic and PG clinics at Red Cross. The school that she's at has OT and physio, so they liaise with all of us if there's any problems, but she still comes to visit us and make sure that everything is okay. To say thank you to the Grooteskier team for obviously loaning us the PAMA device in turn for our patients' rehabilitation. To all the members who played a huge role in managing our patient, the C2 Burns team, our patient and her mom, and of course just the Burns Society for this opportunity to present my case. And thank you very much.
Thank you so much, Eleonora. A good outcome, and you certainly highlighted many challenges. Of course, the attitude of patients do play a part, but certainly your care and correct medical care certainly was influential in having a good outcome using this PAMA device. So well done to you and your team. Just a comment from Dr. Dos Passos indicating that he saw her last week and she now walks without crutches. Really incredible. Well done once again to all involved. Our next speaker is Ms. Sidi Mbonani, and the title of this presentation is Diabetic Foot Burns, a Foot Risk.
Good day, everyone. Thank you for joining me as I share my presentation on diabetic foot burns, a foot at risk. My name is Sidi Mbonani, and I'm a senior podiatrist at the Chris Hospital. As we get into what the topic is about, diabetes is a non-communicable disease that poses a big challenge for the health system. And it's not only in developing countries, but also developed countries into the challenge regarding the management of diabetes. But more so, the burden is seen on the financial side of the healthcare system. If we were to look at diabetes from an African perspective, according to the International Diabetic Federation, in the sub-Saharan of Africa, we find that there are about 19 million people that are between the ages of 20 and 79 that are actually diabetic. Now, it's estimated that by 2035 or 2045, the numbers will go up to about 47 million. Now, if we were to look at the prevalence of the undiagnosed, because that is where our problem is and where our challenge is, it is estimated that about 45 million people that are impaired in terms of glucose tolerance are actually not diagnosed. They don't even know that they're actually living with diabetes. And we know that undiagnosed diabetics are about 60% of adults who live with diabetes, but they don't know that they. It is also known that, or maybe communicated by literature and research, that 1 in 9 births according to the IDF, in the African region are affected by hyperglycemia due to pregnancy. Now, when we look at the financial burden of diabetes, we also find that $9.5 billion are spent in healthcare for diabetes. So we need to consider that in our efforts to treat diabetes, if the prevalences go up, therefore the complications also go up. We look at the deaths that are caused by diabetes that are much higher than those caused by cancer and AIDS combined. And when we look at the complications that come with diabetes, especially when we look at our feet, we find that non-traumatic amputations are done every 20 to 30 seconds globally. And only 60.2% of those amputations are actually account to diabetes. There is an increase in diabetes that may lead to an increase in the complications that might present. When we look at diabetic foot burns, it is a phenomenon or a problem that we see that it's increasing worldwide. Even in our institutions, we're seeing a bigger number of people coming through. And it is becoming more of a common occurrence. Unfortunately, because of late presentation of patients to our clinics, we find that by the time they present themselves, the wound has evolved so much that it doesn't actually look like a burn wound. And they can present as a non-complex or complex burn wound, and that is where the treatment then changes. These wounds present in most cases with a reduced sensate foot. So there's a reduction of sensation, and patients didn't know they were hurt, and they end up, because of lack of pain, they end up managing themselves at home, and then by the time they present to us, it's very difficult to treat the wound. Now, when we look at the pathology of how we get diabetic foot injuries, more specifically looking at when you're looking at your diabetic foot burns, we find that the key thing around the pathology is assessment. Now, assessment of this diabetic foot, it's more of an outward inward assessment. Now, it's not just of the foot, but it's also of the wound that we present. But when we look at the pathology, we look at three trifactors or three factors that contribute very highly when it comes to diabetic foot injuries that may lead to loss of sensation and may lead to having burn wounds. And we look at vascular supply, we look at neurological supply, we also look at the presence of infection. We find that the presence of infection does play a big role in terms of the decision that can be taken for an amputation to be done. However, we also find that the loss of sensation, which is the neuropathy that may present to the uncontrolled diabetes, plays a very, very big role because it actually then escalates the infection. And because the nervous system functions on soft tissue as well, once they are not functioning well, it affects how the vessels work, it affects how the muscles work, and therefore plays a role in certain things that might contribute to the progression of the wound. And the pathology of the diabetic foot complications may lead, and this is probably the end result that is not well received or is not a positive for the patient, is when they lead to amputation and death. And we find that when a patient has a wound already, or at times when we find that a patient dies because of a diabetic foot, we know that there are 2 or 3 other factors that have presented. And as you can see on my right side, where we have what we call the Wi-Fi, which is the current assessment of wounds in the management of a diabetic foot complication. From a podiatry perspective, we look at the wound, we look at the ischemia, we look at foot infection. And our assessment based on the pathology looks at how best can these 3 or the trifactors that contribute to diabetic foot amputation can work together or be managed in such a way that we have limb salvage. Peripheral neuropathy, as I have mentioned, it's a very serious complication, right? And the mechanism is not fully understood. However, it presents with a plethora of symptoms. It also presents with a plethora of other complications. Loss of sensation means a patient cannot sense when they've hurt themselves, when they've burned themselves, when they've stepped on something that is a danger to them. They don't even feel when there is friction that generates heat and that causes blistering or burn, other types of burn wounds. We find that because of loss of sensation, the injuries you can't explain how they started in some instances, but also they present with what we call neuropathic pain that cannot be explained, pain that has presented itself without having a cause for it. Now, when we look at how diabetic foot burns are caused, you'll find a diabetic who's had a corn and they want to use corn acid. Generally, that will be salicylic acid, and that's a caustic burn. And in other instances, things that we might take for granted, the use of hot water bottles, the use of heaters, the use of car air cons and heaters, those pose a challenge for them. We've had cases where patients have used hot water bottles have burst or they're too hot, and they actually get a burn from those. That is why if you can't feel it, then it becomes a problem. And if you're starting to have or if it's an initial stage of the presentation of peripheral neuropathy, as podiatrists take a stance where We do regular assessments to see if there's progression or not. We work as a team in a multidisciplinary approach where we work with the diabetes nurses, the diabetologist or the physician to make sure that the glucose levels are controlled, but also we work on the patient's knowledge. We educate the patient, we educate the family, right? We found that patients that have presented with peripheral neuropathy and they present with either burn wounds or any other wounds, because of the escalation of infection, it leads to lower limb amputations. And commonly coupled with vascular problems, and these would be peripheral arterial diseases or other vascular problems. But we know that because of the nerves not functioning as they should, patients find themselves with that other part of the trifecta that causes the problem. Osteomyelitis is one of the challenges that we are facing because we find that once these injuries happen, because the skin is so thin, it's close to bone, it sets in much faster. With the peripheral neuropathy, infection escalation is also quite, progresses quite fast. One of the common things that we also hear from patients is that I have never consulted a podiatrist. I've never had my feet assessed or checked so that we can determine the risk classification and how we classify them. We obviously have what we call a moderate and a high risk and no risk at all. No risk, we look at HbA1c, we look at glycemic control, we look at is there a nerve or neural system compromise or vascular compromise. If they do not present with any of those complications, then we know they are a no risk. However, when they start presenting with an initial or an onset of either one, which is the neuropathy or the peripheral vascular disease with no ulceration, you could say they are moving from a moderate to a high. The patient has had a diabetic foot ulcer, whether be it a burn or from any other cause. We consider them a high risk because recurrences of ulcers are very common in diabetic feet. So if you've had a diabetic foot ulcer as a patient, chances are it will reoccur again. Our main aim is to make sure that we monitor. However, while monitoring, we work at preventing further injuries, be it using insoles, with regular treatments, whether it be general podiatric care. We're looking at nail and skin infections, nail and skin problems. We also look at the basics where there is a change of the foot's morphology due to the neuropathy and how we can do a proper redistribution of pressure on the foot so that we don't have areas that have increased pressure. And those increased pressure further causes damage as they would cause pressure ulcers, neuropathic pressure ulcers. Now, what are the challenges that we are facing? We find that patients present at clinics very late. They get an injury, they get a burn. Once they have a burn, they sit at home. And I'm sure other clinicians have also heard this where patients use butter, they use toothpaste or any other home remedy so that they can treat their wounds. And the late presentation at times is not only by choice, it's also influenced by lack of services or no access to service or services that has to be accessed very far from them. And we find that patients present with that. Some patients do fear that they will get an amputation because they're diabetic and they have an injury, not understanding that by presenting themselves earlier, we could have actually saved that limb. Lack of knowledge plays also a very big role. Knowledge is empowerment for patients. And once a patient has no knowledge of what they have and what are the possibilities ahead, then a patient wouldn't make a decision that will benefit them. Yes, we do find patients who know what needs to be done and they do it, and they don't do what needs to be done. Patient adherence is also very important. And patient adherence is not just dependent on the patient. Now, as a clinician, my job is to empower the patient so that they understand and be part of the treatment, part of the assessment, part of the diagnosis, part of discussing what the management plan is, as we progress with the management plan, we encourage them to adhere to what is required of them. As clinicians, we play our part, but patients also have a responsibility of playing their part as well. I cannot stress enough the role that podiatrists play in the salvaging of limbs, but also in the prevention of amputations, more specifically non-traumatic amputations that are associated to diabetes. Prevention is better than cure, and we play our roles in different levels of care. The preventative, obviously the levels where we educate, we assess, and regular monitoring of a patient. When a problem presents at a secondary and tertiary level, where we also get involved in the management of such patients. But if we don't have access to podiatrists and patients don't have access to those services, therefore they do not get a full foot assessment, full education, and advice as to how to take care of themselves. These challenges, they obviously evolve depending on where the patient is, just as much as they might be similar. However, they do evolve as to where the patient is, depending on that. But also, it's a matter of, do people know what services are available to them? And some they do not know. So we also need to work hard to educate colleagues, educate patients, and also make sure that we play our role in the management of diabetic foot burns and diabetic foot complications. Now, we have made efforts, and as we continue to make efforts of assisting present us with burns, we find that beyond the challenges of access and beyond the challenges of adherence and knowledge, the other challenges is that burn wounds are generally very hard to treat and manage, and it's merely because of the area that is affected, which is the foot. We find that it's a tricky area to navigate around. The dressings that are generally in the market are quite big, and they don't necessarily accommodate the size of the foot, whether it's or not. We also find that in areas of increased pressure, which is on the plantar aspect of the foot, that is also one of the challenges that we have. So managing a diabetic foot burn, we have to find means and ways of making sure that moisture control is one of the key aspects of our wound care program. The area that we are treating, as you can see on the top left of the presentation, this gentleman had burn wounds from a hot water bottle, and it's bilateral, and the distribution also says it. In most burn wounds, especially if it's a heater or if it's a hot water bottle, the presentation of the wound itself tells you that it is a burn wound and what is the possible cause of the wound. And he's got his wounds on the plantar aspect, and it's ideal for him not to ambulate. However, it might be difficult, and this is where we introduce diabetic foot offloading boots or offloading shoes. This is where we also try and make sure that a patient is encouraged to elevate their feet and to rest, and also follow the plan so that they can get healing much quicker. If you can look at some of these routes, you'll realize that the foot might not have what we might consider to be a normal shape, but in most cases, when we talk to these patients, they would rather have a foot with a missing toe or missing two toes rather than not have a foot at all. And that is ideally what we are aiming at. We're aiming at saving the limb. And once the limb is saved, how best can we make sure the patient ambulates, the patient is active, the patient is able to do what they are able to do at home without having the hindrances of pain, the hindrances of discomfort as well. Now, in conclusion, when we look at diabetic foot burns, we know that the biggest contributor to such wounds is the loss of sensation, which is peripheral neuropathy. The pathology of peripheral neuropathy obviously goes hand in hand or correlates with glycemic control. It also correlates with the patient's ability to know what they're supposed to do at home. General podiatric advice that we would give is patients should always check their shoes at all times, avoid using do not actually use hot water bottles and heaters. Also, what we've also found is that patients that decide to walk barefoot at the beach, and to us is something that to some people it's actually quite something to take for granted, but for diabetics with peripheral neuropathy, it's quite dangerous. And we educate as much as we can, and we drive preventative approach of diabetic foot burns. However, once a patient presents with a wound, we look at multidisciplinary team approach, because we never work as an island, and we know that we need other expertise from other colleagues, where we're looking at glycemic control. We look also at is there a need for a surgeon? Can we save this liver or not? We also look at counseling. Counseling that we look at is social worker involvement, if there's a need for a psychologist to also be involved. We also look at how best can we allow this patient to gain from everyone else that is able to gain from. A holistic approach of patient-centered care that allows the patient to be part of the treatment, allows the patient to also make the decision and understand what the consequences of their choices helps us. I cannot reiterate the role that education plays in terms of preventative, but also as part of management. And we look at current advanced wound care and offloading modalities that assist us. We try our best to do as much as we can. However, we know with diabetes as a non-communicable disease that pose a huge challenge financially for the health system, a huge challenge financially for certain people that might lose their jobs because of they've had an amputation or they actually have the bone wound. So we look at how best can a patient's quality of life be improved through improved patient care, but also looking at experience, looking at evidence-based practice and best practice wound care that can allow this patient to obviously live their life fully. Now, it is important to remember that in most of life's greatest challenges are preceded by chaos. And our aim is in the chaos that we are sensing, we find ourselves in regarding diabetes, the management of the diabetic foot. We know that the changes will come through the chaos. So the chaos we accept in our grace, and we then follow through with making the changes that we can. I really hope that you have enjoyed the presentation, and thank you very much, and we'll have to follow up with the questions. Thank you.
Thank you so much, Ms. Sidine Bonani. We certainly did enjoy the presentation. As you say, educate, educate. Knowledge is indeed power, and also including and involving the patient is so critically important. Thank you once again. I don't see any specific questions from the audience at this stage. So I'd like to thank you and also invite you to please continue interacting with the audience in the chat box. Our final presentation for the day is by Dr. Ellen Rogers with the presentation entitled Quality Improvement in Burn Care, Indicators and Interventions.
Good day to you. My name is Alan Rogers. I'm a plastic surgeon at the Russ Tilly Burn Centre in Toronto. I'm going to be discussing quality improvement interventions in the field of burn care. Two questions that I pose are what are they and what are quality improvement interventions, and how do they differ from traditional research? And then secondly, how are we doing in the field of burns with publishing, with respect to publishing our QI interventions, and how can we improve? What is quality, first of all? Well, quality is the standard of outcome that we achieve with our patients. And there's 6 main or core criteria that we use to evaluate quality. These are efficacy, safety, access, patient-centeredness, equity, and efficiency. In the field of quality improvement, we can address one or all of those, or more than one of those, as we introduce an intervention at the patient level. Hospitals are complex. To achieve a change can often take a lot of time. What is true consistently is that those at the front line need to be engaged. They need to feel involved, and in order to make a difference, they need to actually buy into the intervention that you are suggesting occur. Better yet, they should come up with the intervention themselves. Quality improvement offers us the tools to understand the problem, to introduce a change, evaluate its efficacy and the impact of its change, and then to ensure sustainability of that change. In order for us to do that, we need to first understand the problem, and we do this using baseline data. How is traditional research different from quality improvement interventions? Well, they're actually 2 sides of the same coin. It's often true that quality improvement interventions are the best method of introducing a change that has been developed through traditional research methods. It is also true to say that traditional research may come up with generalizable knowledge, but that doesn't mean that that knowledge will trickle down to the patient in a meaningful way. And so using both techniques, both the intervention and the traditional research, one can ultimately get that intervention most effectively and sustainably to patients. They're different. Quality improvement uses a more flexible, adaptable approach that takes into account local factors, which are certainly not the case with traditional research. They usually occur over a shorter period of time, and they use different evidence-based methods. How are we doing in the field of burn care? Well, in order to answer this, we performed a systematic review. I did this with Drs. Wallace and Cartotto from our unit. And essentially what we came up with in this process were that 881 records were identified. We excluded those that were not related to burns or that were duplicates, and ultimately came up with 414. Of those, as many as 332 were actually qualified not as quality improvement at all, but rather as traditional research. And why that is, we will discuss a little bit further, but essentially most of them were used methods that were not in keeping with quality improvement. They may have been retrospective studies or prospective studies, and they didn't apply an intervention based on knowledge of the baseline data and didn't assess the effect of the intervention. Of 82 quality improvement intervention studies that we actually identified, only 20 were full text. The remainder, the other 62 were in fact abstracts from conferences. We came up with a novel 10-point scoring assessment tool, most important being that there was an intervention that was assessed in comparison with baseline data. You had to meet all 3 of those in order to classify as a QI. And the number of relative criteria were factors that were in keeping with quality improvement work rather than traditional research, and relates to the time of the intervention, that it was evidence-based, that Research Ethics Board approval was waived. And many of these came from the SQUIRE guidelines, which are sort of the gold standard method or scaffold for development of a QI study. So many of the studies that claimed to be quality improvement, as mentioned, were actually retrospective in nature. They identified change ideas, but actually didn't test them. When we look at the 20 full-text studies, many were in the burn journals. They related to patient care, factors or sort of themes like infection control, education, triage, and rehab. And unfortunately, only a third used QI methodology. The mean score was quite high, close to 8 out of 10, with 7 scoring 9 out of 10, actually. Looking at the abstract-only studies, those appeared to be good studies. They had scores as high as 7.4. They had slightly broader types of themes, including nursing education, patient safety, and pain management, as well as nutrition. Also, mainly in the burn journals and in the burn unit setting, with also fairly high scores, 7.5. And the reason we think they didn't translate into full text is possibly because the reception they received from journal editors, or potentially the methodology that they used. And so we came up with a number of components that we felt were important that can be read here. The emphasis perhaps more on methods in response to an aim, a smart aim, like a specific, measurable, achievable, realistic, and timely aim in context with reference to previous literature. And then doing some form of iterative change over time with reference to a family of measures. So looking at the process, how effectively that process was applied, and also perhaps looking at balancing measures. And then using QI methods to demonstrate the results effectively. And then in the discussion, looking at the results in context, particularly with reference to previous work, and in some ways proposing ways or methods that were applied to sustain the intervention. So looking overall, quality improvement gives us the tools to analyze a problem and introduce an intervention that can sustainably take hold. And this can be usually best achieved with stakeholder engagement. Most studies we found that claimed to be QI were in fact traditional research. And of those that were in fact quality improvement, only a fraction of these were full text studies. A lot of them never were converted into a full text study, and we looked at reasons for that. And then we're proposing that authors and investigators use the SQUIRE guidelines both as a scaffold for developing the QI study in the first place, but also in assisting them to generate the manuscript for publication. We felt that it will be journal editors will be more receptive if they do this. Thanks very much for the opportunity to present the work, and I look forward to any questions.
Thank you, Dr. Rogers. Really appreciate the presentation. Just a couple of comments to reiterate in the chat box. Congratulations, well done, outstanding work, and I concur with all of those comments. I think there's one quick question of what dressings did you use in the management of these cases? I'm not sure exactly who that was directed to. But overall, well done, and some outstanding work presented and shared here and today in general. I believe that brings us to the conclusion of today's presentations. It really has been a fantastic day. Thank you to everyone for attending the first day of the South African Burn Congress 2021. To all the speakers, it really has been fantastic, and we certainly have learned so much. I'd like to quickly bring back Dr. Anne Forster onto the stage to perhaps share some comments or reflections on today's presentations before I end off with some final announcements. Thank you, Dr. Anne.
Thank you, Ridwan. So that brings us to the conclusion of day one. And I want to just quickly thank Ridwan for pulling this program together and connecting all the dots for us. I think it's been an exceptional day, and I think we've seen so many interesting things, all the way from pre-hospital to ambulances, burn survivor stories, and then the most interesting things that people have been doing in burn care. And I think it kind of reiterates what Ethel said this morning, that what we're doing locally could actually be considered, global gold standards. And I want to thank the speakers, not just for their talks today, but also for what they're doing for our patients. I think everyone here, has a passion for burns, and I want to thank you for that. And then obviously to all the delegates who have joined us from far and wide, I hope you had a good day. I hope we didn't overstimulate you with too much information. But we hope you got some insights and maybe some new ideas that you could take forward. And then obviously always to Trade, who continues to support us. And thank you for taking part, showing us how your dressings work, how your products work, and continued support to the Burn Society and to our patients at the end of the day. So I think that's it from me. We thank you for this lovely day. I hope you guys have a wonderful Friday evening. Take a break, relax, digest today, and then we'll see you guys all tomorrow. Yeah, so over to you, Ridwan.
Thank you so much, Dr. Foster. I fully concur. Just three final announcements before we close today's session. If you are active on social media, I do encourage you to please share your comments, reflections on the day, and use the hashtag SABS Congress 2021. We'd certainly like to continue the conversations that have started today and also amplify the excellent work. So once again, on social media, the hashtag is SABS Congress 2021. Let's continue the really interesting conversations. Secondly, please do visit the virtual booths of the trade partners. They are all accessible from the main conference link. There are some prizes available to some lucky winners who visit all of the trade sponsors booths. And finally, in the chat box within the auditorium or main audience link, we still have the word cloud to please share your location where you're logging in from, and also please participate in the poll on your job designation. We'll try and bring that up tomorrow at some point during the second day of the Congress. I think that brings us to the end of day one of the South African Burn Society Congress 2021. Enjoy the rest of your Friday evening, and we look forward to seeing you bright and early tomorrow morning. Thank you.
Coat. Nanocrystalline silver-coated antimicrobial barrier dressing range. Acticoat barrier dressings demonstrate clinical efficacy in the treatment of infected wounds. At first glance, Acticoat dressings may appear to look similar to other silver barrier dressings, but deep within the structure we can see why Acticoat nanocrystalline technology is so unique. The deposition of silver impacts the efficacy of the dressing. The more silver that is available in a dressing, the more pathogens can be killed. When we look more closely, we can see there is a visible difference in the silver coverage of Acticoat dressings compared to other silver dressings. On an Acticoat substrate, there is a continuous coating of silver, compared to other silver barrier dressings that show a less dense deposition of silver. Nanocrystalline silver has a high surface area, so can achieve a sufficiently high Ag+ concentration to be rapidly bactericidal in the presence of wound fluids. The unique construction enables more silver to come into contact with the wound fluid. Within 30 minutes, positively charged silver ions come into contact with bacteria, disrupting the cell wall and cell membrane, denaturing the proteins and enzymes, preventing respiration and inhibiting DNA synthesis, resulting in cell death. The challenge with the use of low-dose silver dressings is that active silver binds to many components found in wound fluid,
such as RNA and DNA, chloride ions, devitalized tissue, proteins, and other organic material. This leaves little to no available Ag+ to kill bacteria. So it's important that the silver dressing delivers enough silver to sustain the Ag+ concentration needed to be bactericidal. A marked difference in the speed and extent of kill was observed. This example shows EMRSA. As the bacteria die, they turn red. You can see how quickly and effectively Acticoat starts to kill. Acticoat has broad-spectrum antimicrobial activity and is proven effective in vitro against a broad spectrum of gram-positive, gram-negative bacteria and fungal wound pathogens, including strains of MRSA. Acticoat makes a real difference to patients. It reduces bacterial burden, helps prevent progression of wound infection and wound invasion, leads to faster reduction of clinical signs of infection, has less risk of resistance, is proven to provide an efficient antimicrobial barrier. Acticoat barrier dressings come in various different formats, which all contain nanocrystalline silver. Flexible, absorbent, or conformable, each Acticoat variant is developed with properties specific to its required use. Acticoat broad-spectrum antimicrobial barrier dressings with unique nanocrystalline silver are proven to prevent and treat wound infection.
Somewhere beyond traditional thinking, beyond standard treatments, is a place that bridges where we've been to where we're driven to be. It's where innovation that saves and sustains lives meets the providers who make it happen. Where our ability to manage illness expands to reach patients with limited options. Where we address complications before they become life-threatening. Where we're not only treating diseases, but also discovering smarter ways to prevent them. This is our place, where we come together to write our greatest chapter as a visionary company operating at the center of global healthcare. This is the intersection of our boldest possibilities. This is the new Baxter.